நலம் தரும் நாயகனே, நவசக்தி விநாயகனே, என்றும் நலம் தரும் நாயகனே, நவசக்தி விநாயகனே, என்றும்
So a very good morning to everyone. On behalf of EST and Endocrine Society of Tamil Nadu and Pondicherry and the Indian Academy of Pediatrics Pondicherry chapter, a warm welcome to everyone gathered with us here today this morning for this annual Pediatric Endocrine Conference, Trendo. So let's begin the meeting with Tamil Thai Valthu.
தமிழனின் நாளும் தலை குனிவேனோ சூழ்ந்தின்பம் நல்கிடும் பைந்தமிழ் அன்னாய் தோன்றுடல் நீ உயிர் நான் மறப்பேனோ செந்தமிழே உயிரே நருந்தேனே செயலினை மூச்சினை உனக்களித்தேனே நைந்தாயனில் நைந்து போகுமென் வாழ்வு நன்னிலை உனக்கெனில் எனக்கும் தானே முந்தைய நாளினில் அறிவும் இல்லாது மொய்த்தனன் மனிதரா புதுப்புனல் மீது செந்தாமரை காடு பூத்தது போல செழித்த என் தமிழே ஒளியே வாழி செழித்த என் தமிழே ஒளியே வாழி செழித்த என் தமிழே ஒளியே வாழி.
Thank you. So next, lighting the Kuttuvilakku, I would like to invite upon Dr. S. Murthy, Dr. Ravichandran, Dr. P. Venkatraman, Dr. Soundarajan and Dr. Kumaravel sir. Dr. P. S. Soundarajan sir. Sundaraman sir.
நலம் தரும் நாயகனே நவசக்தி விநாயகனே என்றும் நலம் தரும் நாயகனே நவசக்தி விநாயகனே என்றும் நலம் தரும் நாயகனே வானம் அனைத்துக்கும் காரணனே நிலம் நீர் வெளி நெருப்பு வானம் அனைத்துக்கும் காரணனே என்றும் நலம் தரும் நாயகனே நவசக்தி விநாயகனே என்றும் நலம் தரும் நாயகனே. சதுர்த்தியில் உன் பிறப்பு அந்த அருமுகன் உனது உடன் பிறப்பு ஆவணி சதுர்த்தியில் உன் பிறப்பு அந்த அருமுகன் உனது உடன் பிறப்பு காவலை தருவது நின் பொறுப்பு நின் கழலடி தானே என் காப்பு காவலை தருவது நின் பொறுப்பு நின் கழலடி தானே என்.
Thank you. May I invite upon Dr. Kumaravel sir to deliver the inaugural address.
Good morning all. Respected senior doctors, the members of Endocrine Society of Tamil Nadu and Puducherry, the IAP members and my dear friends. It's a great privilege on behalf of ESTN to welcome you all to this pediatric Trendo update. So, Trendo, actually this Trendo is a remake of what Dr. Sundaraman and Dr. Venkatraman has done. And when you try to look at the age of this Trendo, I think Dr. Sundaraman sir has been doing this from the year 2000, if I am right. So it was done as speed endo, and from last year ESTN was given the privilege to conduct this speed endo. So we have slightly transformed this to a Pete Trendo, and last year being COVID, we had a virtual meet on Pete Trendo, and this is the first physical Pete Trendo meet. And hats off to Dr. Vijay Bhaskar Reddy and the whole organizing team of Puducherry for making it a grand success. And with this, we will get this meeting started, and thank you so much.
Now I would like to invite upon Dr. Ravi Chanda, IAP President, Pondicherry Chapter, to deliver the inaugural address.
Good morning, everybody. Warm welcome to Pondicherry on this pleasant Sunday morning. Respected office bearers of Endocrine Society of Tamil Nadu and Puducherry, distinguished members of IAP, the respected speakers who are very well known in their field for having come on this Sunday to this academic feast to enlighten us. I am very happy to see Professor Murthy, who was a professor when I was a UG student at MMC. It is nice seeing him again. It brings me back pleasant memories of my alma mater. Growth is a concern of every mother. Yesterday in my clinic, my receptionist brought her child, 15-year-old boy, for some minor consultation, some school issues. I told, Madam, your son is taller than you. She immediately said, no, sir, he has to grow taller. This is not enough. So, the growth is in the heart of every mother. So, and which is a very vast subject. But knowing the basics is important not only for academics, but for the practice and for the community. One child with hypothyroidism identified correctly in the newborn period is a great service to the society. Very humble service, which I know of one or two mothers who are coming me for the past 15 years because that boy was picked up in the neonatal period for thyroid. That even now they come once in a year, sir, how is my child? Is he okay? He has to take tablet, or you do want to test. So that is the vital importance of endocrinology. It is really happy that the Endocrine Society has chosen this venue and invited all of us and made the free registration for IAP members. I am very thankful to the Endocrine Society for this noble gesture. With this, I invite you all to this academic feast. Thank you, one and all.
Thank you, sir. So now we'll get the scientific program started. The first session is on growth, and to chair the session, I would like to invite Dr. S. Murthy, Director, Endocrine Diagnostic and Research Center, Diabetic Care Center, Chennai, and Dr. A. Ravichanda, President, IAP Pondicherry Chapter, to chair the session.
Can I have the brochure? The first session, as I alluded, is on growth. The first topic is 9-year-old girl shortest in class by Dr. Hemchand, Chennai. Next, followed by SGA child, role of growth hormone therapy, Dr. V. Kumaravel, Madurai, followed by the quiz on growth. I invite the first speaker to the dais.
Good morning, friends. Welcome to Pediatric Trendo. On behalf of all of you, I would like to thank Dr. Vijay Bhaskar Reddy and his team, Dr. D.B. Nayak, Dr. Jay Prakash Sahu, Dr. Satish, Dr. Vel Murugan, and others for their warm hospitality, excellent arrangements, and getting together this wonderful conference. The organizers have requested, because it's a tightly packed schedule and people have to also return back by 4 p.m., that we all stick to time. The two sessions are there. The first, as Dr. Ravichandran had mentioned, was on short test in class, how to approach, and the next one will be SGA child, role of growth hormone. Each talk will be for 20 minutes and 5 minutes discussion as well as question answers after each talk. That is what the organizers want. And after the two talks, you have a quiz for 10 minutes. And hopefully we should finish on time. It's 9:05, so by about 10:05 we should end the session. So now for the first talk, may I invite Dr. Hemchand, who is such a well-known international as well as national pediatric endocrinologist. He's a MBBS MD Pediatric Fellowship in Pediatric Endocrinology, Senior Consultant and Head of Department of Pediatric Endocrinology, Mehta Hospital, Chennai. Numerous achievements, awards, recognition, including the IAP textbook Pediatric Endocrinology. He's the co-editor. Many publications in peer-reviewed journals. May I now request Dr. Hemchand Prasad for his talk.
Good morning, everybody. Over the next 20 minutes, we'll have an overview of short stature. So why have I put this slide in this scientific session? We'll see as we go through the presentation. So the theme of this talk is a 9-year-old girl with short stature. The flow of this presentation, we'll first have about 10 general rules of how a pediatrician should approach a short child, and subsequently we'll apply these 10 rules onto 5 cases. First important thing, Indian Academy of Pediatrics way back in 2007 came up with this very beautiful growth monitoring guidelines, which emphasize that length should be measured in every vaccination visit in the first 2 years of life. Subsequently, every 6 months, every pediatrician should measure height, and subsequently annually. SMR should be measured annually every year. This is very important. This is a standard guideline from the Indian Academy of Pediatrics way back in 2007. What charts to use? The Indian Academy of Pediatrics has again given a very simple answer, less than 5 years. Please use the IAP simplified WHO charts, which give on a single page the measurement for length, head circumference, weight, and if you flip it backward, you get the charts for weight for height. So these are the charts recommended for children less than 5 years. And for children above 5 years, these are the new pediatrician-friendly charts that are recommended for use. These charts represent the WHO charts at birth and in the first 5 years of life, and the IAP 2015 charts subsequently, for which I think a lot of ESTN members have contributed, given immense contribution to the development of these charts. So 2 additional tools in the new pediatrician-friendly charts. One is the BMI lookup tool, and second is the mid-parental height calculator. I'm really very proud to tell that probably in the whole world, our charts are probably the only charts of the Indian Academy of Pediatrics where no calculation is needed. No need to calculate BMI, no need to calculate mid-parental height, please plot. I think Indian Academy of Pediatrics has made it so simple and given us such a beautiful chart. Just plot it and interpret it. How do you plot it? When you see the child, see the point of intersection of the age on the x-axis and the measure on the y-axis, and use a dot to mark the measurement. The same measurement has to be done for weight for height. On the older chart, again at the point of intersection of the age on the x-axis and the age on the x-axis and the measure on the y-axis, a dot has to be placed as shown in this particular slide. The plotting is done at 3 monthly intervals in the first weight and height charts and on accurate months on the BMI charts. So this is some of our studies which show that these charts are very useful in Indian children. I think the first important learning pearl commandment a pediatrician should follow is please follow the IAP 2007 guidelines which are valid even in 2022 for growth monitoring. Please measure length, please measure height at appropriate ages. In the first 5 years, please plot them on the IAP modified WHO charts and subsequently on the pediatrician friendly growth charts. What to use? Percentiles or Z-scores. This is a 9-year-old child with a height of 117.5, which is at the 3rd percentile on the growth chart as well as -2 STs. What should we use? When you say that the child's height is at the 3rd percentile, it just denotes a rank. It just says that 3% of the Indian children are shorter than this girl. That's all it says. Whereas if you see a Z-score, it says that this child is 2 standard deviations away from the average. So both of them tell the same thing. If you say the distance between Chennai to Pondicherry is 120 kilometers, and if you say it is 75 miles, both of it is the same. Similarly, 3rd percentile and -2 STs represent the same understanding of the child's growth. Where is the child in the perspective of the Indian population? So when you say that the child is at the 3rd percentile, it means that 97% of the Indian girls are taller than her and 3% are shorter than her. If you say if it's -2 SDs, it is 2 standard deviations away on the negative side. Both Z-scores and percentiles are interconvertible, and Indian Academy of Pediatrics says for all practical purposes, percentiles are preferred in routine clinical practice. So we understood that we have to use the IAP charts, and we understood that percentiles should be used. Next, how do we plot and how to identify short stature? Any height below the 3rd percentile as shown in this slide is considered as short stature. Whenever you have a height that is 2 percentiles below the target height, for example, this child has the target height at the 90th percentile and you have the child's height at the 10th percentile. 2 major percentile lines below the target height is considered short stature. And the third definition of short stature is growth velocity below the 25th percentile. So these are the Indian growth velocity charts, and if you have 2 serial measurements, calculate growth velocity, and if you find the growth velocity is below the 25th percentile, it is short stature. So the definition of short stature is if the height is below the 3rd percentile, height is 2 percentiles below the target height, and growth velocity is below the 25th percentile. Coming to the 4th commandment. How do you calculate target height? All of us know very well the target height is calculated as father's height plus mother's height plus or minus 13 on the basis of the sex of the child. The Indian Academy of Pediatrics has come up with this new mid-parental height calculator. All you need to do is mark the father's height, mark the mother's height, and join the two. That denotes the target height percentile. It has made our work very, very, very simplified and easy. This girl has height at the 10th percentile. Target height is assessed to be at the 10th percentile without doing any calculation. So child's target height percentile and the child's height percentile are matching, so don't need to worry. So for a message for the pediatrician is please use the target height calculator and interpret the child's height in the perspective of the parent's height. Another important normal variant of growth is constitutional delay. Late bloomers as shown in this slide. The child is born normally, slowly deviates to the 3rd percentile, grows normally along the 3rd percentile, but does not bloom when other children are blooming. The child has a delayed bone age, and ultimately if you see by around 14 to 15 years, the child enters into puberty, catches up and reaches a normal height, a slow bloomer. This is another important normal variant of short stature which is identified on serial growth monitoring. The message from these two cases is that if you find that the child has height below the third percentile, please interpret the height in the perspective of the target height, and don't forget that the child may have constitutional delay. Right. Constitutional delay and familial short stature are two important normal variants which pediatricians should be aware of to understand short stature in a given child. This is the fifth commandment. Coming to the sixth commandment. What are the clues that the growth chart can give in terms of identification of a pathological cause for short stature? Whenever you have a child just below the third percentile, it is most likely a normal variant. Not always, most likely a normal variant. Maybe familial short stature, maybe constitutional delay, maybe a sequelae of low birth weight, maybe nutritional deprivation. But you find the child is significantly derived away from the third percentile. As shown in the red curve, you know that this child most probably has an endocrinopathy, may have a skeletal dysplasia, may have a syndromic state. So the first clue from the growth chart which points to a pathological state is the position in the perspective of the third percentile. The more the child is deviant from normal growth, more likely you are going to find a pathological cause. The second important clue which the growth chart can provide is the relative affection of height and weight. Whenever you have a child who has significant affection of height more than weight, you are looking at a child with a pathological cause of short stature. Whenever you have a child with weight affected more than the height, then the conventional teaching is this child could have a nutritional or a systemic disease that is contributing to poor growth rather than an underlying endocrinopathy. So the second clue is the relative affection of height much more than weight as a possible clue to an underlying endocrine disorder. And last important clue is the relative sparing of the weight in terms of the sparing of the weight. Whenever you have, this is the novel BMI lookup tool, no need, especially in children above 8 years, there is no need to calculate BMI, just plot it at the point of intersection of the weight on the y-axis and height on the x-axis. Whenever you have the height, weight for height preserved, you are going more in terms of a pathological cause for stunting, whereas whenever you have poor weight, you are looking in terms of a normal variant. And lastly, whenever you have a rapid crossing of percentiles, like the rabbit previously was on the 25th percentile, over a span of 1 year has jumped below the third percentile, the child is losing the race, has a pathological cause. A slow tracking of percentiles, as seen in this particular slide, is growing slowly like a tortoise. You might as well reassure and follow up this child slowly and clinically in your setup. So the important message is, what are the important clues a growth chart would provide for a pathological cause for short stature? Number 1, sparing of weight. Number 2, rapid crossing of percentiles. Number 3, significant discrepancy from the third percentile. More away, more likely you are going to find a pathological cause. So this is the 6th commandment as far as short stature is concerned. All of us as pediatricians are aware of this ICP model of growth, where growth is divided into infancy phase, childhood phase, and puberty phase. Now there is a new added concept of growth at birth determined by maternal nutrition and in utero environment. And the new pediatrician friendly growth chart very beautifully depicts the ICP model. Growth in the infancy is assessed on terms of good nutrition and health care on the WHO charts. Growth during childhood and puberty is controlled by growth hormone and thyroid hormone during the childhood phase and by sex hormone during the puberty phase. Growth at birth is a reflection of the maternal nutrition and the intrauterine environment. So what is the corollary of this? Whenever you find growth faltering that occurs at birth, think in terms whether it's an SGA, whether the child has a skeletal disorder. Whether you find the growth faltering occurring during the infancy phase, think in terms of poor nutrition as a cause for growth faltering. Whenever you find growth faltering occurring during the childhood phase, growth hormone may be the culprit. And whenever you find the growth faltering occurring during the puberty phase, hypogonadism may be the responsible factor. So important clue on the timing of growth faltering that gives a clue to the pediatrician to do a proper evaluation. So, I think this pointer is running faster than me. So, but remember, there are two important caveats to this. Any short child, irrespective of the phase, a thyroid profile is mandatory. Hypothyroidism can present during infancy as growth faltering, can present during childhood as growth faltering, and during puberty also as delayed puberty and growth faltering. Similarly, Turner syndrome can present as growth faltering in any of the 3 phases. So irrespective of the phenotypic features, please do a chromosomal analysis in every short child. So the next important clue is the ICP model. Every pediatrician should keep in mind the age of onset will give a valuable clue to the pediatrician to the underlying cause for growth faltering. Hypothyroidism and chromosomal testing is very important in every girl child and hypothyroidism in every short child. Now, whenever you find a child who is growing poorly, you look for the cause for poor growth, like a car that is going slowly. So the cause may be innumerable. It may be because of an underlying systemic disease that is not allowing the child to grow. It may be because of a defect that the child was born with, SGA baby who is failing to catch up. It may be because of defective bones. It may be because of a skeletal disorder or rickets. It may be because of a syndromic state like Down syndrome, Noonan syndrome or Prader-Willi syndrome, or it may be because of poor caloric intake like nutritional deprivation. When all these causes have been ruled out, think in terms of endocrine cause for stunting like growth hormone deficiency. So the next commandment is a proper history. Understand that these are the various etiologies of short stature and a specific focused history and a specific focused examination to measure the proportions. These are the Indian proportion charts which can be used, and any proportion below the 3rd percentile or above the 97th percentile should be a pointer to a just close this PowerPoint. No, this is not the other one. Other PowerPoint. You close this PowerPoint. So it's very important, yes, to measure proportions, plot it on the Indian proportion charts and identify disproportionate short stature. So of course, these are the important clues in terms of history. You have the onset of hypoglycemia in the neonatal period. Any textbook of pediatrics would tell you what are the histories and what are the clues. So a focused history and a focused examination in terms of looking for clues for underlying abnormalities like presence of single central incisor, presence of elevated blood pressure for chronic kidney disease, presence of striae for Cushing syndrome, extremities for features of hypothyroidism, rickets, Prader-Willi syndrome, features of undescended testes, micropenis for growth hormone deficiency, etc. Every pediatrician should look up every child, short child, with an eagle's eye to pick up important clues and rationalize the investigation. So the important message is you should look at the timing of stunting and also the physical features and history to take to give a proper direction in terms of evaluating the short child. So the next important clue. So this is a child, a 9-year-old girl who presents with short stature. The growth chart is reassuring. You find that this child is at the 3rd percentile, appropriate for the family. You are happy. But unfortunately, what has happened is this child has entered into menarche. Her bone age is 14 and she has completed her growth at 9 years. This is a child who was seen at 18 years, looked as if he has completed his growth, but evaluation showed he was just Tanner stage 1 and bone age was 10 years, indicating that this child has a potential to grow even though he is chronologically 18 years of age. So the message from these 2 slides is that bone age and sexual maturity are important clues for the implications for the growth potential. How much growth is left for a given child? You see a 9-year-old child with advanced Tanner, be very careful. You see a 9-year-old child with prepubertal, go a little slow. So bone age and sexual maturity are important clues for the residual growth potential. So pediatrician who finds that the growth potential may be compromised, be very careful. You are walking on a tightrope. You find that the growth potential is immense, go slow in terms of evaluating. You might as well follow up. And the last important clue, commandment is, look at the charts recommended by the Indian Academy of Pediatrics. These are all the girls' charts, BMI lookup tool, the BMI, the weight for height, the growth velocity. What is really striking and common in all these charts is every chart has a red line and almost every chart has a yellow line. So the message is Indian Academy of Pediatrics wants all of us to explain what this chart means to the parent and take her into partnership and evaluate this child further. For example, if you have a child whose height is below if you see this child, This child is faltering in terms of growth. At 9 years, she is below the third percentile, but at 6 years, she is above the third percentile. So at 6 years, she was above the red line pass mark. Now she is below the red line fail mark. I think this would be a simple way to convince the parent for a proper evaluation. If you have to really look in terms of understanding, tell the parent your child was previously at the 50th percentile. 50% of the Indian girls were shorter than your child, but today the child is at below the third percentile. Only 3% of the girls are shorter than your child. This sort of clear understanding that is presented to the family will definitely make them more cooperative for whatever evaluation you're trying to suggest to them. So these are the 10 important commandments for growth which I thought one should keep in mind in terms of looking into a short child. Please follow the guideline from the Indian Academy of Pediatrics and plot them. Recognize short stature. Percentiles should be used. Height below the third percentile is useful to help identify short stature. The mid-parental height calculator is a very useful tool. Remember normal variance. Look for valuable clues from the growth chart to pick up pathological stunting. ICP model, proper history, focused examination, pivotal. Bone age and SMR tells you how aggressive you should be. And lastly, take the parent as a partner and involve her in your decision-making process. So let us apply this into some cases. So this is a child who was seen at 9-year-old for short stature. Look at the position of the child. Child is just below the third percentile. This child may have a normal variant, short stature. Look at the next clue with the mother is the growth chart is giving. The child target height. The target height is below the third percentile, calculated on the mid-parental height centile. So what is happening? This child, even though is short for the population, is normal for the family. Previous growth recordings showed that this child is tracking along the same percentile. So I think the message from this case is, please remember the 10 commandments. Whenever you have a child's height just below the third percentile, in the appropriate range for the family, and the weight is relatively preserved, and also child is tracking centiles, you are looking at a child with normal variant short stature, probably familial short stature in this child. This next child is a child who is short, but look at the position of this child. The height is very significantly away from the family, from the third percentile, and it's also short for the family. Very short for the population, very short for the family. What other clue this growth chart is telling you? Deceleration of percentiles. This child was previously above the third percentile at 5 years. Now it has dipped below the third percentile, as you can see on this chart. So remember the ICP model. Whenever you have growth faltering occurring during childhood, you have to think in terms of growth hormone deficiency as a likely cause. This child was evaluated further. The weight was preserved, again indicating that this child has a pathological cause for short stature. So this child has craniopharyngioma, growth hormone deficiency, as a cause for poor growth. So the diagnosis is made on the growth chart. The previous chart gave you a simple clue that it was familial short stature the pediatrician had to follow, but this chart, the parent is alerted to a very grave condition like craniopharyngioma just on the basis of this growth chart. You save the life of the child by growth monitoring. This is a child with short stature, very significantly away from the third percentile, very short for the family. Serial monitoring shows that the defect is there not during childhood, but right from infancy. The culprit is not C of the ICP model, but I of the ICP model. So this child was looked into more carefully. Upper segment, lower segment ratio was abnormal, and a diagnosis of achondroplasia was made. A proper understanding of the growth chart and the pattern of growth helping. Doing unnecessary testing like IGF, MRA, etc. is futile in this child when the diagnosis is simple skeletal dysplasia. Next. This is a child, a known case of type 1 diabetes. This child presents to you with short stature. This child is just short for the family, more affection of weight. Remember the important commandment. Whenever you have affection of weight more than height, you're looking in terms of a systemic disease. This child was evaluated and the diagnosis of celiac disease was made in this child. And the last case, this is a child who presented to us with short stature. But look at this child. Look at, these are two girls who come on the same day. Both of them are just short for the population. They are just short for the family. Look like normal variant. But look at this. This child had a delayed bone age. The other child had an advanced bone age. And this child had compromised growth potential. The advanced bone age, the advanced sexual maturity tells that this child is running like a rabbit and losing the growth potential. This child has a delayed bone age. It is still pre-pubertal. This child is growing like a tortoise. Be slow as far as this child is concerned. So the message to the pediatrician, growth chart is very important, but Tanner stage and bone age kind of complement the assessment of growth in every short child. So I'm almost done with the presentation. So just some miscellaneous points. All short stature is not GH deficiency. Growth promotion can be done only till 14 years in girls and 16 years in boys. In our state, free growth hormone therapy is available in many government institutions. Short stature may help you pick up a grave disease like craniopharyngioma, individualize your investigations, and take the help of extended growth charts. These are the extended growth charts where you have additional percentile lines for specialized settings. So let us go on to the take-home messages. So whenever you have a 9-year-old girl who is growing poorly, it's like a car who is going slowly. So a 9-year-old girl who goes slowly, always use the pediatrician-friendly growth charts. Identify the children who are faltering. If the child's height is below the 3rd percentile, 2 percentiles below the target centile, or growth velocity below the 25th centile, this child has short stature. Look for important clues. If the height is in the target range, normal growth velocity, it may be normal variance. It's like a speedometer. Look at why the car is moving slowly. Does the child have a systemic disease? Does the child have a deficit like SGA? Does the child have abnormal proportions like skeletal disorders or rickets? Does the child have features of syndrome? Is the child fed properly? Ask yourself those questions. If all those are satisfied, never forget to do a thyroid profile and a chromosomal testing to miss these conditions, irrespective of the phenotypic features. And lastly, look into the growth chart very carefully. A child's height significantly away from the 3rd percentile with preserved weight and rapid catch down of percentiles is an important clue to an underlying endocrine abnormality. I think that would be a simple summary of an approach to a 9-year-old child with short stature. Thank you very much.
Thank you very much, Dr. Hemchand, for that very elegant presentation. Very practical. You gave us 10 commandments. You actually played around with the growth charts. And you also proved how just with simple growth charts, without complicated investigation, you could definitely come to a reasonable diagnosis, and probably a couple of confirmation tests may require. I have 2 questions for you. The first is nutritional deficiency. Macronutrient deficiency, yes, common, and there are some clinical findings which suggest. But you can have a micronutrient deficiency presenting only with growth failure. Now, how do you handle them?
Definitely, I think that's a very important cause for growth faltering in our setting. Deficiency, relatively poor intake of micronutrients that present as relative growth faltering and failure to thrive. I think physical examination, identification of the nutritional deficiency, supplementation, and reassessment of growth after a while of maybe 6 months or 1 year to see if there is catch-up of growth that occurs. If the child moves towards a normalcy, moves towards the median in terms of height and weight, you know that that is the culprit. You would probably reinforce that the child gets the recommended daily allowance of that particular micronutrient and follow up this child on serial growth monitoring.
Second is you want to rule out growth hormone deficiency. What would be your choice of screening test? Growth hormone dynamics, IGF-1, IGF-BP3.
See, I think this has to be individualized for every particular child. I think skeletal maturity is a very important, valuable clue in terms of underlying cause growth hormone deficiency, complemented by the IGF-1 as a screening tool for the measurement for the growth hormone deficiency.
Thank you, sir. Anything for you? Any question from the audience? 1 or 2 questions.
Thank you very much. Thank you. And I reinforce, please use a pediatrician-friendly growth charts, the only charts in the world without any calculation. Thank you.
Thank you so much, Dr. Hemchand, for that excellent presentation. You have made an excellent beginning for the conference. second talk, and that's by Dr. Kumaravel, MD DME Endocrinology, Director Institute of Diabetes and Endocrinology, Alpha Hospital Research Center, Madurai. He is the President of the Endocrine Society of Tamil Nadu and Puducherry, awarded Honorary Professor IMA CGP. He has contributed also to Growth Chart IAP, multiple publication in peer-reviewed journals. And he's going to talk on SGA child, role of growth hormone therapy. Over to you, Dr. Kumaravel.
Good morning, my dear friends, respected chairperson, co-speakers. I think Dr. Hemchand has made my job simple. He has described in detail regarding the growth chart. My topic is more focused on SGA child and the role of growth hormone therapy. So this would be the overview of my talk. I would try to discuss on epidemiology, basics of SGA and why a SGA child could have a short stature, how exactly do you diagnose, and the management and the role of growth hormone in child who are born SGA, some case scenarios, and then a summary and a take-home message. So the global prevalence of small for gestational age, I think the global prevalence is very high, and data from 2010 which showed that even in Indians roughly around the prevalence of SGA was 46.9%, which included both preterm SGAs and those child with term SGAs. And the cause for small for gestational could be multitude, and SGA is basically defined as either your birth length or your weight or both, which could be more than 2 standard deviations or less than below 3rd percentile. And the cause for SGA could be multitude, starting from maternal factors or your maternal family history, or it could be a paternal factors. It could be a father, could be short father born of SGA. And more importantly, various pregnancy related components could affect a child's growth and which could lead to a child with small for gestational age. I'm not going to the details for causes for gestational age because that is not the real scope of my talk today. So let me try to discuss why is that I am concerned with this SGA child. So the SGA child can have a short-term consequences and a long-term consequences. And short-term consequences could be something like hypoglycemia, thermoregulatory difficulties, symptomological defects are difficult to adapt to after the delivery. But the long-term consequences which I am more concerned as an endocrinologist is this growth-related complications with this SGA, especially short stature, and it could have various other systemic related problems also. And the reason why the SGA child could have a problem in growth could be, unless you understand your fetal growth hormone physiology, it is very, very difficult for us to understand. So I'll just have a couple of lines about the fetal growth hormone physiology. We know this growth restricted fetus tends to hypersecrete growth hormone. The reason is very simple. Whenever there is a growth restricted, it is a kind of growth hormone resistant state. So these child could have the endocrine milieu in fetus and growth restriction could be they can have a varied circulating IGF-1, IGF-2 levels, and then this in turn leads to a feedback problem. So ultimately this negative feedback of exerted by low IGF-1 leads to a high growth hormone in the fetal menu. Now what happens once when this SGA child is born, because of this high growth hormone, many of these child could have a catch-up growth after birth. So basically the intense activity of the somatotrophic axis is thought to be the reason for the catch-up growth in this child. So the spontaneous postnatal catch-up growth usually occurs before 2 years or maximum within 2 to 4 years, not more than that. So the child born to have SGA have a higher risk for short stature than to those child which is born for appropriate for gestational age. And again 90% of catch-up occurs during the first 2 years of age, and many catch up by 4 years. If there's no catch up beyond 4 years, I think these are the child we should be really concerned. And children born SGA who do not catch up in height, they account for 10% of all short statures. And this holds good for preterm SGA infants. They have a better catch up than a full-term SGA infants. I think full-term SGA we should be more cautious. Again, infants with birth weights below 1.5 gram and between 1.5 to 2.5 gram, they show a better catch-up growth than those children who are born as a birth weight more than 2,500. So which means the concern here is the full-term SGA and SGA with weight more than 2.5 grams could have a concern with a problem in catch-up growth. So SGA children without catch-up growth, so that is our area of concern here. So as I said before, approximately 10% of children who are born SGA will remain short at 2 years of age, and even after 4 years, 10% could continue to become short. And the mechanism underlying a postnatal growth failure in these children is poorly understood. One, it could be an irreversible defect in the cell number because of the altered intrauterine milieu, or it could be a something related to abnormal environmental condition that has caused IUGR for these infants, or it could be altered programming. Classic growth hormone deficiency is rarely found in these children with SGA. So now adult height of child born for small for gestational age, this is the data with men and women. So the adult height in those patients who are born SGA compared to AGA is roughly around 6 centimeter less, which the child is destined to have. I think the 6 centimeter could be a major impact for most of our children, because as rightly said by our pediatric professor, he said even every child wants to keep on growing. So I think this child is destined to grow more, and we have missed the opportunity of the growth of 6 centimeters which the child is destined to have. So the adult height is less for SGA children. So how exactly do you diagnose these children with small for gestational age? The diagnosis, the first step is identification of the children born SGA. So you should know the gestational age of the mother. Accurate measurement of the birth weight and length is very important, and you should know the cutoff against the reference data for most of this individual. So the important point to remember here, it's appropriate anthropometric measurement at birth is very, very critical. I'm sure at birth, many of us measure the weight, but very few of us measure the length of the child at birth. I think as a neonatologist, a pediatrician, even a birth length has to be measured appropriately, and it has to be documented. The second step in the diagnosis of child who is born with SGA is to look at the catch-up growth. So these child should be plotted in the growth chart, and catch-up growth has to be seen whether these cells are growing normally at par. And when there is no evidence of ongoing catch-up growth, always exclude other causes of short stature before branding them as a child with SGA with short stature. So now how do you interpret catch-up growth in your growth chart? So another easiest thing in the growth chart is any growth chart which is in the pink color is for the female, any growth chart which is in blue color is for the boys. Because when you're busy clinical practice, sometimes you plot the height in a different growth chart, you may falsely diagnose short stature or normal stature. So how do you interpret? So this is a child, you can see here, you have a height which is less than 3rd percentile. By 4 years, there's a catch-up growth. The dot which is below the red line just crosses above the red line. So this is a child with SGA which had a normal catch-up growth. Similarly, you can have another scenario like this is a child again born with small for gestational age. You can see the height is less than the 3rd percentile. As the child grows 4 years, there's no catch-up growth. So this child would definitely require evaluation and intervention. So the height less than 3rd percentile even at 4 years of age should definitely be evaluated. So this is a SGA born child without catch-up growth compared to the graph which I have shown in the previous slide. So these child would respond better to growth hormone therapy to reach the optimal height. So the monitoring of growth in a child born with SGA, I am sure Hemchand has discussed in his slide also, early evaluation of short children is recommended. You evaluate every 3 months for the first year, then every 6 months these child has to be evaluated till they reach the catch-up growth, then you can go for the routine evaluation what these childs are destined to be. So regular growth monitoring with growth chart plotting and clinical assessment is critical in every patient. So next we'll move on to the management. What is the role of growth hormone in those patients with small for gestational age? So growth hormone treatment is a recognized therapy for children who are born SGA who fail to achieve your catch-up growth. And the effective doses of growth hormone are higher with those children with SGA than those with growth hormone deficiency, suggesting SGA child could have a growth hormone or insulin-like factor resistance in this individual. And the efficacy of growth hormone treatment for short SGA children has been demonstrated in various randomized control and various multicenter clinical trials, and here even we have a various real-world experience to suggest these growth hormone works in children with SGA. And growth hormone therapy has been approved and recommended by FDA and also by the European Agency for the Medicinal Product in 2001 and 2003 respectively for those children with small for gestational age. So the objectives and benefits of growth hormone therapy in those children with small for gestational age is very obvious, is to accelerate the linear growth in early childhood, to achieve a rapid catch-up growth, to maintain a normal growth later in childhood, but the ultimate objective of treatment is to achieve a height within the normal target range which the child is destined. Apart from that, growth hormone can have other pleomorphic effects like increasing a bone mineral density, which could have an impact on cardiovascular function. It reduces the total and visceral fat and increases your lean body mass. It improves your quality of life. And being anabolic, it has shown some data on memory, alertness and concentration, but that is not the primary indication for giving growth hormone these children. So dosing and monitoring, as I said before, the child who requires growth hormone for SGA, usually the dose is higher, and the growth hormone dose is roughly around 0.033 to 0.067 milligram per kilogram body per day, and maintain IGF-1 levels in the upper one half of the normal range. And during growth hormone therapy, the following parameters should be considered or monitored. You look for the fasting glucose, you look for the lipids, you look for the insulin levels, IGF-1 levels, and always try to maintain the IGF-1 at the upper half of your normal range. So this treatment can be continued as long as the bones are open, and again they can be continued as long as the growth velocity is preserved. So usually treatment is continued as long as there is an accelerated growth phase. So you stop during the puberty, or when your growth velocity falls to less than 2 to 2.5 centimeters per year during the late puberty, you can stop growth hormone in these individuals. So effects of growth hormone therapy, the height during childhood, you can see the growth hormone therapy effectively normalizes height both in male and female. So this circles, open circles are those prior with growth hormone treatment, and once when you start these children with growth hormone, you can see the closed circle, there's a crossing of percentile. So that's again Hemchand has reinforced your growth chart, crossing of percentile. It suggests probably with treatment, whenever the crossing of percentile happens above, it suggests these child have a very, very good response to your growth hormone. And the growth response with growth therapy, again, normalization of adult height depends on the duration of therapy and the age at start of therapy. So here you can see the initially at the first year with various doses of growth hormone, the initial height standard deviation score is -3, and then with 6 years you can see the standard deviation score has nearly normalized the adult height. So the long-term continuous growth hormone treatment results in a normalization of adult height in SGA patient, and 85% of the children born SGA achieved a normal adult height, and 98% of children born SGA achieved adult height within the target range. So it has growth hormone in SGA child has been efficacious to reach your adult target height. So the various factors which affect the growth hormone response, one is the primary cause is these patients would require a higher growth hormone dose. Younger age at the start of the therapy, these patients have a better response. Secondary thing could be the higher height standard deviation score and weight at the start of treatment, and higher mid-parental height standard deviation score. Again, these could be secondary attributes which could have a better response to growth hormone in these children. So we do have data from real world evidences. So ANSWER study which was done in USA which basically looked at various children with short stature, whether it could be indication of growth hormone deficiency or SGA or a child with Turner syndrome. So what they showed is those children who have started treatment early. So the cutoff age for early they used was girls age less than 8 years, and in boys age less than 9 years. So all growth hormone interventions should start early. Earlier you start, the response in achieving your adult height is much higher. And this holds good especially for all short stature, and in SGA children, those children who started less than 8 years had a better response in reaching your adult target height. So some two case scenarios I would highlight. This basically suggests a healthy boy who was initially referred to a clinic at 7 years of stage with short stature. So the height was 110 centimeter, less than third percentile. The bone age was more or less normal or slightly delayed by 1 year, and IGF-1 and IGF-BP3 was normal, and various other testing was also normal. So the birth history, this child was a preterm SGA and birth weight was 1,880 gram. The height, weight, everything was less than third percentile, normal developmental milestones, no husband, no other chronic illness or other comorbidities. You can see the growth chart. So these are the growth chart from the previous record. The growth is less than third percentile. So now basically with this previous, there's no catch-up growth even at the age of 7 years. So you start this patient on growth hormone therapy. You can see after growth hormone therapy, there is a cross in percentile, and this child reaches the so this would reach the target height. So growth hormone at an early age, it shows crossing of percentile from below 3 to above 3 and even to 50th percentile. So that is the target of or aim of therapy also. So this is a child with small for gestation born who had or who failed to show a catch-up growth. Similarly, you can have another case scenarios where a boy was referred to a clinic for 12 years of age for further evaluation of short stature. Again, the height is less than third percentile. Neurological, cardiovascular, respiratory and abdominal examinations were normal. Schooling was regular. Other tests were normal. And again, the birth weight was 1925 gram. And you can see the target height, father's and mother's height, which was much higher compared to the child. You can see the various growth plotting. So this child, born SGA, no catch-up growth, but unfortunately no intervention was done for this child. So if this child has been diagnosed or evaluated early for the cause of short stature, this child would have grown. So this is a common thing what happens when a child presents to a physician or a pediatrician. Many times in busy practice, parents are reassured for the child. Your child will grow. Your child will definitely grow. So this child was reissued at 4 years. Then some nutritional supplements is prescribed. Then the child develops peer pressure, and then it goes for a various evaluation. So referral to growth specialists at 12 years, basically then you start them on growth hormone therapy. This child will grow, but probably this child has missed the golden period for the growth. So the chance of achieving the adult target height would be much less because of the late onset of therapy. So the take-home message here is, please don't avoid and don't wait and watch in such cases when your height is below the 2.5 standard deviation. Always try to establish the diagnosis of short stature before following up the patient, because I think that is very, very important. You should establish a cause for short stature, whether it's a familial or constitution delay or SGA, and then you decide to wait and watch is left to you. So based on this, I think case identification is very important. We did a very interesting study to assess the prevalence and the various etiological profiles of short stature among school children in South Indian population. What we basically did is, we measured in 23 schools, roughly around 16,000 students, height and stature was measured. What we did was that initially our team will go to the school, they will measure the height and weight of each individual. Then with this height and date of birth, we used to plot this in the growth chart. And in this growth chart, any height which is falling less than third percentile, then we go to the school again, we get the permission from the school authorities and examine. So we reconfirm the height, and again everything is reconfirmed. So the child, both these child was growth hormone deficiency, which was basically diagnosed in the school health program. And one interesting child, what we diagnosed was that this is a very interesting child of psychogenic short stature. Though I have read more of psychogenic literature, this is one very interesting case which we encountered. So many of the small schools, the teachers are very clear about the students' history. So these were the teachers, we are asking them how long this child is short. The teacher says, மோலெல்லாம் கிளாஸில் நல்லா தான் இருந்தா, இப்போ ஒரு வருஷமாக தான் இவ்வளோ காட்டிலும் மற்ற குழந்தையெல்லாம் வளர்ந்துட்டாங்க. Then we asked what is happening. Then the child said, தெரியல சார், அவங்க mother passed away, so father had married again. So in this 1 or 2 years, the child is so down and depressed. So then we told the teacher it could be a cause of psychogenic short stature. Why don't you shift the child's growing environment? Then the teacher said, அதான் சார் நாங்கள் யோசிச்சிருக்கோம், அவங்க பாட்டி வீட்டுக்கு கூட்டு போகிறேன்னு சொல்லியிருக்காங்க. Then this child was shifted to his grandmother's house, and then we finished the project and we came out. Then this teacher came and met me after 1.5 years. He said, "Sir, you சொன்னது கரெக்ட் தான், பாட்டி வீட்டுக்கு போனோடனே குழந்தை வளர்ந்துருச்சு." So basically that's it could be identification of short stature is very, very important before you decide on intervention. So this was the prevalence what we got. Familial short stature constitutional delay in growth was roughly 58%. Growth hormone deficiency was 8%, and so it is very, very important to establish the diagnosis because many of the short stature could be treatable. So to summarize, approximately 10% of children born SGA exhibit failure to catch up growth, and there's an unmet need for improving the identification, diagnosis and regular monitoring of SGA. The growth hormone is an approved and proven treatment for children born SGA. Growth hormone is relatively safe and well tolerated. Wait and watch approach should not be practiced, and early treatment is very important. And birth weight and length measurement is important for early identification. Regular monitoring of birth weight and length is critical and vital to identify failure in catch-up growth. Early and timely referral to growth specialists is essential, and a multidisciplinary treatment is required for optimal outcome. And appropriate initiation of growth hormone at 4 years instead of wait and watch approach, and early referral and evaluation is important for your adequate achievement in height. And thank you so much.
Thank you very much, Dr. Kumarvel, for that very erudite presentation and simplifying a complex topic. Now, short for gestational age as well as idiopathic short stature, the rationale for using growth hormone therapy is more empirical. We have not identified a definite pathological cause for them. And as you had explained, probably it may be growth hormone resistance, that's why you require a higher dose. And of course, the response is not as much as you get with the classical growth hormone deficiency. Now, would you have a spectrum of cases in SGA which would you feel respond better to growth hormone therapy? Because even the IGF-1, BP3 values are all variable. Or would this be just a form of neurosecretory defect where endogenous secretion is impaired and your testing does not bring it out? Would there be a spectrum of in the spectrum of cases of SGA, would there be any group of them who would respond better to growth hormone?
So that I think even data are very clearly shown. SGA, preterm and term. Term SGAs, they respond better to growth hormone, and especially the catch-up growth is less in those with term SGA compared to the preterm SGA. And again, SGA, they have looked at the length and the weight. So you can have a child with small length, you can have a child with small weight also. So the child with weight appropriate and the length less, they respond better.
Thank you. Dr. Ravichandran? Yes. Any question from the audience? Yes.
Actually, zinc deficiency, you asked this question earlier to mention, is supposed to be height is surrogate marker for children, young children. So before we start growth hormone deficiency, we have to see the zinc status and then give zinc. Then only I think we must try to embark on growth hormone therapy to make these children come to that. That's my feeling.
Sir, most of these children,
I don't know what is the cost of growth hormone, which has come down to that level that we can give growth hormone to so many children.
So one is the cost, but second thing, all those children with whom we have listed the indication for growth hormone therapy, before initiating growth hormone, we ensure the other factors are normal. For example, we ensure the nutritional status is normal. If they are hypothyroid, we make them euthyroid. If they are hypocortisol, we make them eucortisolism. So unless you ensure the other growthing milieu is normal, we don't start them on growth hormone therapy. So because of lack of time, we are focused only on growth hormone. These cells may not require only growth hormone. So before starting growth hormone, all other endocrine parameters, nutritional parameters are taken care, and then only we start them on growth hormone therapy for the optimal outcome.
Dr. Venkatraman?
Sir, this SGA baby's growth hormone dynamic study, this dosage same as 4 microgram or
So usually the dosage of growth hormone in SGA child and Turner syndrome is higher compared to other indications for growth hormones. So
stimulation test.
Stimulation test, what they say, even in this SGA child, the stimulation test will not pick up anything because most of the data which have shown, most of stimulation tests are normal in this SGA child. Even your IGF-1 would be lower side of normal, and even your bone age would be more or less similar or it would be slightly delayed. So many times the SGA child is diagnosed based on your growth chart and your birth history. So these are the two things which could really help you to diagnose SGA child with poor catch-up growth.
Dr. Sundar Raman.
That was good talk, Dr. Kumavil. This extension of Dr. Mukti reiterated, it will be better because you got a good chunk of population. You can do some genetic or molecular study to know which individual has got a better potential for growth hormone treatment. Because SGA is only in a sublime period. Definitely no stimulation test or any test will be a marker for the diagnosis and treatment. And definitely, as we know that in growth hormone deficiency, there are some genetic markers. Is there any, you can go for a genetic and molecular study with these studies, I think so.
Yes, sir.
Any other questions from the audience? If not, in the interest of time, I think we'll go to the quiz.
So there will be total of 5 questions. You will be having an online platform to answer the question that we will be sharing subsequently. So the question could be MCQ based, picture based, or open-ended question. And each question should be answered within the specific time limit of 60 seconds. So timer will be just above your screen, right? And participants who answer the question early will be given more marks than who answer the question late, even within the same specific time period. So the questions most of the times will be simple, picture based question. So if you know the question, you answer early. If you answer early, you may get almost twice out of the mark than who answer the late. And you cannot answer the question once the time is lapsed. And you just in the screen where you are answering, above that itself, you will have both time and points clock will be visible. And each question will be loading automatically. Like once I approve the question here, in the screen of your phone, you can just see the question will be loading. Please do not try to reload yourself. And whatever decision of the quizmaster will be final, right? So with this, we'll go into the login portal. Yeah, next slide. So please log into this website, that is www.menti.com, and type the code. Okay, just type this code. So it is www.menti.com. Code is 26278097. I'll repeat again. It's 26278097. Please, in the name column, please type your name followed by affiliation, both. For example, if your name is Ravi from JIPMER, then you can just type Ravi space JIPMER or something like that. So apart from name, we also need your affiliation so that we can identify yourself at the end of the quiz. So I'll give a minute or so that you can please log into this. Okay. So we'll go into the, I think, yeah. So we'll start the quiz now, right? So this is the first question. I think you'll be seeing subsequently in your slide. So answer in one word, link between two figures. So this is the question. So we have two pictures here in this screen. So the same thing can be seen in your mobile also. So one, you can see human growth hormone, that is very visible. Another, you can just see some kind of trophy. So just try to link these two pictures and just give the answer in a single word. If you know the answer, please type it early so that you will get more marks. You will be placed higher even if others also answer same number of questions. So we have 15 seconds. We have 10 seconds. Last 5 seconds, please type the answer. Yeah. So we are done with the first question. We'll go into the second question. So this is a 15-year-old female child during workup for short stature with associated with primary amenorrhea had following X-ray finding, which is very typical. So please type the diagnosis. Just type the diagnosis. So this is a picture of right forearm with part of the wrist. So what is a typical picture which is seen here, and correlate with the history that we have given, that is short stature, and other is primary amenorrhea, and give the answer in a single word. So we have around 20 seconds more to answer the question. Last 10 seconds. So final seconds. Okay. So we'll go into the third question. So please try to answer early, right? So that is my request. So this is a 17-year-old child with tall stature with following karyotype. So what is the diagnosis? So this is a karyotype of a child who also had tall stature. So we need the diagnosis. We should see carefully actually. We have last 25 seconds. Child with tall stature with a karyotypic finding which is seen here. So last 10 seconds. Last few seconds. Okay, so we'll go into the next question. So term non-suppressible insulin-like activity refers to which of the following hormones? Term non-suppressible insulin-like activity refers to which of the following hormones? Option A, growth hormone. Option B, insulin-like growth factors. Option C, insulin, its role in fetal health. Option D, growth hormone releasing hormone. Option E, growth hormone, that is porcine form from pig. So which of these five options we refer this, which of these five hormones we refer like non-suppressible insulin-like activity? Just select one of the option. So we have 20 seconds to answer the question. So last 10 seconds. Okay. Final second. Years old with measured height of 110 centimeters. So we have given the 50th centile of the population, that is 150 centimeter, third centile of the population, that is 130 centimeters. So we wanted you to calculate the standard deviation score. Okay. So the measured height is 110 centimeter, and we have two other parameters, that is the 50th centile of the population, that is 150 centimeter, third centile of the population, that is 130 centimeters. So we all know standard deviation score we can calculate either from the chart which is available, okay, or from the tables. So even the growth chart itself, we can calculate the standard deviation score if we know what I meant in this question. So we have last 8 seconds. So final seconds to answer the question. Okay. So just give me a minute to give the answers. Now we'll have the answers followed by winners. Sir. Sir, nothing, sir. We'll just have the answers. Yeah, so we'll have the answers now. So we'll go to the first question. So the answer in one word, link between two. One is growth hormone YL is minus 4 ST. First is Dr. Ronald, I do not know, that was the name which was given. Second is Dr. Puffy. And third is Dr. Varun Chipper. Please identify yourself at the reception for the prize money. Thank you.
So thank you for that exciting quiz. So now we are moving to the next session after a wonderful morning session. The theme is thyroid, and to chair the session, I would like to invite upon Dr. P. Venkatraman, Senior Pediatric Endocrinologist and former Professor of Pediatrics, ICH MMC.
Yeah. My salutations and respect to my co-patrons, Endocrine Society office bearers, not to forget about the President of Indian Academy of Pediatrics, Puducherry. We are going to have another 20 minutes, very common issue, very, very common. How common is it? Professor Srinivasan knows about it. Whenever we go as examiners to any medical college, immediately they will bring a full-blown. Now the scenario has changed totally. And now that we have two eminent speakers, one is from Velo, Dr. Sara Mathai. She is a PhD in pediatric endocrinology. Now she is holding Unit 1 of Pediatrics, Christian Medical College. Please.
Thank you, sir. And good morning to everyone. At the outset, I'd like to thank the organizers, in particular Dr. Vijay Bhaskar Reddy, for inviting me to give this talk here on this important topic of newborn screening for congenital hypothyroidism, diagnosticity. So what happens? Less than 10% of the children have a clinical diagnosis in their first month of life, and even by 3 months, only about 30% get diagnosed clinically. And we know this paper, which was published in JPM in May 2007, there is an inverse relationship between the delay in the diagnosis and initiation of treatment of congenital hypothyroidism with the intellectual quotient. In the first 3 months, from 89, it drops to less than 54 beyond 6 months of age. In the 1970s, newborn screening was initiated, and it became the standard of care in most of the developed countries by the 1980s and 1990s. However, we don't have a national newborn screening program in India. I would like to add, not yet. ICMR initiated the pilot study in 2007, which screened 100,000 newborns for congenital hypothyroidism and CAH at 5 regional centers representing the east, west, north, and south of India. Currently, we have very limited state-level screening programs, and screening programs are available at selected districts in few states as well. But a large number of hospitals actually have initiated the screening program, which is independently run by each hospital. So in 2017-18, SEP published the locally relevant clinical practice guidelines for newborn screening, diagnosis, and management. It was published in 2 parts. Part 1 focusing on the screening and confirmation of diagnosis, and part 2 on imaging, treatment, and follow-up. These 2 documents are excellent and covers all aspects of the screening and follow-up of congenital hypothyroidism. Just looking at the summary of these guidelines: who to screen? Every newborn, using either cord blood or postnatal blood, ideally taken at beyond 48 to 72 hours of age. And what are the cutoff? Uniformly across India, the SEP recommends the use of mention as serum units, which is 2.2 times the whole blood units. It's very important because adjustment of the hematocrit in whole blood we need to do, and it has to be preferably uniformly recorded as serum units. So value of TSH more than 20 is considered positive. If it is more than 80, the recommendation is to collect the confirmatory sample and start thyroxine immediately, even before the reports are available if there is a delay. For values between 40 to 80, confirmatory sample after 72 hours of age, and the milder elevation, those between 20 to 40, confirmatory sample at 7 to 10 days of age. And how do we confirm? So these are the screen positive ones, and we recall and do a venous sample for all the 3 components, at least TSH and free T4 or T4, whichever is available. And it's only T4 or free T4 which is recommended to be measured, because TSH usually takes time to normalize. We aim to maintain the T4 or the free T4 in the upper half of the reference range for age, and at 1 month serum TSH, T4 and free T4, 2 monthly till 6 months of age, because this is the age of the maximum growth during infancy, and dosage adjustments need to be done. 3 monthly from 6 months to 3 years, and to 3 to 6 monthly thereafter. All children with primary congenital hypothyroidism should undergo a screening test and a clinical examination for other congenital malformation. And if transient CH is suspected, re-evaluation has to be done at 3 years. Does age of sampling L-thyroxine? And what is the most important information you need? The age at which TSH sample was collected. Why? Because at birth, because of the fall, the cord blood TSH levels can be 10 to 20, but with the fall in ambient temperature, there is a TSH surge which can occur any time from 30 to 60 minutes after birth, and it can peak even up to 100. Peaks on day 1 and steadily starts declining, and by about 72 hours or later than that, it's expected to return to normal. So this is the rationale for taking either cord blood or a sample, ideally after 48 to 72 hours, to avoid this cord blood TSH surge. So SEP guidelines have suggested differential cutoff for sampling. Beyond, if the mothers are getting discharged early and we need to take a screen sample, so at 24 to 48 hours, instead of TSH cutoff of 20, they have recommended a cutoff of more than 34. And in Lucknow, the recall rate was significantly reduced to 0.84 using an age-appropriate screen cutoff. There are special situations. We know that preterm babies have a different thyroid profile. Their TSH elevation may be delayed. They have an immature hypothalamo-pituitary thyroid axis. They may be ill with other conditions, a non-thyroidal illness, for many reasons. But just not to miss them, SPA still recommends an initial screening of all preterm babies at 48 to 72 hours of age. And babies who are sick in neonates also, at least by 7 days. This is just so that we don't miss them. And rescreening is considered at 4 weeks of age for high-risk neonates, which are preterm, low birth weight, very low birth weight, multiple births, and ill neonates. We also can have a scenario where there's a normal TSH and low T4 and free T4. We would consider sick euthyroidism, which is again non-thyroidal illness. Central hypothyroidism. It's important to actually assess this clinically, look at these babies, look for dysmorphic features, midline defects, and look for and rule out other pituitary hormone deficiency. It could also be a primary CH with delayed TSH elevation. It's important to remember to not treat lab values. Good history taking is important. 4-day-old baby with clearly an elevated TSH and low T4 and free T4, which suggests a hypothyroid state. But mother has thyrotoxicosis and she's on carbimazole during pregnancy. So the likely cause of hypothyroidism in this baby is a transient hypothyroidism caused by the antithyroid medication through the transplacental transfer. Occasionally, a TSH receptor blocking antibody can also cause a transient hypothyroidism. It's important not to initiate treatment in these babies because they can develop a hypothyroid Graves' disease by 1 to 2 weeks. And mothers with thyrotoxicosis, we may sometimes have to monitor the baby's TFT even up to 6 weeks or beyond. So history taking is very important. Thyroid gland imaging, radionuclide scan, preferred is the iodine 123, but it's not available, so most often is technetium 99. It can be done as long as the TSH is elevated before, without delaying treatment, or within 7 days of treatment initiation. There can be situation where the radionuclide does not pick up the thyroid gland, but it is seen in the ultrasound, a eutopic gland. We are aware of the many conditions which can actually cause it, one being TSH receptor, blocking antibodies, sodium iodide importer mutations, etc. So ultrasound is quite complementary to the technetium scan and can be done at any time. And in the past, and even in the current SPA guidelines, knee X-ray is mentioned. Absent distal femoral epiphysis, that has got a correlation to the severity of CH and the psychomotor developmental outcome. Long term, how do we follow up? At every visit, the clinical follow-up should include growth and development. We heard lots about growth in the first 2 sessions. Definitely, we need to follow up their weight gain and height gain, length gain. Development, because any developmental delay, we need to refer them early. Compliance with the thyroxine, the technique of administration, whether they're doing correctly or not, it's very, very important because it's available only in tablet formulation. Biochemically, we need to do TSH and free T4, and it's important to preferably tell them to give the blood sample and give tablet on that day, or at least there should be a 4-hour gap between sampling and testing. And the aim in children is always to maintain TSH in the age-specific range without over-suppression, and T4 and FT4 in the upper half of the range. Any change in dose, we need to repeat it by 4 to 6 weeks. And a trial of therapy if permanence is not established. What does overdose of thyroxine cause? Short-term tachycardia, some nervousness, disturbed sleep pattern, but prolonged overdose causes serious damage, osteoporosis, premature cranial synostosis, bone age advancement, behavioral problems, etc. So that's why this biochemistry is important to keep adjusting the dose. Now coming to what is the most cost-effective screening and management options available to maximize neurocognitive outcomes in resource-limited countries like ours and countries with no universal newborn screening, because all the long-term outcome studies are from the developed countries. So now we're going to talk about our experience for the last 21 years. It was initiated by Professor Raghupati, and we have a team including the pediatric endocrine, neonatology, obstetrics, clinical biochemistry, nuclear medicine who kindly does all our scans on the same day, and radiology who helps with the ultrasound scan. And it was commenced in July 2001, and we screen all inborn babies live more than 26 weeks and more than 900 grams, and who are alive at 72 hours is put onto the system, and we screen using cord blood sample, and our cutoff is more than 25. We recall the family after 24 hours, after good history and clinical examination. Diagnostic confirmation is done. Etiology is confirmed on the same day because it is available for us, and thyroid at a later date. After detailed parental counseling, thyroxine is initiated, and we closely follow them up. If the repeat test, if the venous confirmation is inconclusive, we call them back after after a week or so, and thereafter every 2 weeks till CH is either confirmed or ruled out. Over the last 21 years, we have screened close to 232,000 babies, and we have confirmed primary CH in 179 of them. If you look at the etiology, agenesis, in dysgenesis, agenesis is the vast majority, which are 51, ectopia 40, gland in situ 85, of which 82 of them had a nuclear scan, and scan was not done in 3 children primarily because they were quite unwell and we had to start the treatment. Incidentally, we also confirmed central hypothyroidism in 8 children because of their markedly suppressed cord blood TSH, and we went on to do the further tests and confirmed with central hypothyroidism. So what are the lessons that we learned? Cord blood versus sampling beyond 24 hours. We are probably one of the rare institutions which still continue with cord blood. So this data was analyzed in 2015 with the other larger cohorts from India, from Hyderabad, Chandigarh and Lucknow. So it's a little old comparison, but that was the data at that point of time we had. And if you look at it, we had screened 142,000 babies. So we noticed that there is a significant reduction in the missed primary screening using cord blood. We had missed less than 1%. This is, even those who have missed cord blood sample will be collected before they are discharged. So including all of them, it's less than 1%, as compared to a larger percentage of misscreening in the other centers. This is primarily because in India, the vast majority have normal vaginal delivery and they are discharged within 48 hours. Of course, SEP has now recommended use of differential cutoffs, and data from larger cohorts are awaited. We also noticed that in all the centers, including us, there is a high rate of non-responders to recall, almost 14 to 25%. So post-discharge sampling relies on parents to bring back to the hospital a healthy, normal child. It's a very difficult task. Its situation has not improved even with 1 and 2 mobile phones at home. So if they are screen positive and if we get the result, even before discharge, we can counsel them to bring back. Another important part was the very early treatment initiation we could do. We could initiate treatment at the mean age of 8.4 days. So by second week, almost 95% of the children are on treatment. Of course, there are disadvantages of using cord blood. Missing non-institutional deliveries, those with central hypothyroidism, those with delayed TSH elevation, mainly other metabolic diseases, because we do have a large number of children with CAH and a lot of other IEM, which cannot be done on cord blood. So when we look at the data from India, there is a wide variation in the CH prevalence, and screen TSH cutoff is an important factor. Higher cutoff, as we all know, increases the overall recall rate, but the lower cutoff increases sensitivity and increases recall rate. In India, we have a diverse population and very limited resources. So we did an audit of our study. Dr. Praveen did this. And in the first 9 months of our screening program, we had a screen cutoff of 20. And after 9 months, we had increased it to 25. So this 14,700 children is a prospective and a retrospective cohort. And in the 20 to 25 group, none were confirmed to have CH. And we looked at every value for cord blood between 25 to 30. This is a screening of 165,000 population. And 6 babies had confirmed congenital hypothyroidism. So when we looked at every value above 25, we noticed that when you use a cord blood, a cutoff of 25 seems to have 99.2% sensitivity and 97.5% specificity. And the vast majority of ours was a local population. Of course, there is a verification bias here because we have not done a gold standard test of T4 and free T4 for all the children, but in a large screening program, that verification bias is acceptable. And over the years, we have learned the importance of parental counseling. Detailed counseling is very, very important at the time of diagnosis regarding particularly mother not to be blamed for the infancy age. Technique of administration should not administer it along with soy formula as well as iron and compliance. It's a large number of children are under regular follow-up with us, and our oldest child is actually 21-year-old, she's married. And we also, despite having almost 42% of dysharmonogenesis, which are meant to be which could be transient, we have a very high rate of permanence in our cohort, primarily because of the strict diagnostic criteria which is used at the time of diagnosis. And I would like to reinforce that no screen TSH is cut off. In the last, this many years, we had 2 missed children. The first child was a term born with a screen cutoff of 39.6. As you can see, we have followed her up to day 45. Looking back, yes, TSH was not completely normal, but at 5 years, she presented with myxedema and a diagnosis of thyroid agenesis. The child too had a very normal cord blood value of 11.8. So I want to reiterate that clinical examination cannot replace newborn screening. To conclude, we need to have a regular meticulous audit of the dedicated team of newborn screening. Always we have to collect the correct address and telephone number of the families. The aim of any newborn screening is to identify maximum number of children with congenital hypothyroidism with the limited resources. Overdiagnosis should be avoided, and it is important to remember if there is a clinical suspicion, even if it's a screen baby, we need to repeat the thyroid function test. I want to conclude with this slide. This paper was published in 2012. 260 children with congenital hypothyroidism, of which 34 of them presented beyond 5 years of age. And this child had come at 11 years to us with severe short stature and congenital hypothyroidism. We know that there is devastating, irreversible consequences if untreated, and an excellent long-term outcome with simple economical treatment. So I would actually request active advocacy to initiate universal newborn screening program in India. Thank you.
Thank you very much, Dr. Mathai. Actually, the present day pediatricians and pediatric endocrinologists are really fortunate enough that today, for each and every complicated, common problem, you have got a guideline by the Indian Academy of Pediatrics and SEP as against some 2 or 3 decades back. We never had such a luxury of guideline-based clinical practice. And I think this is one of the largest, for newborn screening, especially in southern India, southern part of India. I don't know about the north. This is the only one institution wherein it has been going on since Professor Raghupathi's period. Congratulations to you, madam.
Yeah, it's a big team, sir. Thank you. Thank you for the whole team.
Yeah. And this is a common problem. I request postgraduates to have 1 or 2 questions. This is mainly for you.
I first thank the organizers for giving me the opportunity to co-chair the session with my own teacher, Professor Venkatraman from ICH. I was a student in 94 to 97. Thank you for your wonderful elaborate talk, madam. I got only 2 questions. In periphery, it's very difficult to, get consent for sampling from mothers for newborns. Actually, once we start L-Troxin, the current guideline says initial 3 months we have to do every 2 weeks.
So the first one at 2 to 4 weeks. Ideally at 2 weeks, but it may not be possible, at least at 4 weeks, because we need to adjust the dose. We are giving a loading dose when we give 10 to 15 for rapidly normalizing the thyroxine. So ideally at least at 4 weeks we need to actually call them.
And the guideline says the first 1 year, every 3 months we have to do.
Two monthly till 6 months, because that's a period of rapid growth.
Can you tell me the at least the minimum sampling times for
At least 3 monthly, sir.
once in
2 to 3 monthly.
Because we have some
So,
difficulty.
yeah.
One more thing I want to ask, madam. Whenever you start L-troxin in some babies, the T4 becomes the upper limit of normal. The TSH goes to a very, very lower level. Should the treating physician be alarmed, or we have to?
So the oversuppression of TSH indicates an overdosing, and the high
even though
T4
the T4 is upper limit
high,
of normal.
that upper limit of normal, you may pull back, but we also have to ask them whether, if the TSH is slightly elevated, the opposite condition, and the free T4 is in the higher range, we need to think whether they have given the dose. We missed a few doses, and then, in the last few days they were given the dose, because TSH takes time. It has got a longer half-life and it takes time to normalize.
Okay, thank you. Thank you.
The ISPA guide.
Thank you, madam. I'm Sriram from Chennai. We had an opportunity to survey the Tirupattur and that area belt on geneticists from MGR University. This was a very disturbing information we got. He was actually doing on disability, and a lot of children, adolescents with both physical and mental faculties which are disabled. More than 22,000 population were screened in that belt. It included, I think, Vellore also. I mean, now it is trifurcated, I think. Politically, the districts are changed. So what was that? There were congenital hypothyroid children who were diagnosed appropriately either at Egmore or Vellore CMC also. Very, very unfortunately not followed up and treated. So there were at least 22 or 23 children, I don't remember the exact number.
Hello.
They are now unfortunately having a disability, appropriately diagnosed. So my humble, in addition to the advocacy for screening to be made universal, there should be a definite mandatory follow-up for at least the first 3 to 4 years. These children are unfortunately gaining some benefits out of being called disabled because they get some governmental benefits. So these children who, even though a simple treatment, they took for the first 3-4 months. After that, for various reasons, obviously financial and other reasons were also there. That was a disturbing
I think much
information.
of it can be overcome by family counseling, very detailed and elaborate counseling at the time of diagnosis.
These are all children who are all diagnosed in major centers in Chennai and including Christian Medical College. So I don't think that would have been an issue, is what I presume. I have only seen 7 or 8 of those children on follow-up, but there were not less than 20-30 like that. Each village has at least 1 or 2 like that. It means there is some other phenomena. So it included, going for testing, as Sir asked, every week and every month and all going for testing will be probably a problem. And one more thing, this I don't know, this is not the right forum, is the thyroxine bioavailability. This we had an issue with my colleagues from governmental setup will vouch for what I am saying is sometimes, this 10 and 15 microgram per kg will hold good only if the tablet is of that appropriate microgram. I leave it there. There are so many issues at governmental and other quality of tablet.
So we can actually give a divided one, sir. Say 25 microgram, you can give 1 tablet for 5 days and 1.5 for 2 days. That is how we adjust the dose. May not be absolutely correct, but that's the only way to do, because only tablets are available.
I fully agree with Professor Sriram. The same issue we also faced in ICH, not now, some 30 years back. We made a diagnosis of congenital hypothyroidism. They calculate the dosage. At that time, the tablet available only was 100 microgram. That was the only available thing. No other strengths. Now we have got luxury of having 12.5, so on and so forth. Diligently, we make a diagnosis. We tell them to come back. They come back after 2 years or 3 years with the full-fledged sequelae. The same old dose. Sir, you told us to take half a tablet. When the child was 2 months old. That's a real problem for us. Okay, fine. Thank you very much, Dr. Mathai.
Thank you.
We shall move on to the next speaker. Pediatric endocrinology is unique in having a lot of debates, debatable topics from time immemorial. Dr. Sri Nagesh is going to discuss about another debatable but a very common clinical issue, to be or not to be.
Yes.
Over to Dr. Sri Nagesh.
Thanks a lot, sir, and hope you have loaded my slides. The next 20 minutes, perhaps, I'll try to give you a perspective about subclinical hypothyroidism in children, to treat or not to treat. And before I begin, I'd like to thank the organizing committee of Trendo and my dear friend Vijay Bhaskar for inviting me to Pondicherry yet again to give a talk. This is how my talk is going to be. I'm going to give you a brief case scenario of a standard case you'd find in the pediatric OP. What exactly is the meaning of subclinical hypothyroidism in children? What are the various causes which contribute to the diagnosis of subclinical hypothyroidism? A jury classification as to what is mild and moderate subclinical hypothyroidism. You don't have severe subclinical hypothyroidism because it is only subclinical. What are the various mechanistic explanations for the subclinical hypothyroidism? Indications for treatment, and how do you treat it? A typical case you would actually see in a routine endocrine or a pediatric OP. 11-year-old who's on a follow-up with pediatrician for constipation. Believe it or not, constipation is one of the commonest indications where somebody is evaluated for hypothyroidism. The second commonest cause is perhaps obesity. On evaluation, he had a T3 which was in the normal range, T4 which was in the normal range, and TSH which was 9.42, which was above the lab upper limit of normal, which is usually 0.4 to 5 microunits per ml. It varies from lab to lab. And at this point of time, when you are looking at lab normative data, you have to understand two things. One, the normative data varies from assay to assay, and depending on the kit you use, and at the extremes of age, the TSH cutoffs are usually much higher. For instance, in a newborn, a TSH of 9 on screening on day 3 or day 4 would be normal. In a 3-month-old, a TSH of around 7.2, 7.3 would be normal. Child TSH values of up to 5 and 6 can be normal, and again at the extremes of age. In the 6th decade of life, 6 would be normal, 7th decade, 7 would be normal. So whenever you look at normative data and the cutoffs, your perspective should be based on the kind of assay used and the age of the child. And this child had a TSH which was definitely above the upper limit of normal, irrespective of the assay used. And he was then referred to me for treatment of hypothyroidism. He did not give any family history of hypothyroidism, which is again an indicator towards Hashimoto's thyroiditis, as well as the more uncommon causes of genetic hypothyroidism, especially GOX2. Height was around 25th to 50th centile for age. Weight was around 98th centile for age, which is again another red flag why a lot of pediatricians actually evaluate children for hypothyroidism. The big question is, does this child require treatment? If you actually look at subclinical hypothyroidism, the definition varies. Serum TSH levels above the upper limit of the reference range for that particular assay and age, in the presence of normal concentrations of either a total T4 or a free T4. For reasons of economy and as well as the fact that we do not have clear-cut definitions and guidelines as to the use of free T4 assay in the Indian population, where we have a lot of challenges regarding interpretation, we prefer to do a total T4. The reference range for this particular assay was 0.3 to 5, which is the commonest reference range. And mind you, you have to determine this on 2 independent assessments. A single TSH assay does not label a child as hypothyroidism. We have to repeat it on a different day. Most of the time, this is classified as mild and moderate. We don't have, like I've told you, we don't have a severe subclinical hypothyroidism. For practical purposes, any moderate subclinical hypothyroidism is defined as a TSH more than 10 with a normal T4, and a mild subclinical hypothyroidism is defined as something with a TSH less than 9.9 with a normal T4.
Most of the time we treat only when you have a TSH of more than 10. Almost all guidelines and all studies are universal in recommending that you treat TSH when hypothyroidism and the TSH is more than 10. The big question is, what do you do when it is between 0.4 and 9.9, which is exactly what describes the case we have seen right now. As far as the prevalence of subclinical hypothyroidism is concerned, if you've been familiar with this, you would know that prevalence rates for subclinical hypothyroidism are not even very widely known even in the adults. We've got variable data from 4% to 12%. The studies we have had in children are much, much lesser. There has been only one large NHA-NES3 study which has given us a lot of conflicting data about treatment outcomes also, as you'll see later down the line. It indicated a prevalence of 1.7% of subclinical hypothyroidism among 1,300 adolescents between the age of 13 to 16, which is usually the commonest age at which you detect hypothyroidism, because puberty and the increased sex steroids raise the prevalence of Hashimoto's thyroiditis. There was one US insurance database of almost 120,000 children between the ages of 6 months to 16 years, which suggested that subclinical hypothyroidism was routine in almost 2.9% of the children who were part of this database. But again, except these two, we don't have large-scale data as far as subclinical hypothyroidism is concerned. This always brings us back to the big question: do we treat these children? Do we treat these 2.9? Because if you look at this data, 3% of 120,000 children would actually mean almost 5,000 children. Do all these children actually need treatment for subclinical hypothyroidism is what we are going to discuss in the next 10 minutes. Most of the time, the decision making as far as the treatment of subclinical hypothyroidism is based on the TSH level. We already know that if it is more than 10, you would be better off treating. It is also to a great extent dependent on the etiology and the presence or absence of syndromes, which are quite common in the pediatric age group. Most of the time, even today, the commonest cause of subclinical hypothyroidism in children is Hashimoto's thyroiditis. Persistent neonatal hyperthyroidropenia is another common cause, and Dr. Saramata has already dealt with it, so I'm not going to discuss this any further. Gene defects and thyroid dysfunction, which are the second most common cause of subclinical hypothyroidism. Genetic syndromes, especially Down's and Turner syndrome. Iodine deficiency, even in this era of using iodized salt, iodine deficiency is still very common. And in the last 3-4 years, because of issues of price control of essential commodities, more and more people have started using this Himalayan rock salt and the pink rock salt, under the assumption that use of excess iodine is actually harmful. What most people tend to forget is the Himalayan area is perhaps the world's most iodine deficient belt. And in using this kind of pink salt, they're actually exposing their children and themselves to severe iodine deficiency. Iodine deficiency has again started becoming a problem. Use of medications like interferon alpha, use of amiodarone, and perhaps the most common in children, anti-epileptic medications. Exposure to ionizing radiation, especially people who have received chemotherapy and who received a large amount of radiation. Obesity is something which I'm going to discuss further down the line in more detail. And idiopathic subclinical hypothyroidism, a large extent of which is perhaps a variation from the mean or undetected genetic hypothyroidism. Hashimoto's remains the most frequent cause of subclinical hypothyroidism, which is persistent between the ages of 8 to 18 years. Down syndrome or Turner syndrome are also associated with Hashimoto's thyroiditis. Autoimmunity is very common in Turner syndrome. Hashimoto's is one of the ways in which children with Down syndrome can develop hypothyroidism. There are other ways also, because this is integral to the diagnosis of Down syndrome, a lot of whom do not require treatment. If you have other autoimmune disorders like type 1 diabetes, your chance of developing hypothyroidism goes up by almost 30%. Celiac disease is a common cause of hypothyroidism, but again, I think celiac is extremely uncommon in South India. I have not seen a lot of cases. And the current Indian-wide data also does not support incidence of subclinical hypothyroidism in people of South Indian origin. And a lot of times, if you have Hashimoto's, you generally tend to have a trend towards persistent and progressive thyroid function deterioration. In fact, I have not been able to find a lot of published data about this, but in the last 5-6 years, I've been seeing a secular trend towards development and detection of Hashimoto's thyroiditis at a younger age. Earlier, the earliest we used to see Hashimoto's was around 8 to 9 years. Of late, I've been seeing it in children who are as young as 4 to 5 years with a positive family history of Hashimoto's. I don't know whether this is a randomization bias or the use of iodized salt has actually triggered development of Hashimoto's at a younger age. Because we do know that iodine causes a greater incidence of Hashimoto's, though it does reduce the risk of severe hypothyroidism, but I think we need more studies on this. The second commonest cause of subclinical hypothyroidism are gene defects and thyroid dysfunction. Commonly TSH receptor mutations. Almost 12 to 30% of children in this one particular American study had with non-autoimmune subclinical hypothyroidism actually ended up having genetic hypothyroidism. The commonest is a TSH receptor mutation. The second is a duox or a dual oxygenase 2 receptor mutations. This is something which we commonly see in our OPs. A lot of them actually come with a family history and some of them are actually X-linked dominant. Many a time the mothers also present with these disorders. Down syndrome is actually a very well recognized cause of subclinical hypothyroidism in the pediatric age group and it remains undefined. We do not have large scale data about Down syndrome. The prevalence in studies has been reported to vary from 25 to 60% and it is intrinsic to the trisomy in Down syndrome. One of the putative causes has been autoimmunity. It has also been implicated that you have a central disorder where more TSH is produced at the level of the hypothalamus at the pituitary and more TRH at the hypothalamic level. And rarely it is considered to be a frequently self-limiting condition. Mild hypothyroidism actually does not require treatment in Down syndrome. A lot of times among medications, the most common implicated medication is anti-epileptic medications because of increased activation of CYP450 and rapid metabolism of your thyroxine supplements and your endogenous thyroid levels. Iodine deficiency, for reasons I've already told you, is again rearing its head in the pediatric population. Coming to the big question, obesity and hypothyroidism are actually a chicken and an egg hypothesis. This is perhaps the commonest reason why pediatricians advise thyroid function tests. The minute they see an obese child in the OP, the first test you get is a thyroid function test, a TSH. Moderate elevations in TSH concentrations will be seen in 10 to 20% of children in the pediatric age group, and this is the reason why a lot of them are actually referred to endocrinologists. And this is a case where this is more often the obesity is the cause of the elevated TSH rather than being a consequence of elevated TSH. Multiple causes have been imputed as to why people with obesity develop hypothyroidism. Most important, this is considered to be an adaptation to an increased energy expenditure. As your weight goes up, your body intrinsically increases TSH, which increases T4 and T3, which increase energy expenditure so that you tend to lose weight. A resistance to thyroid hormones, especially at the receptor level, has also been imputed here. There is also some amount of neuroendocrine dysfunction, which secondarily is again linked to the increased leptin levels which are seen in people who are obese. Leptin acts at the level of the hypothalamus, increases TRH, which increases TSH, which is often misconstrued as subclinical hypothyroidism. And in a few cases, mutations in the TSH receptor have also been reported, which are epigenetic changes because of the increased obesity and the increased insulin levels seen in these children. But whatever it might be, a lot of children, almost all the children who present with obesity and mild subclinical hypothyroidism do not require treatment. A simple advice to lose weight can itself cause a reduction in their TSH levels and they come back to normal. This is how it actually works out. Resting energy expenditure is increased because of the rise in T4 and T3 levels. Leptin levels are always increased in people with obesity. They convert pro-TRH to TRH conversion is improved by increased leptin levels, which cause a rise in TSH, more of T4, more deiodinase activity, increased free T3, and consequently you have more energy expenditure. This is how this link is thought to be explained. Most of the time, when you choose not to treat a person with subclinical hypothyroidism, these are the three consequences which are often claimed to be the reason why we are actually supposed to treat mild subclinical hypothyroidism. Among these three, what do you think is the most important? The answer is actually none. Linear growth a very common reason why people are started on thyroxine is actually impaired only when your TSH crosses 50 and is seen in overt hypothyroidism, not in subclinical. There have been 2 or 3 small studies on linear growth because for reasons of follow-up, it is very difficult to follow up these children. Many of these children, even after 5 years of sustained subclinical hypothyroidism, have tended to have a normal growth. The growth velocity, bone maturation and IGF levels were also normal in these children. The second most common outcomes are neurocognitive outcomes. In fact, the data from these are contrasting. Many studies have actually shown us that there are subtle negative effects on verbal comprehension and immediate and long-term recalls. You'll probably get a B grade instead of getting an A grade in school, and this is not often noticed. The NHNES3 study, which was one of the largest studies which dealt with this in detail, actually said that cognitive performance was normal in children with subclinical hypothyroidism, and in fact it was even better than in children who were euthyroid, which was a bit of a shocker. Some studies actually tell you that they do worse, some tell you that they actually do better. So as far as neurocognitive outcomes is concerned, we don't have any clear findings. As far as bone health is concerned, again, the implication is the second decade and the third decade of life are when you get the maximum bone density. And if you have subclinical hypothyroidism, your bone accretion rate is decreased. But the studies actually do not give us any evidence that this actually happens. We have had only 2 studies which have looked at bone density. And both the studies have told us that there is not much impact of subclinical hypothyroidism on bone density. Perhaps the only area where we've got some evidence for treatment of subclinical hypothyroidism is in cardiovascular risk. Mild dyslipidemia is seen in children even with TSH levels of 5 and 6, which is very similar to what is seen in the adults. You have a high triglyceride level. This is what I have seen even in a lot of my patients and in a lot of studies. And you also have an increased non-HDL cholesterol, and some studies have actually reported a decreased HDL cholesterol level, especially when the TSH is more than 10, but even when it is less than 10, this kind of consequences are seen. This brings us to the next question. So does treatment of subclinical hypothyroidism actually change any of this? This is again a hugely debated question. Some studies have been short-term which are beneficial. We do not have long-term studies or long-term data as to the treatment of subclinical hypothyroidism. As far as the height velocity or the height gain is concerned, there are no appreciable differences in height in RCTs when children were treated with thyroxine as opposed to children who were not treated with thyroxine. No changes in the neurocognitive score. Some studies, if you have seen here, have actually told you that there is a subtle difference in verbal comprehension in subclinical hypothyroidism, but there is no benefit if you actually treat these children with thyroxine. This is a bit like the HDL cholesterol data. HDL cholesterol, which is low, predisposes to cardiovascular risk. If you raise the HDL cholesterol, there's no evidence that they actually improve. The data with thyroxine treatment and cognitive dysfunction is also pretty similar to that. No changes in the long-term bone health, which is evaluated by the bone density, is again seen with this study. The only area where you actually had some benefit was an improvement in abnormalities of the left ventricular systolic and diastolic parameters. And you've also had short-term decreases in the triglyceride levels and the non-HDL cholesterol levels. This is perhaps the only place where we can say that treating mild subclinical hypothyroidism is going to give you benefits. But this is again a moot point whether this increased triglyceride and increased non-HDL cholesterol levels are significant in a child, and whether treating them at the ages of 6 to 7 years is going to better cardiovascular outcomes at the age of 45 or 50 years. This is a proposed flow chart as to the treatment of subclinical hypothyroidism. First, ensure that the TSH is high on 2 different studies. If the TSH is more than 10, go ahead with treatment. If the TSH is less than 10, you are advised to check the TSH and T4 or free T4 after 4 to 12 weeks. If the TSH is still higher and the free T4 is within the normal range, you take a detailed history as to all the reasons I've told you earlier. Examine them for a goiter, hypothyroidism. If you can, do an antithyroid antibodies. I'm just finishing. If the TSH persists, you treat them. If they are obese, advise weight loss. If they are on medications, if you can, cut down these medications and reassess them after 6 months. And if you have a syndromic cause or you got a neonatal onset of subclinical hypothyroidism, you should be more inclined towards treating these children. To To conclude, subclinical hypothyroidism is very common in children. More than TSH, you'd be better off treating. 4.4 to 9.9, wait and watch. And most of the current studies actually recommend a waiting and watching approach because treatment does not give you major benefits. If you got syndromes, if you got a major dyslipidemia, if you have a marked height velocity decrease, I'm not saying a simple height velocity decrease, a marked height velocity decrease, which cannot be explained by any other factors, you are better off giving them a trial of thyroxine for 3 to 6 months. If the neurocognitive problems are severe, or they have disorders like autism, you're perhaps better off giving them a trial. So these are all the conditions where you should have a slightly lower threshold for treatment. In all other cases, wait and watch, and please remember that obesity is not an indication for starting thyroxine. Obesity is the cause rather than being the reason for the hypothyroidism. Is the reason for hypothyroidism. A simple weight loss regimen is perhaps what is most needed for treating hypothyroidism in this particular age group. That's it. Thank you, and if there are any questions, I'd like to take them.
Thank you, Dr. Nagesh. Two important observations we did. Number one is we insist upon the drawing of the detailed pedigree in the case sheet. Whenever we see a proband with subclinical hypothyroidism, our experience shows that the mother, grandmother, great-grandmother, it ran in families, surprisingly. Many families, we were having it. That is number one. Another common observation is that the age, as you have rightly mentioned, the lowest age group in our experience was 4 years, even those days. Okay.
Sir, if I'd like to comment on one thing, I think your observation about the pedigree chart is with respect to Hashimoto's thyroiditis.
Yeah, exactly.
Hashimoto's thyroiditis is very common.
Hashimoto's.
You don't even need to draw a detailed pedigree chart. A simple TPO antibody testing itself would be more than enough to give you an answer.
I agree.
But what I'm seeing is the Hashimoto's prevalence is actually, the age is actually coming down. And this is a secular trend which has been observed with other autoimmune disorders also. It's been well studied in type 1 diabetes. Not so well studied in Hashimoto's because it's perhaps not such a dangerous disease.
Yeah. Yeah.
We had an opportunity to study 45 children with elevated TSH. We published it in Indian Pediatrics a few years back. The interesting observation, we wanted to, they asked what is new in this study. In India, if you submit it, they ask what is new. Subclinical hypothyroidism, this up to 10 and ATA guidelines, all these are often quoted, especially in adult literature. And in those 45 children, one important observation which can be as a take-home practice point is, because it is autoimmune more often, that's what we are understanding, and these deficiencies in other things, in a good, nutritionally well-off thing, we don't expect that. So it reverts to normal. So one more, in addition to independent TSH measurement, the 6 to 9 or even, so we observed children even up to 15. So TSH more than 15 only we treated in that study, and more often it normalizes. Only 4 out of those 42 or 43 children it progressed, and TPO antibody, which will give you a clue in those patients. That was, and we reviewed literature. Dr. Marwa has published a lot of massive papers on Indian children data, and as in gestational pregnancy TSH, the Indian children have a higher
TSH
value.
But one observation is nowadays in affluent children, you'll have to be more concerned about iodine deficiency because they're more often likely to be on this anodized salt. Yeah, I think this question.
Sir, excuse me, I just have a question. So when a child with a normal TFT, when we start them on anti-epileptics, and later somehow they get their TFT repeated, and we often see a low free T4 with a normal TSH or a slightly high TSH, and is that an indication to treat, or if you're planning to wait and monitor how frequently we have to
I think just a week ago we had a huge debate about this on our WhatsApp group. Dr. Ramkumar, who will be the speaker today, was discussing this extensively. Free T4 assays are not very good in the Indian scenario. We don't generally do free T4, except in people who have dysalbuminic hyperthyroxanemia or familial hyperthyroxanemia, or in a newborn where you need an immediate decision. I personally don't do a free T4 because free T4 is accurate only if you do an equilibrium dialysis. If you don't do an equilibrium dialysis, free T4 is not very accurate. You're better off doing a T4. A lot of times T4 will actually give you an answer. And second thing, like I've told you, anti-epileptic drugs not only increase the P450 levels, but they also have, to some extent, biotin and anti-epileptic drugs interfere with the SS. So I would not be treating these children, I'd just wait and watch. Another therapy where you would actually be better off testing for TSH is people who are on growth hormone. Especially when you start giving children, short stage children who are on growth hormone, a few months after starting growth hormone, the somatostatin levels start going up. Once the somatostatin levels start going up, the T4, the TSH will be normal, but there will be a drastic drop in the free T4 levels. I have seen children where the TSH was absolutely normal because the somatostatin was suppressing the TSH, but the free T4 levels dropped down to 0.5 and 0.6. And that is when you have a sudden deceleration in the height velocity, which is unexplained by any other reason. And this is one indication where we actually measure free T4 and start treating these children. In all other scenarios, I would not recommend going with a free T4.
Okay, thank you, sir.
Thank you, sir, for your wonderful
I think
talk.
somebody had a question there.
I think we are slightly running late.
Antibodies are a huge topic. Many people recommend doing antibodies. Some people don't recommend doing antibodies. But if the anti-TPO antibodies are positive, your chance of going towards a persistent hypothyroidism is higher. But only the presence of antibodies with a TSH level of 5 or 6 does not indicate the need for starting treatment. It only prognosticates.
So it should be followed up with antibodies.
They should just be followed up, because I think there was one adult study almost 20 years ago which was done in the US Army. The mean time, the maximum time between the detection of TSH antibodies and the development of hypothyroidism which required treatment extended up to 8 years. Most of them actually developed clinically overt hypothyroidism at the end of 2 years. But this was a study from US Army Hospital, Maryland or someplace, where sometimes people needed up to 8 years. So when the minute you check TPO antibodies and the TSH is slightly elevated, you start treating them. You might perhaps be giving them up to 8 years of excessive thyroxine therapy, so I don't recommend that. Measure the antibodies, but don't act on them until and unless the TSH is increased or the subsequent TSH assay after 3 months shows you a rising titer.
Thank you.
Thank you.
Thank you, sir. I think if there are not any more questions, we can close the session. Thank you.
So now let's have a quiz on thyroid.
So this I'm not going to go through again. The thing is, please answer fast. So that is the only thing you should understand. Like as soon as you know the answer, you just answer. Okay, so go to the next slide, please. Okay, so go on to this website, open a new tab, go on to this website again, www.menti.com, and the code that you have to use is 66074739. I repeat again, the website is www.menti.com. Code is 66074739. And again, please type your name and also affiliation together. So I'll just give another 15 seconds for people to join. Okay, so we'll start the quiz. Nobel Prize in Thyroid was awarded to which of the following scientists? Option A, Edward Kendall for his purification of work on purification of thyroid hormone. Option B, Charles Harrington for its work on synthetic preparation of thyroid hormone. Option C, Astute for his use of thiourea, that is antithyroid drugs in treatment of hypothyroidism. Option D, Theodore Kocher for his work on thyroid physiology and surgery. Option D, Robert James Graves for his work on hypothyroidism. So which of these 5 scientists have been awarded Nobel Prize for their work on thyroid? So we have 20 seconds to answer the question. So select single best option. So last few seconds. So we are done this question. We'll go on to the next question. So a 12-year-old child with no previous medical or surgical history underwent ultrasound neck for suspected submandibular lymph node. So identify the finding noted in ultrasound. So this is the ultrasound neck of a 12-year-old child with no previous medical or surgical history underwent ultrasound neck for a suspected submandibular lymph nodes. Identify the finding which is seen in the ultrasound. You have 20 more seconds to answer. Last 10 seconds. We'll move on to the third question. An 8-month-old child infant presented with congenital hypothyroidism. Phenotypic features include low set ears, cleft palate, spiky hair, and thyroid agenesis. What is the transcription factor which is involved in this clinical syndrome? So just name the transcription factor, either in the full form or short form, whichever way you write, the answer will be accepted. So it's a 8-month-old infant with congenital hypothyroidism, with low set ears, cleft palate, which you can see in the picture also. It's a big cleft palate. You can just see a whole of the palate is like separated, and also spiky hair, which is visible. Apart from that, child also had thyroid agenesis and subsequently congenital hypothyroidism. So what is the transcription factor which is involved in this condition? So we have 10 seconds for the answer. So we'll go on to the next question. That is fourth question. So this is a technetium scan of a child, and what you see in above are the planar images, that is anterior and left anterior oblique and right anterior oblique projections are the below images, so which were acquired 20 minutes post injection of technetium. So what is the diagnosis? Just write the diagnosis. You can just see there is a marking of SSN is there. So if you can know what it is, then I think the answer is very obvious. So we have last 15 seconds to answer. So time is up. We'll go on to the next question and the final question. So this is a 50-year-old male with history of neck pain and goiter. What's the diagnosis of the condition based on histopathology? Just write the diagnosis, the final diagnosis, which could be arrived with the little history that is given, that is neck pain and also goiter, and the classical histopathological finding. So we have 20 seconds to answer, left to answer. So please answer fast if you know the answer. Do not wait for the time to end. So So we have last few seconds. Okay, time is up. Just give me a minute for formulating the results. So we'll have the answers followed by the winners. So the Nobel Prize in thyroid, there is only one Nobel Prize that is given in thyroid, that was to Theodor Kocher for his work on physiology, pathology and surgery. It was a collective work on thyroid, so he received the Nobel Prize. So next slide. So this is a classical hemithyroid dysgenesis. Okay, you can just see the ultrasound showing only the one half of thyroid, that is you can just see the right lobe, but the left lobe is not visible. So it is a thyroid hemiagenesis. Next. So this is called as Bamforth-Lazarus syndrome, but the answer that is expected is thyroid transcription factor 2, TTF2. Okay, so that it has a classical spiky here. Next. So this is a lingual thyroid. You can just see SSN is suprasternal notch. You have the uptake of technetium in the area of tongue, that is in the chin, those areas. Okay, so it is a sublingual thyroid, and this is a classical histopathological picture of subacute thyroiditis. What you see here is a giant cell, okay, and all the neutrophils surrounding that, okay, and so usually it is characterized by infiltration of neutrophils, lymphocytes, histiocytes, and giant cells. So giant cells are typical for subacute thyroiditis. So the total participants were 78. The first prize is Dr. Bill, second is Dr. Ronald, and third is Dr. Akshaya Jipper. Please contact the reception for the cash prizes. Thank you.
So thank you everyone for sharing your valuable insights in the last session, and hope you enjoyed the quiz as well. So now let's for break for tea, and I request everyone to assemble back at 11:30 sharp. And another announcement for participants of poster presentation, they are requested to assemble in their respective posters between 1 and 2 for judgment. Thank you. And posters will be there all day for viewing. So request for everyone to assemble back, and you can bring the tea inside. So welcome back. We are resuming our session. This is an upcoming session, is a panel discussion on pediatric obesity. And to moderate the session, I invite upon Dr. Bharat Ramji, consultant endocrinologist, Arka Center for Hormonal Health, Chennai. He'll moderate the session and introduce the panelists. Thank you.
Good morning, everyone. On behalf of Endocrine Society of Tamil Nadu and Puducherry, I invite everyone for the post-tea break session. So, I think we had nice biscuits, bonda and tea. So, we are going to discuss about a thing which is relevant to the post-tea break session, that is pediatric obesity. And to have the panel discussion on pediatric obesity, we have eminent panelists with us. I invite Dr. P.G. Sundaraman sir, who is a renowned endocrinologist in Chennai, and he needs no introduction to the audience here. I invite Dr. Abhijit Srivastav, who is an Associate Professor of Pediatrics in Lakshmi Narayana Medical College in Pondicherry. I invite Dr. Divya Lakshmi, who is also a renowned pediatric endocrinologist, who is practicing in Sri Ramachandra Medical College and Research Institute in Chennai, Porur. And I invite Dr. Usha Ayagari, an eminent endocrinologist from Chennai. So we are going to discuss about 3 patient scenario. We'll try to keep it as quick as possible because we are a little bit running behind our schedule. Let me start with the first case. So, first patient is a 12-year-old boy. He was brought by mother for excess weight gain since 2020. So, his weight was 58 kgs in 2020 and now he is 73 kgs. And he was diagnosed to have hypothyroidism in 2018, and he is also taking levothyroxine 100 microgram regularly, morning empty stomach. So, when we always take a history now, after pandemic, we are having there is a pandemic of obesity, I would say. It's not, I think we are not getting over the pandemic of COVID and new swine flu and all. There is a combined pandemic of obesity also, especially pediatric obesity, because the psychological impact the lockdown has created for the pediatric population is immense, and a typical scenario of excess screen time, no physical activity, given a separate mobile because everywhere there is online classes and ordering food through apps. So it's a typical thing which we see in Chennai. I don't know about Pondicherry whether you have got so many Swiggies, Zomatos and all. But Chennai, it's a very common scenario. They preferably pizza, sandwiches, they order only late night, like 12 o'clock you order, they'll bring it at 12:30 and they'll start having it. And then using mobile phone for chatting with friends. So father is a diabetic, obese, mother having hypothyroidism, and mother also started gaining weight from the late 30s. The next slide. Sorry. So on examination, his height is 56 centimeters, weight is 73.9, waist circumference is 98 centimeters, BMI is 32.2, extensive acanthosis seen neck, axilla, elbows, and there's no goiter. BP was 106/70. Systemic examination, nothing significant. Testicular volume was 2 ml on each side and stretch penile length was 6 centimeter. So he is in the prepubertal stage. So I want to ask from a pediatric point of view from Dr. Abhijit, what other details would be required to complete the history and examination in a pediatric obesity, and what are the investigations you would like to do in this patient?
Thank you, sir. Good morning, all. Actually, when this question has been put to me, I thought I should put a small approach to pediatric obesity to most of the postgraduates who are here as a pediatrician. So when we start taking history about pediatric obesity, our concern is like what is the cause of that obesity and what are the consequences of that obesity. Next slides. Next, please. So whenever a child with obesity is coming to us, we should first see there are 2 parameters which are very important. That is the linear rate of growth and time of entering into puberty. So when the linear rate of growth is normal or excess and the pubertal development corresponds to the appropriate time, then most of the time the causes are usually familial, which I have put under epigenetics, and or diet induced. So that includes like whether either of the parent is obese or both are obese, maternal preconceptional BMI, or gestational diabetes, or maternal weight gain during pregnancy, or including IUGR, which can be because of the tobacco addiction or alcoholic addiction of the mother. Apart from that, we have other hormonal causes, where you find that the linear growth is minimal, and pubertal entering into the pubertal time is also being delayed. In that condition, we have some 4 or 5 important things to rule out, like growth hormone deficiency. Next slide. Growth hormone deficiency, hypothyroidism, cortical excess, or genetic syndromes like Prader-Willi syndrome. Apart from this, like this is being like the causes we are trying to find out for the obesity. Then what is the effect of obesity on, like what is the consequences, outcome of that one? So we have classified into 3, like one is like adiposopathy, fat mass disease, and quality of life. I have tried to make it very simple as like my capacity. So it is like adiposopathy is like a deposition of adipose tissue and its effect on endocrine and immune system. So we have to rule out like a glucose tolerance, metabolic syndromes, hypertension, like dyslipidemia, things and all. Physical response to fat mass disease is like asthma, immobility, that apnea syndromes, which is because of pressure induced. So these things has to be ruled out. Psychological response is also very important to be taken care of, whether the child is being bullied or there is isolation from the peers, binge eating, late night eating, bulimia. So this is one approach to obese child. We can have some specific system induced focus. Next slide, please. Like here we have like some symptoms and signs, and which we can correlate with the comorbidity. We have like nervous system, in which we see nervousness, school avoidance, or school inhibitions. Then correspondingly we have to keep differential diagnosis in our mind: fatigue, muscle ache, vitamin D deficiency, abdominal pain or indigestion, gastroesophageal reflex. So I'm not telling everything in detail, I'm just trying to tell one approach to the thing. Next one, sir. Regarding examination point of view, hip-waist ratio, strias, skin tags, which will like again correspond to what type of comorbidity is existing, followed by investigations. So investigations in the pediatric obesity is also based on age. So it's been classified as less than 2 years, 2 to 4 years, 5 to 9 years, 10 to 14 years, and more than 14 years. So when we come across a child with 2 to 4 years of age, we do like fasting blood glucose, HbA1c, lipid profile, ALT, AST, and consider vitamin D deficiency. When we are going above 5 years, we are going for sleep associated problems, uric acid problem, liver related problem, and fasting serum insulin, like resistance to be developed against insulin. And beyond 10 years, then only kidney is getting affected, and like consider like type 1, type 2 diabetes or highly sensitive CRP. So this is just, I wanted to put an approach to pediatric obesity for the postgraduates. With this, you can find out what is being deficient in the presentation, what we have been seeing. Thank you.
So we got an idea of how to approach pediatric obesity in terms of history and examination. I want to ask Dr. Divya Lakshmi, how will you define overweight obesity based on the anthropometry in a pediatric population, and how to set a practical or a realistic goal, because we know that a lot of psychosocial issues are playing around with the management of obesity. So how we can set the goals?
Very good afternoon, everyone. Thank you, sir. So I think how to define overweight and obesity, I think for practical purposes, we divide the age group into 0 to 5 years and 5 to 18 years. So 0 to 5 years, it is WHO charts. I would suggest, or the recommended way of doing it will be to use a weight for height or weight for length charts, and the interpretation is given below. I think for want of time, we just, how to define overweight is more than 2 standard deviation from the mean, and obesity is more than 3 standard deviation from the mean. So actually you should be aware, and you should be cautioning the patient if the weight for height crosses more than 1.5 standard deviation, because that is at risk of overweight. I think we need to intervene at that point of time. Next slide, sir. So the interpretation becomes much easier for a 5 to 18 years old, because we use revised Indian Academy of Pediatrics charts, which came out in 2015. And it's very color coded actually. So the orange one says it is overweight, and the red one says it is obesity. And next. The definition used here is the adult BMI cutoff of 23 for overweight and 27 for obesity. Why we use the International Obesity Task Force cutoff, IOTF cutoff, is that the adult equivalent of 23 and 27. Why? Because it is for Asian population, we are at increased risk of metabolic and cardiovascular risk factors, and as well as events, compared to a Western population at a lower BMI. So that is why we have taken the cutoff of IOTF cutoff and adapted to our Indian population. And if you look at the table, so next. And if we look at the table, so there is a separate cutoff that are used. It is no more like 85th percentile for obesity, overweight, and 95th percentile for obesity. So it is different. That is why it is color coded. For postgraduates, if you want to score more marks, you can use this. 71st percentile for boys indicates overweight, and 75th percentile for girls indicates overweight. 90th percentile for boys and 95th percentile for girls indicates obesity. Next slide, sir. So coming to the second part of the question, how to
just this thing. So are you taking waist circumference or waist hip ratio into consideration also, or
yes, sir.
Is it? Yeah.
I think that needs to be mentioned here, because it is one of the, if you look into the IDF criteria for metabolic syndrome, the waist circumference is given the foremost criteria to define metabolic syndrome. And we have pan-India charts available to define waist circumference more than 95th percentile according to age, according to gender. So the chart is available. And so coming to the second part of the question, setting up goal in pediatric obesity. So see, first of all, when you set up a goal, because it is going to be lifelong, first of all, and lifestyle modification has to be multi-pronged: dietary, physical activity, and as well as behavioral. This is where the ecological model of the family becomes very important, the behavioral change. To bring out the behavioral change, it has to be intensive. கொஞ்சம் ஜங்க் ஃபுட்ஸ் சாப்பிட்றத குறைச்சிக்கோங்க, it will be all right. கொஞ்சம் எக்ஸசைஸ் பண்ணுங்க, it will be all right. No, you have to be aggressive and you have to be intensive. And it has to be age appropriate. You cannot ask a 4-year-old, 5-year-old to run for 60 minutes continuously like that. And also it has to be culturally sensitive. என்கிட்ட நிறைய பேர் வந்து ஓட்ஸ் சாப்பிட்டா வெயிட் குறைஞ்சிருமா, bread சாப்பிட்டா வெயிட் குறைஞ்சிருமா? No, you can eat idli dosa also, but you have to adapt to whatever the change. அதுக்காக 5 இட்லி 10 இட்லி சாப்பிட்டா வெயிட் குறையுமா அப்படின்ட்டுனா no, it is not possible.
இந்த கார்ப்ஸே சாப்பிட்றது இல்லை, பிரெட் மட்டும்தான் சாப்பிட்றோம் அப்படின்ற மாதிரி.
So that is one thing. And family centered. So that is what I said, the ecological model of the family. Because if only one person is willing to take the child out for a walking and that person comes home at 10 o'clock in the night, then it becomes a risk factor. So 2 to 7-year-old age group children, we concentrate only on weight maintenance, and more than 7-year-old children, we have to concentrate on weight loss followed by weight maintenance. Next slide. So these are some of the guidelines. I think for want of time, I won't be discussing this fully, but to avoid fast foods, processed foods, avoid taking excess table sugars, sugar-containing beverages, and also people should be aware that, to read the nutritional labeling of food and consume more fiber-containing food like fruits, vegetables, and portion size control education. And many kids nowadays, they are in the habit of, they don't eat properly from morning to evening, and once they come back from home, come back from school in the home, and they constantly graze out eating some or other food, and they even skip sometime dinner also. So this constant grazing throughout the day has to be avoided, and recognize any eating cues, any boredom, sedentary lifestyle. So whatever that is inciting in the child's environment. Next slide, sir. And coming to activities guidelines, so minimum of 20 minutes of moderate to vigorous physical activity in the form of walking, running, doing yoga, swimming, etc. With a goal of 60 minutes per day. Non-academic screen time has to be anywhere between 1 to 2 hours per day, only, not more than that. And also evaluate for psychosocial comorbidities when there is any psychosocial problem is suspected, especially in an adolescent. Next slide. So this is how I counsel my patients. So these are called as SMART goals. See, each the diet can be one goal. There can be multiple goals. Exercise, there can be multiple goals. So how this will be decided is that, you have to create a specific goal. In this scenario, the example that I have taken here is the encouraging physical activity. So specific, how do you want to be physically active? The child will say like, I'll go for cycling, I'll go for walking, something like that. And how will you measure it? So how long and how often are you going to cycle? So it is 30 minutes in the morning or 30 minutes in the evening, and I will do it every day, something like that. And attainable, how will you make sure that you are cycling for 60 minutes a day? I will go along with my mother or father. Realistic, can you do it? Yes, I like cycling. And timely, when you will do it? So I will do it every day. So this is a simple example of how to go with a motivational interviewing or a counseling for a child with obesity. Thank you.
So I think because this patient, mainly from the history itself, we can say that it's simply a nutritional lifestyle related obesity issue, and even if he has a hypothyroidism, his thyroid is very well under control, and he has not landed up with the complications of obesity so far, like dyslipidemia or elevated glucose levels, those things. So probably a lifestyle as described by Dr. Divya Lakshmi, that will be a more practical way of approach and doable thing. Sundaraman sir, what are the clinical markers to decide on whether to do a hormone assay? Because whenever mother brings child for obesity, first thing that is kept in their mind is this is a hormone imbalance. And to dispel that myth that this is not a hormone imbalance, this is purely a lifestyle, for that alone we need to spend at least 1 hour. How will we decide that this patient would require a hormone assay apart from the lifestyle things, and how effectively we can address lifestyle related issues in a post-lockdown scenario? Because children are now, in the last 2-3 years, they have not done anything and they have slowly started picking now. How we can go about it, sir?
Good morning. Thanks for the organizers, especially Dr. Vijay Reddy, for giving me this opportunity. It's very interesting that when we are dealing with obesity, it's important to know whether it is going to be a simple obesity or it is going to be obesity which is secondary some causes. And the first and foremost thing is, has been highlighted, is the anthropometric measurement. If one is lagging by the height, definitely that is going to be an important marker. And also, younger the patient or the child, is going to be obese less than 3 years is more of syndromic in type. So what are the markers that will lead us to do some hormonal test are certain markers. Apart from the anthropometric measurements, you look out for some dysmorphic features. Look out for the mental retardation, deafness, visual abnormalities, hypotonia, and also some of the markers such as the hirsutism, acne, acanthosis nigricans, which is leads on term resistance, especially insulin resistance, or it is going to be a hyperandrogenic situation. And in cases where there is going to be evidences of striae, or there's going to be a central obesity and lacking on the height momentum, definitely one will look out for the excess of cortisol, or it is going to be iatrogenic causes. And one of foremost thing is that we must rule out these causes so that we can do appropriate hormonal study. And very important, these patients especially may have severe headache and produces a symptom of pseudotumor cerebri. So these are some of the markers which will guide us to do the hormonal assay in these patients. Now, how to effectively address the lifestyle related issues is that in the post-COVID, we know that patient physical activity is displaced, and there has been an increased consumption of calories whenever in an idle state. And also the resting thermic energy expenditure is decreased. So they have found out that in the post-lockdown series, there are studies where we are able to have more of the digital viewing, where sedentary habits has increased more than 4.5 hours per day, which is quite commonly seen because most of the children are now being only in the sitting mode and visualize as TV or the cell phone or the iPad. And they have the increased chances of consuming more when they are less active. They consume sugary sweetened drinks and high caloric diet. And very important, the physical activity is decreased. Their physical activity is being more centered to digital activity. And it is also of parenting concern. It is also behavioral and environmental factors. Because we know that when one of the parent is obese, the chances of the child become more than 4 times more becoming obese. And both the parents are obese, it is more than 8 times. So it is also behavioral, environmental, and genetic. So all this put together, these children tend to be obese, and so we must change their activity lifestyle. We must change their eating habits, where consume more of vegetables and fruits, consuming more of the non-nutrient factors, and the importance of not giving them sweetened drinks and more of the corn syrup based diet, and also high fat diet, and asking them to go out and play, or they can play some indoor games which burns the calories, like skipping or stationary jogging. So this must be inculcated from the family side itself. So the parents must be motivated. It must be a counseling for the whole family, because the children cannot follow a diet which the family does not follow. So it must be from the family. So they follow a particular diet, especially during the lockdown period when they have limited constraints, and this they must be advocating from the family. So the child must be taken out by the father and mother for an exercise, and they must sit in a particular time and then only eat. Eat along with the family is very important. Many times they eat during viewing the TV or the digital media. They tend to consume more calories. So ask them to have a time specified eating, and they also inculcate the eating of healthy habits, like the eating of fruits, vegetables, legumes, and less of sweetened drinks which has more calories.
Thank you, sir. Well said. So, Dr. Usha, you are going to follow up this patient serially in the next at least 1 or 2 years till they switch on to another endocrinologist or pediatrician, because they won't be obviously seeing the results. So how are you going to follow up, and in each follow up what are you going to monitor and what are you going to do?
So I think this is really important, and I have to say my colleagues have covered most of the points in what we would do in terms of treatment. But I'm going to talk broadly about the principles and practice rather than drilling down to the specifics. See, if you look at the rates of obesity in children, if you look forwards from 1975 till 2016, you can't argue that genetics has changed. But the rates of obesity in both boys and girls under the age of 18 years have increased 8 times. Boys and girls, 8 times. This is not genetic, this is mostly environmental or epigenetic. There are factors that we need to take into account that then change these environmental factors. Obesity management in children, I'm going to go back to forwards. I'm going to go from most invasive to what is sensible actually. 2 things that haven't been mentioned, so bariatric surgery and surgical interventions. I generally don't put on the table at all in the pediatric population, and that's primarily because they have, I mean, to be honest, in terms of complications post-operatively, they're equivalent to adult surgical outcomes. But if you look at long-term implications in terms of growth, in terms of fertility, in terms of pregnancy outcomes, you do want to be much more cautious in an adolescent that you're thinking in terms of. It is not absolutely contraindicated, but it is literally the very last resort, whereas I might put it on the table much earlier for an adult with obesity. Medication. Again, I'm coming back to forwards. Medication-wise, the only drug that's licensed for management of obesity in some countries but not in India is liraglutide at the 3 milligram dose. There are studies ongoing for semaglutide and for the combination of phentermine topiramate, and results are expected this year, next year kind of scenario. But at present, none of these drugs, including Orlistat, are licensed for management of obesity in the pediatric population in India. Metformin, yes, we do sometimes use off-license, especially in younger children with insulin resistance and dysglycemia. But remember that against a placebo, it gives you approximately a 3% weight loss when you deduct the placebo controlled weight loss. So useful, but not really a major weight loss or weight loss promoting agent. So we come back to the fundamentals, the foundation. It's diet, it's exercise, it's lifestyle modification. Now, when you talk in the pediatric population about diet, as in the adults, you've got to drill down. But there are a few questions, for example, that you need to ask the parents. When you talk about, for example, family fat consumption, oil consumption, the parents will quite frequently say, we don't, but I use ghee for the children. Now, I don't mind what kind of fat. Fat is fat in terms of calories. So I'm not drilling down into would you use cold pressed versus desi ghee versus whatever. Calories are calories. So where a family may perceive themselves as being health conscious, they will still indulge the children. And that's because psychologically they feel good doing it. You need to ask them about treats and rewards, because in our culture, most treats and rewards, especially from the grandparents and parents, are food-based. So show of hands, how many of you have had a celebration in the last 1 month, and how many of those have revolved around food rather than activity? Yes, come on, you're lying if you don't put your hand up. Yes. So why is it not a walk at the beach, or why is it not a session rock climbing? Why is it always a nice restaurant? I like it, so I do it, right?
Hedonic.
So you've got to.
Hedonic things, we are all tuned to that.
Well, the thing is, exercise can be hedonistic because it gives you the same kind of stimulus. But we choose food because culturally and personally, it's an option I like, right? So you need to drill down frequency, types, treats, rewards, right? And as Dr. PJS has mentioned, this kind of mindless eating where we are trying to promote mindfulness. Tell me if I'm running over time, because this is something I can talk about for 2 hours, right? So eating in front of the TV, not eating as a family. putting something as a snack when they're back home from school, sitting in front of some kind of a screen time. Exercise, as you have said very correctly, as Dr. Divya Lakshmi has said, needs to be measured. It's not just go be more active. It has to be tailored to the age group, and remember, children need supervision when they're exercising. So and that's the other thing. I will not do an obesity consultation for a child without both the parents being there. Not just one parent, but both the parents being there, because frequently you'll see that it runs in the family, genetic or not. You need to talk not just about exercise, but about the time they spend sedentary. Not all schools have activity periods now. So it's not just time spent in exercise, but time spent sedentary and time spent in front of screens. I mean, Dr. PJ showed 20 years ago that children who watched 1 hour versus 2 hours of TV time had a risk factor for obesity. So screen time matters, and this was before social media existed, right? Sleep. In the case that you mentioned, sleep was disrupted. And behavioral changes, goal setting, stimulus modification, and self-monitoring. Extremely important. And in the very younger kids, self-monitoring may need to come from the adults. And at the end of the day, when you're managing a young adult or a child with obesity, the hierarchy goes person, family. Young adult goes person, family, but in a child, it goes family. The person doesn't have much autonomy. It goes school and childcare environment, built up environment. If they don't have somewhere to exercise safely, there's no point telling them to ride a bike or go running in the park. Societal. Girls, for example, once they reach puberty, societally get inhibited from going out and exercising. And then policy, government policy. All these need to change for our children to be safe.
I think a lot of things have been said, and I think we as a team should take forward this.
One thing I just want to add. In fact, she is very categorical that the timing is definitely important. We must see to that they do not continuously graze food. We must ask them to have a particular time for food. This can be only with the family and in the dining table. So it is not in the TV room or in the computer room that they're going to eat the food. And I want to know whether how many of you have, apart from this case, which is a case of hypothyroidism, which requires the treatment with thyroxine and the TSH to be reduced much, and to see how effective the dosage is. What is your experience on the use of topiramate? Because a lot of in fact, the bariatric surgery is not much indicated in a pediatric population, and almost the drugs are not indicated. And metformin as such, for a frank obesity, whether it's useful, it's questionable. How far is topiramate used? Because I've used personally topiramate in cases of the childhood obesity. Your opinion, others?
No, I haven't used. I don't. I'm not sure, like it is approved for use in children also for weight loss purposes.
I think it's approved in the US, if I'm not mistaken. It does have approval in the US as a sole drug. It gives you about 4 to 5 kilograms of weight loss, but in personal practice, it's not licensed for use in India, and going into the unlicensed territory in Indian clinical practice is really difficult, especially when you're talking pediatric population. So I'm not using topiramate in India, no.
No, it is not labeled, but it's off-label, where definitely the topiramate decreases the appetite to an extent, and definitely about 3 to 4 kgs are reduced, which I have seen.
Thank you, sir. So we'll move on to the next patient. I think we have talked much about the lifestyle issues. Here, second patient, he was born in 2004 and he came for a first visit in 2015. He was the third child of non-consanguineous parents, normal vaginal delivery, no significant problems till 2 years before. Father was concerned that boy has very protruding abdomen and he is gaining weight but not gaining height in the last 2 years. His height is 116 centimeters and weight is 27 kgs. So you can see that maybe his BMI may not be in the very high category. You can see that there is a very prominent protuberant abdomen for this boy, and you can see the little bit of a cherubic facies also for this boy. And when you see the growth chart, you can see that the height is well below the 3rd centile and weight is at the 25th to 50th centile, and the BMI category he comes at the between the overweight and the obese category. So Dr. Usha, just how should we interpret this anthropometry, and what would you suspect in this kind of a thing where they are in the overweight category but there are some signals?
This, I think Dr. Hemchand has covered extensively today morning. So 30 seconds, where you have a disproportion of height to weight, think pathology. This child has fallen off the charts in terms of his height, gone below the 3rd centile, but is maintaining his weight. This is going to turn out to be some kind of pathological, usually endocrine kind of cause. Given his truncal obesity, recent weight gain, I would suspect, and the moon-like faces, as you said, I would suspect either a Cushing's or the hypothyroidism. You really don't see this much of a disproportionate in height to weight. So I'm thinking more towards the Cushing's. The second question was, what would you suspect? Yes, so endocrine cause certainly, pathological, not physiological, not nutritional, not slowing because of other factors. I'm thinking possibly Cushing's, hypothyroidism slightly lower on the list for me.
So actually in the previous patient itself we were discussing when to go for a hormone assess, because most of the children will be brought to us mainly for the hormone assays or with some hormone reports which will be, we won't be able to interpret that report at all. So these will be the two situations when they come to us. So this patient, we were suspecting Cushing's, and 8 AM cortisol was 22. The ACTH value was 227. I put the normal limits in the quotations, and then the cortisol after giving dexamethasone tablet was 10.5 micrograms. So the glucose, renal functions, electrolytes and liver functions were also normal, thyroid function was also normal. So I will ask Sundaraman sir how to interpret the results and basic tests that we do. Suppose we want to rule out a Cushing's based on the anthropometry and the clinical features, what tests and how to interpret? This is a quick this thing, sir.
Yeah, in fact, as Dr. Usha has told that the diagnosis of this case is going to be Cushing's. And in fact, the commonest causes for the Cushingoid features is going to be iatrogenic in pediatric population, because most of the situations are, they have been given some cortisol drops or by syrups for various respiratory conditions. And that is the most common causes. In fact, the endogenous type of Cushing's, they have shown only about 10% of new cases has been there. So most commonly it's going to be an iatrogenic cause. And in the endogenous Cushing's, if it is less than 7 years, it is mostly of adrenal origin. And more than 7 years, it is extra-adrenal, whether it's going to be pituitary or it's going to be ectopic or other types of Cushing's. And the important biochemical findings that we find is the loss of diurnal rhythm. It is the first and foremost. And there is going to be elevated urinary free cortisol. In fact, we know that the dexamethasone suppression test in adults were the dose that we know, but in the pediatric population, the dexamethasone is to be given in the dosage of 0.3 to 0.5 milligrams per square meter body weight, and to a maximum of 1 milligram. And the cutoff is around 1.8 microns. Here in this case, we know that the post-dexa is 10.5. Definitely it is elevated. And if you're going to measure these, especially you must take in the cognizance whether the child has been using anticonvulsant, rifampicin, amyloglutramide, and in case of severe diabetes or in malnutrition, psychiatric conditions where it can give a false value. And there are instances when we can put them on the indwelling needle and monitor the cortisol in the midnight cortisol. And if the midnight cortisol is more than 4.5 microns per DL, it's suggestive of a Cushing's. And you also have a late night salivary serum cortisol, which can be measured between 11 p.m. to 2 a.m. And the value cutoff is more than 145. nanograms per DL. And if you want to take into the cognizance of the ACTH, they have shown that when the plasma ACTH is more than 29 picograms per ml, in the face of an elevated cortisol is suggestive of Cushing's disease. And the adrenal cause, if it is usually the ACTH is less than 5 picograms per ml, where there is going to be elevated cortisol levels. You do a low dose or a high dose dexamethasone test. The dosage is around 30 micrograms per kg per day, and the high dose is 120 micrograms per kg per day. So these are the various tests that we can perform in the pediatric population. And the inferior petrosal and the peripheral ACTH rise after or before a CRH test is going to be more than 2 and more than 3 respectively. So these are all the various tests which can be done. And very important that we must realize is the elevated urinary free cortisol, loss of the diurnal rhythm, and in the dexamethasone suppression test, the cutoff is less than 1.8. And in these situations, you find all the values are higher, then it is suggestive of an endogenous Cushing's. In an exogenous Cushing, you don't find elevated cortisol level. In fact, it is going to be where you find a Cushing features, but you don't find an elevated urinary free cortisol.
So main thing is to do a cortisol, at least baseline 8 AM cortisol, to rule out exogenous, because that's the most common cause we see. So moving on to the last case, just a brief thing, like a 14-year-old girl, 9th standard student, and she attained menarche at 9 years. Cycles were regular for 2 years. Now she has got irregular cycles, only withdrawal bleeding with the LMP 4 months back, and she has again a weight gain in excess, blackish discoloration, hirsutism, father, mother both having diabetes. Mother had gestational diabetes, and they came with usually they go for a Marshall checkup, they come with a TSH of 5.56, and mother says that because the TSH is high, she is getting so much weight, and because of that only, because she is not getting periods, the weight gain is more. That's what the mother's statement is, and we can see that she is clear-cut on the obese category. BMI is going somewhere way beyond that red line. So examination-wise, we have a higher BMI and hirsutism and the thin pale striae, not like a classic Cushing's, and the systemic examination was normal. So investigations again, borderline pre-diabetes state with the elevated total cholesterol and the testosterone, everything was normal. So just to ask Dr. Divya Lakshmi, though Dr. Nagesh has covered already, the TSH is mildly elevated. So is this the reason for weight gain?
So I would, actually there are two parts of this question. So elevated TSH, I would disagree. And lack of periods, I think this, I think in terms of, the mother's perspective of understanding of PCOS. So that's why I wrote as partially disagree. But see, it's a very interesting and as well as very complex to understand pathogenesis that goes behind this is a textbook description of PCOS case. I don't think like there is any doubt in that. And so the interaction between when you gain weight, you are going to have insulin resistance, you are going to have and then that is going to cause hyperandrogenism in its own complex way. Hyperandrogenism, again, it's going to, decrease the production of LH, and anovulation is going to happen. And, it's like a vicious cycle, and we can, wheels on the bus go round, round like that, it will keep going. So somewhere we have to stop it, and if we make the parents and the child understand this process, they are, much more very compliant to lifestyle modification and weight loss. And TFT, coming to TFT, like 2% of general population in pediatrics will have some subclinical hypothyroidism. And upon follow-up, if they lose weight, they definitely come to the TSH, and the TSH comes to the normal range. And this is a study done by Thomas Rainer from Germany. Not only TSH, including thyroid volume also increases if the BMI increases. And if they lose weight, the thyroid volume and as well as the TSH come back to normal range.
So last question to Dr. Abhijit. How will you approach these issues? Like, what are the basic points that we'll see in a girl with PCOS and what are the long-term implications?
Actually, here three things which should be considered. First thing is to make the parents and the child both understand about the problem, which is actually a very challenging task. To know about it and to come to the parents level to make them understand that, like we had a scenario you said, like because of menses irregularities and values in thyroid, parents are thinking that weight gain is because of that. So whether they should be able to understand, and we should make them understand that these things are because of obesity and not obesity because of these things. So this is totally an individual skills to make them understand. Second thing is regarding PCOS clinical diagnosis and laboratory diagnosis, and to rule out other differential diagnosis for it. So we have a battery of investigations which we do, so which can very easily confirm that it is a case of PCOS. And with respect to the management, the major role is oral contraceptive pills, for which the girl child is also very much concerned regarding the regular menses. And second thing is definitely lifestyle modification. And third thing is, if it is required, metformin. Apart from this, the concern regarding like a subclinical hypothyroid, so already Dr. Shri Nagesh has discussed well. Wait and watch is the best policy. Interval is, like I just put as a take-home message, 3 to 6 months interval. And laboratory parameters and clinical parameters, one should be very watchful. Whichever is corresponding to the thyroid parameters, thyroid profile. Like we know that more, see, first thing is whenever there is doubt regarding like subclinical hypothyroidism and all, first thing is to repeat the investigation. If it 100% you are sure, okay, it is same, then wait and watch. If the value is more than 10, start on treatment. If value is less than 10, wait 3 to 6 months, monitor the child and keep following. Change of lifestyle, weight reduction definitely improves the thyroid profile.
I think the take-home message is like we used to be taught in MBBS that 3 most common reasons for mitral stenosis is rheumatic. So 3 important treatment for pediatric obesity is lifestyle modification, and lifestyle modification. Thank you.
So thank you so much everyone for that enlightening discussion, and we are moving on to the next session, diabetes in children. And to chair the session, I would like to call upon Professor Ashok Kumar Das, Emeritus Professor of Medicine, Mahatma Gandhi Medical College and Research Center, Puducherry, and Dr. Rajiv Soni, Head of the Department Pediatrics, Rajiv Gandhi Government Women and Children Hospital, and to take over the session. Thank you.
Talks of 20 minutes each and 5-minute discussion following each talk, and the topics discussed today are actually assorted topics. The first topic will be on a pediatric diabetes, on a child new onset diabetes, the 10-year-old child, and the second will be something very interesting. Krishna is here. Krishna, I'm not seeing him. Krishna is there. You come to the front, Krishna. So Krishna is going to talk about something very, as usual, he talk about the pain, priorities, and etc., all the P's. And that is Krishna's style. He will be the second talk. With this, I'll hand over the forum to Rajiv, to introduce first speaker.
Good morning, everybody. May I have the pleasure in inviting Dr. Mohan Shenoy. He's a consultant endocrinologist working in Sri Gokulam Medical College and Research Foundation, the Trivandrum. He is the Joint Secretary of IAP Tiruvananthapuram and Joint Secretary of IMM Trivandrum. He is the editorial board member for Thyroid Research and Practice, Indian Journal of Child Health. He is also a reviewer of International Journal of Diabetes in the Developing Countries and IGAM. Recipient of the Nagoji Rao Memorial Gold Medal in MBBS and a scientific secretary in FedEncon 2022 IAP Kerala State Conference of the Endocrine Chapter. He is associated with 10 chapters and has 25 publications in peer-reviewed journals. He is the first author of 2 chapters in ESI Manuals of the Endocrinology, 2nd edition 2015, co-author of ISOC Task Force publication on the pediatric gender incongruence 2020, and has organized multiple endocrine awareness sessions.
So over to Mohan for his talk.
Thank you, sir. So let me just request the organizers to please load the slides. Yeah, thank you. So greetings from Trivandrum, and thank you organizers for having me here. So for the next 20 minutes, I will try to stick to my agenda. I will try to simplify the concepts which we are going to discuss. Adolescence or puberty is like a fragrance of roses. You can see all these beautiful flowers are there. So they have to bloom on time, and they should correctly go in. Do you just next slide? Up. It's not going. So you can move from there only, no problem. So I just, I think one more animation will be there. One more animation. Yeah. So I will just give you a brief, like in a ABCDE approach. Is it working? Yeah. So A will be starting for all algorithms, B basic aspects, C with the how to take a history in the proper approach, then differential diagnosis of these conditions, and some emerging issues which I think we have to discuss regarding heterogeneity. Next slide, please. So diabetes as definition we all know is having multiple etiologies, and it is a metabolic issues with chronic hyperglycemia and disturbance in the carbohydrate, fat and the protein metabolism. And maybe one of the things which acts best is lifestyle measures, but in pediatric diabetes, insulin may be the first choice, and the results are because of defects in the insulin secretion or the action or both. So both of them can be implicated. So let us see a case capsule, a 10-year-old girl coming with excessive thirst, tiredness, thinning, hyperphagia and polyuria. Last 2 weeks, what symptoms they told, it is called hyperosmolar symptoms. The beauty about pediatric diabetes is that this actually come in an acute manner, but we have given treatment correctly, these symptoms gradually reduce. So the glucometer values are high, the lab RBS is 590, urine ketones are 3+. She was stable clinically, though she had vomiting. She was not that much severe in high DKA. The acidosis was only in a mild range. So the family history is very important. As the previous team, we already know that family history of diabetes is important, other etiologies, PCOS is important, obesity is important, heart disease is important. So this context, diabetes is there in the father and the grandmother, onset at 35 years and 50 years respectively. So it's not the father's mother, it is the mother's mother. So both sides we have to take history. So the problem with this case is that last 2 years, the person also had a weight gain, and they thought that actually this weight loss is beneficial for the child. So they did not consult anybody when the weight loss was there. So they are not able to document exact weight loss which happened, but they had told that when the last 2 years prior to this time when she came, there was a weight gain. She told that as usual they tell physical activity was low. She was only weighing around 30 kg at the age of 8 years. She became 40 kg. So normally the BMI has become okay, but now you can see it's 50 kg. So you can see that pre-pubertal stage when you have a weight gain, it can be having components of metabolic syndrome. So this person had evidence of acanthosis nigricans also. Acanthosis is the velvety skin on the neck or the axilla or the foot. So you can see that these conditions can be diagnosed in the community level also. So referred by a general practitioner to the family doctor, later the pediatrician, and finally to the emergency room. So what is the diagnosis in this case? It is a clear-cut case of a type 1 diabetes, except for the acanthosis and the family history. Family history can be there in any case which we take proper history also. So type 1 diabetes, because of the hyperacute presentation with ketosis And when we know this case, usually we give for a test like other tests, we'll rule out other infections. There is evidence of glucotoxicity, there is also mild ketoacidosis, and we know we have to give this is the labs which we did. So we can see in the lab set that the fasting glucose after 1 week had come to 240, the PPBS is 330, and HbA1c, we know it is always in the important range, it's higher side. So in this range, we want to be in the pre-diabetic range of 5.7. So it is definitely more than the range. And you can see the anti-GAD antibody is also elevated. So the GAD antibody is one of the tests we do for the type 1 diabetes and other diabetes also. But we have other tests to do. There is like IA2, insulin antibody 2, islet cell antibody. These tests we do when a workup is necessary. So basically we did these tests. We also did the thyroid test. As any previous discussion we know, we have to rule out secondary causes, and we should ensure that growth is also maintained with thyroid functions. So the C-peptide done, actually we did it when the person was stabilized after 3 weeks. We should not do at the time of the admission or when the time glucose are very high. We should do only when we have given a proper treatment correctly. So this is also coming in the low range. So in this context, we have to give importance to classification. So classification of diabetes in the young or in the new onset is actually very difficult to tell. People will ask you which type it is, which is type 1, type 2. They all know other conditions are also there. So we know this is the easier classification by Patterson et al. We can see here subgroups of monogenic diabetes is also important with the family history. Exocrine pancreas defects, because in Kerala we have also descriptions of fibrocalculous pancreatitis. We should keep all these conditions in mind. Chemical causes, because we are at that time we had a COVID context, we don't know whether the steroids were used. The child did not have a COVID, but I had seen some people with a multi-system inflammatory syndrome. So they had requirement for some other drugs that time. This is a very important classification when we have to identify. So again, back to the discussion classification. Very recently, 3 years back, the revision was done to the original classification, and this is how the current classification holds here. So other specific times have been clubbed together into hybrid forms, and we can see here unclassified forms are also seen in the pediatric classification. So we know that some genetic causes may not have a diagnosis. Some rare conditions can also be diagnosed only by screening them. This is why we should have an index of suspicion for them. So this is the reason why we should manage type 1 diabetes correctly. So the pathophysiology in diabetes, ketoacidosis also can occur because of absolute deficiency of insulin. So stress, infection or insufficient insulin previously known to take, that can definitely affect the axis of growth, and counter-regulatory hormones do not take over, and we can see that there is a other pathophysiology of carbohydrate, fat, lipid, protein, they got deranged. And you can see the end result of hyperosmolarity, increased lactate, osmotic diuresis. This table is very routinely described in the Nelson textbook. So we classify severity of DKA into 3, that is the mild, moderate and severe. We can see here very clearly and succinctly brought out. There is also another type of hyperosmolar non-ketotic coma. It can be occurring in type 1 diabetes, in some type 2, and we can see specifically in the older adults or other, but this can be seen in some pediatric cases with having transient neonatal diabetes also. So neonatal diabetes, we may think it is not to be seen, but we have some childhood case reports where they are diagnosed only by MODY genetic test. This is how we diagnose the hyperosmolar non-hyperketosis syndrome. Yeah. So how do you approach a new onset diabetes in this age? So the first and important thing is the short duration of typical symptoms, then the ketosis present or absent. So accordingly, they are classified into type 1 and type 2. Very simple, you can see. Type 1 has another classification of type 1A and type 1B based on the presence of antibody or not. So again, we can see there is a typical development, insulin requirement is very high initially, and as we know, time comes that other conditions also can interplay. So even the MODY can, that is the maturity onset of diabetes in young, can behave as a in between the type 1 and type 2. So this is why that type 2 is also coming uncovered more in the pediatric age group because of multiple lifestyle factors and other conditions we know. So obesity, as the previous discussions were on there, type 2 diabetes can also be diagnosed in the pediatric age group, and definitely we have so many patients who have actually resolved by themselves. We don't call it remission, they actually resolved by themselves by lifestyle after giving a proper initial treatment. So always think about other comorbidities and other syndromes. We had a case report of H syndrome with multiple other conditions included in that. So this is why we should know the entire classification. So life before the discovery of insulin was very pathetic. So we can see this graphic, insulin has crossed 100 years this year, and we can see before the onset of the insulin therapy, we had people actually collapsing and dying. And this is the first person we can see in this picture, and I know the quiz will be also maybe under this question only. So the initial prescription was on the starvation diet was there, and they had asked them to actually starve to death maybe. So that time we had no other option. Insulin was only available as bovine forms. Last 30 to 35 years we have got recombinant insulins, and now we know that insulin technology has also advanced to give other biosimilar insulins also. So how does insulin work? So insulin is working just like a glucose and a key concept. So when the glucose channel does not work by the receptor block, definitely insulin opens the receptor and unlocks the channel. Last 2 minutes regarding studies being published. So pediatric diabetes, in the COVID pandemic, the proportion of patients in the mild to severe has also changed. So because COVID virus may also have an immunomodification effect. So the reason why complications cannot be screened in these patients may be one of the reasons where they don't come that time correctly. So this was a description where the virus-induced pathology was also proposed. I'll just conclude. So I think type 1 diabetes guidelines are there. I think I found the Canadian guidelines quite interesting, which is why I put this. International pediatric adolescent guidelines are also there, but this describe how we should approach with the family and the team, include them in the development and the profile. So I think the transition to adult care is also important. As the child grows into adolescence, definitely they require proper transition time, which is why we should have a team with the pediatric and adult transition always working together. So summary of these slides is that pediatric diabetes is not uncommon. We know that we celebrate the Diabetes Day and the Child's Day together on the same day in India. And these 3 points will help you to identify the acute presentation. The second one is the workup, how extensive you should do depends on the case. Watch out for the atypical signs and do the genetic test, asking your people around you for the exactly one. I think the last slide will be regarding endocrine awareness, because we are conducting weekly awareness programs. Last July, we had some scare with one of the babas telling about insulin as a myth, we should not use them. Actually, ESI actually took it up, and even other organizations did it. So we should always advocacy for the patients, provide them awareness, tell them to identify the 5 T's like thirst, toilet, the tiredness, the thinning, and the test when required. A simple test like glucometer test can be done in any family which given proper guidance. So to conclude, we should definitely give insulin in the proper person, give the nutrition therapy and individualized physical therapy. Next person will talk about the advances. Definitely the CSII and the CGMS have improved the treatment. Still we should identify glycemic goal as near to 7.5, which is the ideal one in type 1 diabetes. So I just thank you all for the kind listening.
Thank you, Mohan. I think it has been an exemplary talk. Dear friends, you know, the way he discussed the case, there are 3 possibilities. He said type 1 diabetes. He also discussed type 2 diabetes in the young. You know, we have a registry which I chair called DIY registry, not do it yourself, diabetes in the young registry. And we have found the commonest case is type 1 diabetes. 62.9%, 66%, but the second commonest is the type 2 diabetes in the young adolescents, which we discussed. And we have also harmonized those results with the search. We call it search and DIY. You focus search study.
Search
you see
study.
that.
Actually, Indian data, ICMR data was...
ICMR data has been harmonized, and we have found the age of onset of type 2 diabetes in the young can be 12. So 10 and 12, there's a very thin line dividing. So he beautifully discussed that it cannot be possibly type 2 diabetes in the, there are few pointers. Patient has IR features of acromegalicans, child was obese, and he has a strong family history. These are the pointers, but these are the red herrings. The proof of the pudding was the patient was having 600 blood glucose, and ketones were strongly positive, and the C-peptide, stimulated C-peptide was only 0.1. So those pointed, there is a type 1 diabetes. I think he beautifully discussed that. Of course, the small volume of monogenic diabetes, he also discussed from a point of view of Pondicherry pride, the glucokinase gene was described by somebody who belonged to Pondicherry, settled in France, a French by nature, Philippe Frogel, who gave the glucokinase gene, which is one of the type of the Modi. With this, this topic is open for discussion. So we'll
Thank
have
you, sir.
about 3 minutes more for discussion. So any questions, short questions and short answers, Mohan.
Yes, sir. This person on follow-up is doing well. Actually, I did not add the follow-up. Last
doing
3 months, the person's HbA1c is in target.
I believe below 15, please think of type 1 diabetes at any cost. And between 5 and 15. And you also showed the neonatal diabetes, you showed the KCN11J gene.
KCN1.
So that is also one of the priorities in the government of India. We want to diagnose more of neonatal diabetes, both permanent and temporary. And this genetic is available for everybody to send cases, and we do that. They also respond to sulfonylurea, as you rightly point. Brilliant talk, Mohan.
Thank you, sir.
Brilliant. Now, please ask some questions. Without that, it will go.
Yeah.
Please, we have 2.5 minutes more. Any comments? And you know, the four most important that if you would have concentrated, I say that to Sini. Sini is my friend, you know, so if we have concentrated on the children from 1947, we would have different nation. We didn't concentrate. So today we have been a different nation. So the pediatrics, diabetes, pediatric endocrinology has not gone much feasibility. And you know, we tried to compile pediatric diabetes. We found a lot of scope in India for the pediatric diabetes. Now, the question I would like him to answer for the benefit of the audience is that, you know, how often do you find Mohan in your practice? I have seen Mohan's hospital. I know his friend who is the director, Manoj. So how often you find type 2 diabetes in the young people nowadays?
It's actually increasing, sir. The registry is not there in both conditions.
Yeah.
But I think definitely it's increasing last many years. Maybe because of screening has been diagnosed.
Yeah.
But I think digital era is very important. So people don't want to walk outside. They are not using the proper lifestyle measures. But I think multiple factors are there still.
Okay, second short question.
Yeah.
That, you know, type 2 diabetes in the young is described as a malignant, quote unquote, malignant diabetes.
Yeah.
Why and how do you take care of it?
So this problem is because the community, it actually goes in. So they just told it infectious like etiology. It is not infectious, but the problem is one person having type 2 diabetes in the young, definitely the family also does not know, and they will also do the same thing. They propagate the same problem. And basically the problem continues with the generation also. And the trans generation also it progresses, because gestational diabetes in the mother, they may not be properly monitored. That can be the reason for the diabetes in that woman in the future. And their children have an earlier onset of diabetes.
Yeah, so actually Nikhil has written that paper on behalf of the DIR, what Mohan is speaking. Now this type 2 diabetes in children, you cannot brush aside. They get maximum complications in the kidneys and in the heart and at a young age, and also produce, their prodigy also develops type 2 diabetes. Therefore, they are quote unquote malignant type 2 diabetes. Ordinary type 2 is also malignant. Don't think that adult diabetes is not. But compared to that, the type 2 diabetes in children is absolutely malignant, and
they have to live with it for longer time. Once they diagnose, they live it with longer time.
They live longer today, and their blood vessels bath in the syrupy blood for a very long time. So complications more. Last two questions to person from the God's own country. Yes, Doctor.
Good morning, sir.
Kaveri, come on. Short question.
Yes, sir. Morning, Dr. Sara Madam told that they are going to make it mandatory. Of course, not in government, but in all private hospitals, they are doing search for congenital hypothyroids. Like that, why should we not do it for in school health?
Yes,
Government
yes.
should go and teach the children to come out of this malignant syndrome. But
Yeah.
It's a simple test by doing a GMR.
Yeah.
Another thing is, why should we not have more of health education to start from first
Yeah.
standard to 10?
Point well taken, ma'am. Because school education is very important.
Population, and that is going
Yeah.
to be the major way of decreasing
RSSD actually took it up as a defeat diabetes also, when program was there.
chairperson for WDW and Pink Vision sector.
Yeah, I think what Kaveri says is important. Yeah.
I have a plan of covering 84 schools by
Correct. I think school health checkup and looking at the weight.
I want more people. I want more people who will
it is a
help me
good-
also in that,
laudable,
and big
laudable.
policy makers like you who
Laudable
will
effort.
recommend to the
I
government.
just want to add that Kerala is another place where we are taken it up forward. That is a Mithai program, which you all know. It is a government-sponsored program. They are giving pumps, not the very easy pumps. They are giving the ordinary, older type pumps. But definitely they are also giving other insulins also free of cost, and they are giving even CGMS monitoring. They are giving all these things. And they are also providing more education in the community level. Even the school, in the exam writing period, they want to go for a loo that time. Even that has been considered and given, I think, in the government
Mohan,
program.
thank you very much, because I have to be conscious of time.
Yes, sir.
The last question I want to ask, because you are from Kerala, the God's own country. You know, what has happened to pancreatic diabetes? It is still there, it has come down, disappeared. What has happened?
It's like a mirage, sir. It's actually coming up and coming down. We don't know what has happened, because Givargis et al. Was the first person who took it up.
We know Dr.
And
Varghese.
later on, Balakrishnan sir took. Last several years, I think the gastroenterologists and endocrinologists have got they are not still identified, but only important point is that they will require pancreatic enzyme replacement, very important for them, for the growth to be ensured correctly.
Thank you very much. Big hand for Mohan, and thank you very much. We have discussed all aspects of pancreatic diabetes. Over to Rajiv.
Actually, of late, means yesterday itself, I came across one case in my hospital. The case was admitted only for loss of, means weakness only, not even loss of weight, only weakness, a 8-year-old girl. Yesterday, when we were actually taking rounds in the ward, just one of my PG and also I was actually thinking that why not to take the blood sugar, though there was no history of polyphagia, polydipsia, polyuria. And by 1 o'clock we were surprised that the blood sugar was 490 and there was no ketones. So without ketones, blood and only complaint is weakness, we should be suspecting diabetes as one of the differential factors.
I think Rajiv, therefore we have said today, like pulse, BP, PG sir is here. Sir, we have said like pulse, BP, temperature, respiration. The fifth vital sign is blood glucose. That's what Kaveri is speaking, Sar is speaking. So if you do blood glucose in everybody, it's the fifth vital sign. And Nitin, what do you think? It is important. Pulse, BP, temperature, respiration, blood glucose is a must. Dear friends, with this comment, I'll request Rajiv sir to invite the second very, very phenomenal. His appearance is my younger brother. I can't think anything about him. Krishna, please walk up to the dais.
May I have the pleasure? May I have the pleasure to introduce Dr. Krishnan Swaminathan, MD, PhD, FRCS. He is a consultant endocrinologist. He is associated with Madhuram Diabetes and Thyroid Centers, and he has got 75 publications. So over to you.
His basic difference that he is different. And in the various forums, whether it is Muruganathan's Hold Forum or whether it is the insecticide forum, whether it is doing something really for the type 1 diabetics forum, Krishna has distinguished himself. Over to Krishna for the talk. The title of the talk it was The Pain, the Priorities and the Progress in Type 1 Diabetes. Over to Krishna.
அனைவருக்கும் பணிவான மதிய வணக்கங்கள். Good afternoon everyone. அருமையான தமிழா இல்லை சுமாரான இங்கிலீஷா? தமிழ் எல்லாருக்கும் தெரியுமா? எல்லாருக்கும் தெரியும். ஸோ அப்படி கலந்து அடிக்கலாமா? First of all, it's such a privilege to have a legend here, Professor A.K. Das. Thank you very much for chairing this, and Professor Rajiv, today I met him. And Vijay Bhaskar is a brother to me. Thank you for the invitation. அடுத்த 20 minutes வந்து it's going to be very low on science. இந்த ஸ்டடி அது இதெல்லாம் பேச போகிறதில்ல. நான் இந்த டைப் 1 டயபிட்டிஸோட வலி என்னவென்று தெரிய வேண்டும். நமக்கு அது தெரிய மாட்டேங்குது. எப்படி சாரி ஸ்லைட் மூவ்மெண்ட் எதுங்க? சாரி அப்படியே மாத்துறீங்களா? ஓகே. இன் ஃப்ரண்டா இங்கே? Yeah. So for the next 15-20 minutes, what is the pain of telling a parent that their son or daughter has type 1 diabetes? What is the mental, social and financial strain? What are the priorities? What is the blatant truth that's happening in India at this point of time? ஒரு அரசாங்க மருத்துவமனைக்கு போனோன்னா ஒரு டைப் 1 குழந்தை இருந்தால் என்ன நடக்குது? And what are the priorities that we have to change? And I'm giving this presentation because we all need to be the change that we want to see in India. நம்ம அரசாங்கத்தை குறை சொல்லிக்கிட்டு இது கிடைக்கல அதை கிடைக்கலன்னு சொல்கிறத விட what can we do as individuals and as a team to change the landscape of type 1 diabetes in India? and the Coimbatore model of Idhengal Charitable Trust, what little work we have done over the last 5 years to try and make a change. So before I start anything, I want to thank all the children and their families. எனக்கு ஒரு கஷ்டமான நேரத்தில் ஒரு புகைப்படம் எடுப்பது ரொம்ப ரொம்ப கஷ்டம். So they still allow us to present photographs. Even at their deathbed, we are just so humbled by the opportunity that families give to us. இப்போ வலி வந்து எனக்கு எம்டி சீட்டு கிடைக்கல, டிஎம் சீட் கிடைக்கல, ப்ரொஃபஸர் கிடைக்கல, இந்த பக்கத்து டாக்டர் மாதிரி மெர்சிடிஸ் பென்ஸ் இல்லைங்கிறது கிடையாது. The pain today is to tell a parent that their son or daughter is dead. And இது அன்றாடம் பண்ணிட்டு இருக்கேன். இப்போ now I've got close to 800 children with type 1 diabetes. We are one of the largest units in our part of the world. And இந்த பொண்ணு ஸ்னேஹா, என்னோட பொண்ணு பேரும் ஸ்னேஹா, this girl died 6 months ago holding her hand for want of best treatment that a rich person or someone in a western country can get and take it for granted. ஒரு 10,000 சம்பளம் வாங்குற ஒரு அப்பா அம்மாக்கு 7,000 ரூபாய்க்கு இன்சுலின் எழுதி கொடுத்தா எப்படி வாங்குவாங்கல்ல? ஒரு கவர்மெண்ட் ஹாஸ்பிட்டலில் போனோன்னா வயல் சிரிஞ்ச் இருக்குது. 70% of households don't have a fridge in their home. And in the மண்பானையில் வைக்கிறது இதெல்லாம் there's absolute rubbish and waste of time. இது வந்து summer temperature all the insulin gets degraded completely to the extent that we see children on 120 units of insulin per day with glucose of 500, 600 and 15 admissions with DKA. This is what is happening. And அந்த அம்மா குழந்தை இறந்த பொழுது ஒன்னே ஒன்று ரூம்க்கு வந்து அப்படியே tears streaming in her eyes. ஐயா இறைவன்கிட்ட ஒரே ஒரு வரம் கேட்கணும், கேளுங்கம்மா, என் பொண்ணை சீக்கிரம் அழைச்சிட்டு போயிட சொல்லுங்க, இந்த வலி வேண்டாம், end stage kidney failure 3 வருடங்களாக குத்தி எடுத்தாச்சு இந்த குழந்தைய, சீக்கிரம் போகணுங்கிறது ஒரு அம்மாவுடைய வேண்டுதல். And we are allowing this to happen. We are sending rockets to the moon, but we are allowing a poor child with type 1 diabetes to go home dead. For what now? For want of best treatment, which would cost 5,000 rupees per month. So இது வந்து நான் ஸ்காட்லாண்ட்லேருந்து மதுரைக்கு வந்தேன். And I just think that the Almighty Lord Meenakshi has got me to Madurai of all places. I'm not a native of Madurai. And இந்த கதையை நான் 1000 times சொல்லிருப்பேன். I get goose flesh every time I tell this story. அப்போலோ மதுரையில் இருக்கும்பொழுது ஒரு ஈவினிங் 5:30 I'm going home and this boy Arjun was brought with cardiac arrest. And அங்கே வந்து அரசாங்க மருத்துவமனையில் he was declared glucose is more than 800 for want of 3 days lack of money to buy the insulin. ஆனால் அந்த பேரண்ட்ஸ்க்கு அவேர்னஸ் இல்லை, இன்சுலின் நிறுத்தினா டிகேக்கு போகும்னு. And இந்த அம்மா, this mother is taking this boy in an auto rickshaw on a dead boy for his final rites, and they cross to Apollo emergency, and I keep thinking that the Lord Meenakshi was in the auto. அந்த அம்மாக்கு திடீர்னு ஒரு intuition, பின்னாடி இருக்காங்க அவங்க, she says get the auto into emergency. And a cardiac arrest call, monitor potana, the boy was in pericardiac arrest, he was not completely stopped it. So we resuscitated him, got him to ICU on my name, and on his 8th birthday 2 days later he recovered completely. And in the photo vandu oru pasmara thani pol irukum photo idu, on a dead boy just sitting up, and we decked the ICU with balloons, and on that day the whole pediatric ICU every child got better for whatever reason. And panathal vaanga mudiyadadu innum maruthvathil nariya irukku. So for young PGs listening to this talk, what am I getting out of it nu nenikadinga. So money is important, but at this age you start thinking that if I can't do it, no one will do it. And panathal vaanga mudiyadunum nariya irukku. Indha paiyan every Jan 31st on his birthday he sends this present to my daughter. Innu ஏழ்மையில இருக்கான், கை காசுலாம் சேர்த்து last year on the present every Jan 31st. So there are things that money still can't buy. எங்க இது என்னங்க இது? Okay, so this is what is happening. இப்போ எங்ககிட்ட இருக்கிறது எல்லாமே rural underprivileged families. In the COVID time, there's zero salaries for a lot of laborers. You understand how difficult it is? The cost of earning is around 10,000 ரூபாய் ஒரு மாசத்துக்கு. ஒரு அனலாக் இன்சுலின் நம்ம கொடுத்தோம்னா ஈஸியாக 3,000 to 5,000 ஆகும். இது கூட குளுக்கோமீட்டர். அண்ட் குழந்தைங்க they have to check at least 2 or 3 times a day if we are going to make some sense of it. Along with needles, இதெல்லாம் பார்த்தோன்னா 5,000, 6,000 வரும். ஒரு டிகேஏ வந்துச்சுன்னா ஒரு அரசாங்க ஆஸ்பத்திரியில் போனோன்னா how good systems are depends on the local hospital. If not, the child is gone. If they come to a corporate hospital, it costs minimum 1 to 1.5 lakhs. And அவன் வந்து 10 வட்டி கடன் வாங்கணும் அதை அடைக்கிறதுக்கு. And this will keep on happening again and again to the extent that parents give up at some point. போனா போதும்னு நினைக்கிறாங்க. And you know what happens with kidney failure? That's 7 lakhs a month. What is happening in state hospitals? Again, I've met Ma Subramaniam Ayya 2 weeks ago, our health minister, and he's promised to take this up further. In most of the units, there's no dedicated type 1 diabetes clinic. It's just a general clinic, and there's no one who's got a special interest in type 1 dealing with that. Insulin is given mostly in glass vials and syringes, and I know the NHM is giving it through pen devices. Madurai is doing it, MMC is doing it, but not in any other centers. Cold chain storage of insulin is a big question mark. In the COVID nerlam, we went to a lot of government hospitals. It's not even in the fridge. And 60% of rural families don't possess a fridge. No glucometers. The cost of testing is very high, and very high morbidity and mortality. Most, if not all, children will die by 15 to 20 years of age with end-stage kidney failure or some decay. So what is happening in a private setup? A huge cost of investigations. Patient பயப்படுறான் உள்ள வரதுக்கு. உள்ள ஒரு கார்ப்பரேட் ஹாஸ்பிட்டல் இப்போ வந்தா 10,000 ரூபாய் குறைஞ்சு வெளில போக முடியாதுங்கிற மினிமம் இன்வெஸ்டிகேஷன்ஸ்க்கு. Huge prescription of analog insulin beyond poor man's finances. நம்ம கேட்க மாட்டேன்றோம், உங்க மாத வருமானம் என்ன என்று நம்ம ஒரு தாய் தந்தையிடம் கேட்க மாட்டேன்றோம். And minimal time, because there's a huge chunk of 100 type 2 patients waiting. For one type 1 child, it takes 30 to 45 minutes, and we can't spare the time on that. And it's not sustainable for poor families. So on this side is the doctor attitude. If a poor type 1 comes, doctor என்ன நினைக்கிறார்னா இது எப்படியும் ஒன்றும் பண்ண முடியாது, இந்த குழந்தை போதான் போகுது, என்னால் எவ்வளவுதான் பண்ண முடியும், nothing can be done. ஏதோ ஒரு insulin, and usually it's a BD mixed out insulin, which is never going to work in a child, and more trouble for me. And if an insulin pump, it's so much advanced, but medical profession is not catching up with the technology. So insulin pump பத்தி தெரியலனா அது மோசம், இந்தியாக்கு இது சூட் இல்லைன்னு நம்ம சொல்லிடுறோம். Whereas the reverse is true. Patients said they are absolutely depressed. They think that the child is not going to survive for too long. What is the long-term future finances? And the difficult GMT ன்னு சொல்றேன், தீவிரவாதிகள் என்று சொல்லப்படும் சொந்தக்காரர்கள். இந்த குட் மைண்டட் டெரரிஸ்ட்னு சொல்றோம் நாங்க. ஒருத்தரை நல்லாவே இருக்க விட மாட்டாங்க நம்ம ஆளுங்க. எனக்கு இங்க வா அங்க வா, ஆயுர்வேதம் தெரியும், ஹோமியோபதி தெரியும்னு ஒழுங்கா போடுற இன்சுலின் நிறுத்துவாங்க நம்ம ஆளுங்க. ஸோ 3 டாக்டர் சொல்லுவேன், வாட்ஸ்அப் டாக்டர்கள், கூகுள் டாக்டர்கள், தீவிரவாதிகள் என்று சொல்லப்படும் பக்கத்து வீட்டுக்காரனும் சொந்தக்காரனும். பட் பேஷண்ட்ஸ் அதான் கேட்குறாங்க இப்போ. So what are the focus areas in which you and me can make a difference? First, immediate thing is insulin and consumables. We need some pen insulins with analog insulins given by government hospitals across the board. Now, one ரெண்டு இடம் சொல்ல. Health insurance கொடுக்கணும். ஒவ்வொரு குழந்தைக்கும் ஒரு 2 lakh health insurance cover கொடுக்கணும். Insulin pump therapy மாதிரி technology should reach the poorest of poor. பணக்கார மட்டும் ஐஃபோனை வச்சு புண்ணியம் இல்லைன்ற. இது ஒரு ஏழைக்கு போகணும், அங்கே ஒரு மாற்றம் வர வேண்டும். ஒரு ஃப்ரிட்ஜ் இல்லாமல் பல குழந்தைகள் இறந்து போவதை பார்க்கிறோம். இப்போ இதயங்கள் ட்ரஸ்ட் வழியாக 400 ஃப்ரிட்ஜ் சப்போர்ட் பண்ணிருக்கோம். எங்கள் ஃபர்ஸ்ட் கேள்வியே ஃப்ரிட்ஜ் இருக்கா இல்லையா, இல்லைனா நெக்ஸ்ட் டே ஃப்ரிட்ஜ் கோஸ் ஹோம். எஜுகேஷனல் சப்போர்ட் ஃபார் கேர்ள்ஸ். இன்னைக்கு ஒரு பெண் குழந்தை ஒரு கிராமத்தில் இருந்துச்சுன்னா, இன்சுலினில் இருந்துச்சுன்னா, படிப்போ கல்யாணமோ பயங்கர டிஸ்கிரிமினேஷன். And most of these girls don't survive because they are on insulin. So if you give education to girls with type 1 diabetes and help them with placement, then it makes a complete change. இப்போ 20 கல்யாணத்துக்கு போயிட்டோம் இந்த 1 year மட்டும். And we've delivered so many girls with type 1 diabetes, meaning that they are no different to any other person. And இது எங்களால் மட்டும் பண்ண முடியாது. It needs ministry level intervention, and we need an exit strategy. கொடுத்துட்டே இருக்க முடியாது. How to come off it, and we need advanced research to know why this is happening. So we started the Idengal Charitable Trust. I believe every single doctor should have a trust with a very golden aim of what you want to do in your area. It's amazing how much power we have to harness either corporate social responsibility money or pharmaceutical funding to a very good cause. நாங்கள் வந்து ஒரு 10 குழந்தைங்களோட ஒரு 5,000 ரூபாய் என்னோட பணத்தை போட்டு 2017 we started Idengal Charitable Trust, and இப்போ கிட்டத்தட்ட 8 government hospitals across the state we have adopted. கோயம்புத்தூர் GH, சேலம், இப்போ திருநெல்வேலி, கன்னியாகுமரி போகிறோம், தஞ்சாவூர், திருப்பூர், எல்லா கவர்மெண்ட் ஹாஸ்பிட்டல்ஸும் we are adopting. This child lost her eye because of fungal sinusitis with severe DKA, but doing extremely well on basal bolus insulin, and suddenly the parents do have a hope. And இப்போ இது ரீசெண்டாக வந்த குழந்தை glucose is more than 600 with severe DKA, and just giving இந்த குழந்தைக்கு இந்த சிரிஞ்சில் போட்டால் ஓடும் குழந்தை. இன்சுலினே கொடுக்க முடியாது அந்த அம்மாவுக்கு 3-4 times. whereas இப்போ இந்த 4 mm அல்ட்ராஃபைன் நீடில் அம்மா எனக்கு இன்சுலின் போடுமா, நான் போய் விளையாட்டு வரேன்னு சொல்லி இப்போ காமிச்சிட்டு போகிறாங்க. ஸோ அந்த பையன் just 2-year-old, all doing extremely well on some of the best insulins that rich people could get. And Idengal Trust வழியா, this is a game changer. We are providing the best glucometer along with 90 strips per month per child till 25 years of age. So it's a huge project going on, and suddenly children can check their glucose and report back to us. And the Project Lifeline, in fact, Coimbatore collector inaugurated this project, ஒரு குழந்தைய பார்க்கறதுக்கு 5,000 rupees வேணும். இது நிறைய பேர் ஒரு பர்த்டே பார்ட்டி நம்ம ஒரு கேக்கை கட் பண்ணால் 5,000 ரூபாய் கிடைக்குன்ற. So I think as doctors we can connect with ourselves, our people to try and do this. So currently we are supporting around 700 poor children with type 1 diabetes, all analog insulin and pen fill cartridges, 4 millimeter needles, and free glucometer with 50 to 90 strips per month. So அடுத்தது health insurance. So if even a rich child has type 1 diabetes, insurance is rejected in India. எனக்கு it's a high risk of admission. So Star Health oda medical director is my senior at MMC. அப்புறம் நான் அவர்கிட்ட Dr. Prakash, I talked to him, I said, sir, please do something for this. So இதயங்கள் ட்ரஸ்ட்டுக்கு they waived off all pre-existing conditions. So இப்போ எங்களோட எல்லா type 1 குழந்தைங்களும் they have a 2 lakh Star Health insurance card. So that any DK, anywhere in the country, they can get admitted without paying anything. So in the ponnu, in fact, she came in with severe DK and cerebral edema, and she lived to tell the tale because of the Star Health insurance card. And she was able to come to a corporate hospital to get it done. So next one was the pump. Insulin pump, I want again youngsters, PGs to be more aware of pump therapy, because I've had patients telling in the Indian whether a pump is suitable kadiyadu, idu panandam panakaran dhaan podnu, adella rubbish ngra. In our most rural poorest children do much better on pumps than the richest kid in town. And we have got around 220 children on insulin pumps from the poor families. We are one of the largest program in the world for rural underprivileged. And these are all our girls, especially girls with type 1 diabetes, we fast track them to the pump program. This is 1.7 lakhs per pump with 10,000 rupees per month is the running cost. And the trust is able to support all our children. In the Punna Swati, 15 admissions with DK at Coimbatore GH. And literally given up, and on pump therapy, just completely life transformed. Suddenly injections say kadeyadu, 4 days once tube matna podum. And we have published our work as well in IJM 2019. If a 50 patient project we are publishing now, just goes to say that we are seeing a 3% reduction in HbA1c. Are you back, Laporna? And this is the photo of the year. She has no parents. இவ்வளவுதான் வீடே 2 தட்டி இருக்கு அவ்வளவுதான். And ஒரு cousin வீட்ல ஒண்டிட்டு இருக்கு இந்த பொண்ணு. Now she's been educated through இதயங்கள். She's placed in Roots group of companies and doing extremely well on insulin pump. But எங்களோட most rewarding thing is this photograph. இது என்னோட கம்ப்யூட்டர் ஸ்க்ரீனில் எப்போவுமே வச்சுப்பேன். Why are we doing this work? இவங்களாம் 7-8 yearsலேருந்து type 1 diabetes across Tamil Nadu state from very rural underprivileged areas, now educated, placed, getting married and bringing their sons and daughters to us. And I think this is where we can make a transformational change, and it's a fight back. So this is not a very scientific study, but 43 DK admissions have come down to 1. 513 total hypos have come down to 45, and 43 severe hypos have come down to 2. It's under review for publication. And we have adopted Madras Medical College as well. That's where I studied. So we've started the pump program in MMC. And sitting in Coimbatore, I can harness the 24-hour levels sitting in the comfort of our office. So we use heavily sensor technology. So all our less than 5-year-old children are on AGP continuously till they finish 5 years of age. And again, the குழந்தை 4 தடவை 5 தடவை குத்தணும். நிறைய parents don't sleep at night for fear of severe hypoglycemic seizures. So சென்சரை மாட்டி விட்டுனா 2 மணிக்கு அம்மா போய் ஜஸ்ட் இதை பார்த்துட்டா கூட போதும். So this costs around 10,000 per month for the trust. இது எங்க எவ்வளோ மோசமாக இருக்கு. And fridge program, இப்போ இது ஒரு கூரையில் இருக்குது இந்த பொண்ணு ரம்யான்னு சொல்லிட்டு severe DKA because they didn't have a fridge and they were keeping the insulin close to the heat source. கிச்சனில் வீடே அவ்வளோதான் இருக்குது. அண்ட் அம்மா அப்பா கிடையாது, பாட்டி தான் பார்க்குறாங்க. அண்ட் all we did was to get a fridge to the next door shop. எனக்கு அவங்க கோக்கெல்லாம் வைக்கணும்னாங்க, நீ அதை வச்சுக்கோ என் குழந்தைக்கு இன்சுலினை வை அப்படின்னு சொல்லிட்டு again we educated the family and complete transformation. And in the Godrej kuda we worked R&D with Godrej. This is the new fridge that Godrej has released with our input over the last 2 years. Idu vandu 2,500 rupees idu engalukku kedaikudhu. You just need to plug it and it maintains between 2 to 8 degrees centigrade. So you can keep at least 10 to 15 cartridges or around 6 to 7 vials in this. So this is a fridge program. And we are not going to let down our daughters. We're not going to let down our own daughters. So huge educational program for all type 1 girls, especially from +1, +2 onwards to college and placement. The Rolls-Royce is a big partner with this. They give a big funding for us to educate girls especially. And on top of it, when the placement support, Anubharati, she did her teacher training. And முதல் salary இந்த குழந்தைக்கு வருது 6,000 ரூபாய். அதை கொண்டு வந்து சார் ட்ரஸ்ட்டுக்கு நீங்கள் வச்சுக்கோங்க சார் அப்படிங்குது. And that is what we want. We want these children to grow up and give back to the society what they got. And nearly done. So this was pre-COVID, able to meet Dr. Harshavardhan, but we are moving at a PMO level as well as state level. We have met the NHM director, and Idengal is now the official partner for National Health Mission Tamil Nadu to lead the Type 1 program across government hospitals here. And we are very happy that our district collector took a big interest. He's a doctor, Dr. Samiran from, he's in Coimbatore now, but he has taken a big interest to try and push the Type 1 program to the health ministry. And அடுத்தது வந்து இந்த பெட்டர் டு டீச் ஹவு டு கேட்ச் அ ஃபிஷ் தேன் டு கிவ் அ ஃபிஷ். அதான் நம்ம எத்தனை நாள் தான் 3000-5000 தந்துக்கிட்டே இருக்க முடியும்ல. இஃப் ஐ எம் நாட் ஹியர் டுடே, God willing, these children have a very long way to go. So we are rehabilitating the mothers of poor children with type 1 diabetes. அதனால் இப்போ இந்த கறவை மாடு cow donation program is going big. நான் இப்போ அருமையான மாட்டு broker ஆகிட்டேன். இப்போ தமிழ்நாடு முழுக்க எனக்கு தான் கால் வருது மாடுக்கு. இப்போ எது ஜெர்சி மாடு, எது நாட்டு மாடு, எவ்வளோ லிட்டர் கறக்கலாம் எனக்கு தெரியும். அண்ட் அவனே ஆடி போகிறான் அந்த மாட்டுக்காரனே, சரி இவ்வளோ தெரியுமா டாக்டர்னு சொல்கிறீங்களேன்னு. ஸோ இப்போ வந்து 30 cows இப்போ டொனேட் பண்ணிருக்கோம் at a cost of 50,000 rupees per cow, but it's earning these families 8,500 rupees per month. So now they're able to buy their own insulins, and அவங்க சொல்கிறாங்க சார் இன்னொரு குழந்தைக்கு வச்சுக்கோங்க அப்படிங்கிறாங்க. ஸோ பட் திஸ் a huge program going on. ஸோ இதெல்லாம் தான் cows across our state, but it brings a lot of goodness to the home as well. Sudden ஒரு positivity வருது. And our sewing machine program in Coimbatore districts is going very big. So we are educating and teaching all mothers to, and ஒரு 50 sewing machine வாங்கி தந்திருக்கோம். ஒரு ஜாக்கெட் தைச்சா 250 ரூபாய் கிடைக்கும். They can just see their child as well at home and do this, and ஒரு 3,000-5,000 rupees வரும். Nearly done. So we are now actively collaborating with IIT Madras, looking at environmental risk factors in type 1 diabetes. We think that something is going on in the environment, whether it's pesticides, heavy metals. Coimbatore to Salem is very big, type 1 diabetes. And Delta districts, Tanjore, Kumbakonam area, so we are looking at pesticides, heavy metals and industrial waste. And we are adopting, our dream is to cover from Chennai to Kanyakumari. And on top of it, we are supporting Kerala till Palghat districts, Karnataka and Maharashtra as well. And we have started the mobile rural diabetes initiative. So these are all our GH children. We go there every 3 months. We have an Afrin HbA1c machine. So we test that every 3 months, and unless they do well, we don't extend the insulin. So we have a bottleneck. We look at the glucometer memory, the HbA1c before we do it, and 24/7 telephone support. இப்போ டாக்டர்ஸ்லாம் ஃபோன் நம்பரை கொடுக்க மாட்டேன்றோம்ல, எல்லாம் பயப்படுறோம். எங்களோட 700 குழந்தைங்களுக்கு எங்களோட எல்லா நம்பரும் இருக்குது. நைட் 1 மணி 2 மணி கால் வந்துகிட்டே இருக்கும். But I believe we have to do it to try and prevent major admissions from happening. So just to finish it, another 1 minute to go. So 700 underprivileged children, and we have got another 500 on the waiting list to do. We give analog insulin, insulin pump, consumables, annual insurance cover, girls' education, fridges and whatnot. And we are seeing a more than 95% reduction in hospitalization for DKA across all government hospitals that we have adopted, and a 3% reduction in HbA1c on an average. So all I'm asking you is kindly be a part of our work. So if you are in your area where you see a poor child with type 1 diabetes, we are just at the end of a phone, call me anytime. And we cover the entire nation now. All it needs is a phone call. And I just want to finish with this last slide with Ramurthy sir. He's a 95-year-old youngster from Hosur. ஒரு few months முன்னாடி he called me, Swami, உங்கள் ஒர்க்கை பற்றி கேள்விப்பட்டிருக்கேன். I can't travel to Coimbatore. Can you travel to Hosur and see me? I want to give a small donation. ஸோ ஆன் அ சண்டே மார்னிங் நல்ல சரணபவனில் ஒரு கட்டிட்டு நாங்கள் ஜாலியாக ஹொசூருக்கு போயிட்டு இந்த பெரியவரை பார்த்து ஆசீர்வாதம் வாங்கினோம். ஒரு 5 minutes, very sharp. He asked about the work we did. He asked his wife to bring the checkbook, and he wrote, a retired pensioner wrote a check for 4.5 lakhs. And நான் அந்த நேரம் வந்து இவர் கொடுக்குற 5,000 எப்படி நம்ம செலவு பண்ணுறது அப்படின்னு நினச்சிட்டு இருந்தேன். 4.5 lakhs. I couldn't speak. Tears were coming out of my eyes. And நான் டோரை விட்டு வெளில வரும்பொழுது அவர் வந்தார். சுவாமிநாதன் சார், ஒன்று கேட்கலாமா சார்? நீங்கள் சொல்லுங்கள் சார், ஜாதி மத பேதம் பார்க்காமல் எல்லா குழந்தைங்களுக்கும் பண்ணணும். அண்ட் அவரோட வாய் முகூர்த்தம் அடுத்த வாரம் ஸ்டெய்னி ஃப்ரம் நாமக்கல், ஹைஃபா ஃப்ரம் Dharmaburi, and Purnita from Coimbatore got on an insulin pump. So thank you very much for the opportunity.
Dear friends, it has been a talk. I'll call it different talk. It's a talk which is a lifetime, I don't say achievement, lifetime work of a person. And it also a talk which not only inspires, but the proof of pudding that all of us can do it. There can't be any question after this talk. I will just tell 3 sentences that, you know, like water and air, insulin is the birthright of a type 1 diabetes child. And it is no more acceptable that we have a child dying because of lack of insulin. And it is the job of the government. Government says that we are doing this scheme. I will not describe that as a debatable issue. On the March 15th, the Bharat, I think his name is Bharat, the State Minister of Health, Union Government, gave a talk on March 22. This year, March month, he gave a talk in the PIB. We have a Press Information Bureau. He said that we are doing, I'll just describe the schemes that he spoke. I don't know how much is working. He said we have free insulin at every government hospital. It's probably, the chain is not there. He said that we provide Ayushman scheme to 10.4 crore people in the country. How many type 1 diabetes children covered? I have my own doubts. But the bottom line, the fact of the matter is that it is not only government's job. It is each one of the job. And you have seen yourself what a person can do at his level, not at the level of government. And you know, he can do and change the destiny of the type 1 diabetes children. That's the beauty of it. Dear friends, I must tell you also in the registry, we have found many children just disappear. They don't disappear actually. We will go for the follow-up. I'm telling, but I went to Assam to see, I was assigned Assam. He said the person has died, the child has died long back. You know, it is so painful to see that type 1 diabetes are dying without insulin, of infection, of kidney failure, like flies. So dear friends, I think, Vijay, you did correct by inviting a person. I told you the moment I saw his name in the program, I said it is going to be different. Dear friends, it is not only talking. I mean, there is this famous saying by somebody from Pondicherry, no words, acts. And these no words and acts have been done by a person in front of you. Let us give a standing ovation.
Thank you. Thank you very much, sir. Thank you. Thank you. Manamartha Nandrigal, sir. Thank you very much. Deeply humbled, sir. Thank you. Thank you. Thank you, sir.
So with this amazing session, we conclude the morning program, and lunch is available in the 4th floor. So, and we also have a quiz. So people who wanted to proceed with the lunch can go on, and people who wanted to attend the quiz can sit over here. Let us resume by 2 o'clock sharp. Thank you.
So those who want to attend quiz, please stay down. It is only 5 to 10 maximum. It will take 8 minutes to finish a quiz. So the instructions are same. Those who want to attend the quiz, please stay back. Yeah. So we'll go in, I think the instructions are same, okay, as that of the previous 2 quizzes. So you have to answer fast. So this is a login ID followed by code. It's same www.menti.com, but the code here is 520 144 09. Please retype. It is 5. I'll just re-say it is 520 144 09. So I'll just give another 30 seconds for people to log into quiz. So another 10 seconds, then we'll go into the quiz proper. Okay, so we'll start, okay? Just a minute. So identify the scientist. Okay, so he, apart from his contribution indirectly to discovery of insulin, he has a macrophage cell named after him. So identify the scientist. Very simple. So he contributed to discovery of insulin indirectly. Okay. So apart from that, there is a macrophage cell named after his name. So identify the scientist. So either you can type full name or just his last name. Okay, both should be fine. So we have 20 seconds to complete the quiz, complete this question. Last few seconds. Okay, so we'll go on to the next. Once weekly insulin, which is in final phases of clinical trial, is called as. So what is the once weekly insulin, which is now currently almost in final phases of clinical trial? Just type the name of insulin. Just if you know, type faster so that you will get maximum marks. "30 seconds to answer. Last 15 seconds. Okay, few seconds. Okay, we'll go on to the third question. Identify the monogenic diabetes. So this is a CT picture taken at the level of, probably the level of pancreas, okay, which shows pancreas and all the other internal organs. Okay. So identify the monogenic diabetes, just diagnosis based on what you see in the clinical picture. It's very simple. The key findings of the condition is clearly seen in this CT image. So we have 25 seconds to answer. You can just see the arrows being pointed at something, but also look the whole CT image. So last 10 seconds. We'll go into the fourth question. Okay, so name the former Pakistan cricketer who had type 1 diabetes. So he may not be in the picture, but you have to just name the former cricketer who had type 1 diabetes. So no clues, sir. Okay. So he had type 1 diabetes in the during 1997-98 cricket series in Australia. So we have 30 seconds for you to answer the question. You can write the complete name or at least the last name. Both will be accepted as a correct answer. So last few seconds. So we have the last question. Okay, so identify the scientist. It's only one scientist, one taken at his younger age, another taken at his older age. So we all I think Nobel Prize for us is it is like the distance is with like what we see in the stars, right? But this guy has got 2 Nobel Prize. Okay, so the first picture is when he got his first Nobel Prize, and second picture is when he got the second Nobel Prize when he was almost maybe around 85 to 90 years old. So identify the scientist. So another clue, it is not in medicine he got Nobel Prize. So last 20 seconds. So again, if you answer the last name correctly, still you will get the mark, or the complete name if you know. So we have last few seconds to answer the question. Yeah, we are done. Just give me 2 minutes to compile the results. So we'll just see the answers followed by the winners. Okay, so answers are, so the answer is Paul Langerhans. Okay, so we all know macrophage cell. Okay, Langerhans. Okay, so spelling should also be correct. Okay, so to get the answer correct. So this he has done when he was a medical student. Next. So this is insulin icodec. So it's this study was published in 2020 in NEGM. So we expect the insulin will be available very soon. Okay. So it's a once weekly insulin icodec. So this is modify, simple, right? You can just see the atrophy of pancreas, and the other thing you can see is the renal cyst, which is also very clear in this picture. So it's a modify. So this is Wasim Akram, right? So he had developed type 1 diabetes at the when he was playing cricket, right? After in 1997 when he was a captain of Pakistan cricket team. Okay. And this is Friedrich Sanger. Okay, he has won Nobel Prize twice. One in 1958 for structure of proteins, especially insulin. Another in 1980 for DNA sequencing technique, which is still now a gold standard technique. So, and the winners are, the total participants are 54. First is Dr. Shabina CHC. Second is Dr. Magical Rhino, nice name. And third is Dr. Prakash. You can just contact the reception for your cash prize. Thank you.
Thank you, Dr. Velmurugan. So we have lunch arranged at the 4th floor, and we are reassembling sharply at 2 o'clock. The Meet the Professor session is going to start sharp at 2, and we have poster presentations going on outside the hall, and people who wanted to see can look at, and we also have stalls on the right side of the hall. And let's all get back at 2.
My, he's moderator. Okay. My co-moderator will be Dr. C.G. Delli Kumar, who's Additional Professor of Pediatrics, JIPMER, Puducherry. He's in charge of Pediatric Endocrinology Department in JIPMER, and he's published 36 articles in index journals. So
good afternoon, one and all. At the outset, I would like to thank Dr. Vijay Bhaskar Reddy for giving this opportunity, and we will be presenting a case. Two cases we have, XX DSD as well as XY DSD. Provided the time permits, we will finish it off. And I would like to introduce Dr. Komal. She's a DM Endocrinology postgraduate of Madurai Medical College. And so we will start with the case scenario, and I will be interacting, and hope the time permits, we will have discussions from the forum also. Yeah.
Good afternoon, esteemed faculty and colleagues. Today we will be having the Meet the Professor session on a newborn with ambiguous genitalia. So this 4-day-old neonate presented to us with ambiguous genitalia, generalized hyperpigmentation. The child was second born of a second-degree consanguineous marriage with a birth weight of 3.1 kgs, and she was born via full-term normal vaginal delivery.
So these are the what are important history while a case of any DSD coming to the clinics. So what are the things you would like to particular of consanguinity? How the consanguinity will give you a clue to identify a case of etiology of DSD, consanguinity and DSD.
So the congenital adrenal hyperplasias, they're basically autosomal recessive disorders. They are more prevalent where there is inbreeding. So if there is consanguinity, the chances of having a congenital adrenal hyperplasia, especially 21-hydroxylase, is higher, sir.
Just go back the previous one. So any case of DSD if coming, we have to ask the detailed pedigree chart. And so this hope some of the postgraduate will be knowing that symbol. So whenever the sex is not sure, we use this symbol, and once assigned adequately the correct sex, then we can change this thing. So the pedigree chart and maybe first generation, second generations. So we can, as much as possible, we can involve, and it is very important. While history taking, it is important clue to come to the conclusions and what may be the mode of inheritance in case of all the DSD. And how the term, full term and preterms is having an important thing in case of DSD.
Sir, preterm births, especially during the diagnostic evaluation, especially when we're doing 17-hydroxyprogesterone, preterm births can have a false high value of 17 OHP. So that can give false positive results for the test. So while evaluating these patients, we have to keep in mind that it may be false positive. Either use a different cutoff or repeat the test after around term gestational age.
And one more point is if some mild clitoromegaly, that also it is common, and as 2 weeks or some time crosses, that will be regressed. That is a spontaneous regressions of clitoromegaly also we may expect in certain cases because of the maternal progesterone effect into the fetal newborn. So that is also can have. And how the pigmentations and the CAH in history takings, and what are the maybe the etiology for pigmentations, or what are the possible mechanisms, it will come to the conclusions or clue to the underlying diagnosis.
So if there is hyperpigmentation, it indicates towards an excess of ACTH. So whenever there is cortisol deficiency, there will be increased transcription of POMC peptide from the pituitary, which will lead to increased amount of ACTH, beta lipoprotein and gamma lipoprotein. This will act on the mineralocorticoid 1 receptor, which will cause pigmentation in these children. So essentially, if there is hyperpigmentation, it links to associated cortisol deficiency in the child. So conditions with DSD and cortisol deficiency should be taken into account first.
So usually it is a primary adrenal failure. So we expect a very high ACTH. That is the reason for pigmentations. And what is the ideal time manifestations? Whether it is immediately, or what is the time of the manifestations of this adrenal crisis in a case of the classical case of CAH in 21-hydroxylase?
Usually it will take place at around 10 to 14 days of life, sir. Because before that, the maternal progesterone will be having some mineralocorticoid effect. So because of that, before that, the child will not manifest.
So many times it has come. Many times we may do the test at immediately or at the time of second day or third day. Like similarly what morning discussed in TSH after 48 hours. So similar thing is we may expect in this case of DSD, that is 21 hydroxylase deficiency. So the clinical suspicions is very, very important. And if the test report is equivocal, you do the test at the first week or second week. So the time of doing test also is very important. Clear-cut case are very severe. I will come across some genetics thing also. So if a clear-cut case or very severe case, you may expect the severity of the enzyme deficiency is very high. We may be able to pick up at very early. But some cases, you need some time, second week or first week, or you need stimulation test that we will be focusing in the subsequent slides. So this is the prevalence, and obviously it is most quite common, and more than 95% is 21 hydroxylase deficiency, and very rare other less than 5%. Out of this thing, the 11 beta and 17 alpha both will present as a hypertension. And the 21 hydroxylase classical will be solved losing a hypotension, whereas other deficiency, they will present with hypertension and hypokalemia. That is the most important clue. And 3 beta and P4 oxidoreductase, some overlap will be there between these phenotypes. So this is the order of the prevalence. And here also in India, this is Western data, but here also in India, this is the most common 21, and subsequently the 11 beta and 17 alpha. So the presence of hypertension and hypokalemia, we have to suspect these other CAH causes.
So on examination, the baby was alert and active. There was generalized hyperpigmentation. Baby had not undergone any phototherapy. BP was in the normal centile range for the child, that is 64 by 45 millimeter of mercury. On genital examination, the
So
child...
what are the things you have to examine whenever a case of DSD present to you? So what are the clinical findings, and hope all the postgraduates should do thorough clinical examinations before ordering any investigations. Since the clinical examinations itself, it will be a very good clue, maybe a XX or XY, but it is a very difficult situations for the parents as well as the pediatricians and neonatologists to assign the sex. So the genital examinations are very vital clue, and you have to, what are the things you should point out, or what to be given priority for the examinations.
So we have to look for any signs of hyperpigmentation and look for the BP to look whether the child is hemodynamically stable. External genitalia, we should look for the size of the phallus, hyperpigmentation, the clitoromegaly, the length of the phallus, and look for the development of the labioscrotal folds, whether there are any rugosities, and also look for the number of openings that the child has, whether one or two are typical of female thing, and also we should look for any palpable gonads which are present in the labioscrotal folds or inguinal region, which will give us a clue towards whether it is XX or XY DSD.
So ideally through scale we can measure it, and the rugosity, so it is one of the very important clue for the degree of viralizations or degree of androgenizations which is happening here. This is a XX, but you can see that the how much rugosity, so the severe rugosity, it indicates that much amount of high testosterone or that much amount of high androgens is there in this case. So it shows that like a scrotal sac, it is there. But whenever we are not sure about the sex, we use the term as a phallus, not as a penis or not as a clitoris. So we used the term as a phallus. So the phallic length, that is the correct terminology, not to use either penis or clitoris in such situations. Phallus. And similarly, the labioscrotal. So this is a embryological words, the labioscrotal. It is a common for both the things. And another one is a palpable gonads. So when any gonads which is palpable in the inguinoscrotal or labioscrotal area, it is usually testis. And if it is non-palpable gonads, it is not a 100% sure, but it is most commonly whatever palpable things in the labioscrotal or inguinoscrotal, it is usually testis. So many of the times likely possibilities is a XY DSD, but in this case no palpable thing in the labioscrotal or inguinal scrotal region, and it is most common in preterm. So preterms we may not able to Sometimes it will take time to descend the gonads also. So this is all just a degree of virilizations. That is a female XX, we used the Prader stage, whereas in male, the EMS, external masculinization score, and just for the completions I have highlighted. Because of time, we are not going into the detail next. And this is also again spectrum. Commonly, we see the salt wasting that is presented, manifested at very early, and the remaining, it may manifest at any point of time, from the newborn to childhood, to the adolescent, to the adult. And this is the all XX. This is from one of the paper from in our institute, and you can see that the first one is a newborn. The second one is presented at 4 years of age with precocious puberty. And the third also, the simple virilizing, even though the terminology is simple, but they presented very late in form of precocity or that much amount of the clitomegaly. You can see that much amount of the androgen excess, but it manifests at very late point of time.
Yeah, what are all the emergency CH newborn present to the pediatric emergency?
So these newborns, they can present around 10 to 15 days of life with adrenal crisis. So the symptoms will be lethargy, failure to thrive, then excessive sleepiness and things. In female child, they will be associated clitoromegaly, so it will be easy to detect. Male child means those virilization we will not be able to this thing, so high index of suspicion is needed. Sorry.
Yeah, most of the children present to the emergency with the dehydration. They have severe vomiting, dehydration, sometimes they will be in shock also.
Yes.
And if you see the electrolytes, they will be having hypokalemia. And the typical combination of, they will have hypoglycemia. The typical combination of hyperkalemia with hyponatremia with hypoglycemia is classically seen in adrenal insufficiency or CAH children. So we have to immediately correct the sugar. Usually we give 10% dextrose, 4 ml per kg to correct the blood sugar level, and hydration part 20 ml per kg NS we give to maintain the normal blood pressure and continue on the IV fluid. And hyponatremia 3% saline you have to give. Hyperkalemia is very, very dangerous. Yes. It can cause immediate arrhythmia and cardiac arrest. So you have to correct the hyperkalemia mainly by insulin dextrose infusion and saline nebulization. All these measures we will take, we will try to bring down the potassium. These are all very, very emergency. If you don't treat, patient will, there is a possibility that child will collapse and die in the pediatric emergency. The commonly female babies, we don't have this problem because most of them they will be able to identify in the newborn period itself. They will be having typical hyperpigmentation with ambiguous genitalia. The one problem we face is male children with the CAH presenting to the pediatric emergency. So that time, we have to first time diagnose most of them with the adrenal crisis. We have to suspect in the any male child presenting with hyperkalemia with hyponatremia. Then you have to evaluate for the CAH children. So this emergency need to be acted very fast. Otherwise, it's very lethal and it will cause permanent severe damage. Yeah. So what are all the management point CAH?
So initially, the recognition and management of adrenal crisis is one important aspect. Other than that, the counseling and psychosocial support to the parents in the form of counseling should be given. And we have to try to minimize the degree of virilization by early starting of treatment with hydrocortisone to suppress the ACTH. Along with that, salt supplementation, and once the baby comes out of the stress condition, we can shift to hydrocortisone and fludrocortisone oral along with. And the patient also has to be told about sick day instructions. If there is any mild sickness, mild to moderate febrile sickness, the dose of hydrocortisone, glucocorticoid has to be doubled. And if the patient also has vomiting or loose stools or any signs of dehydration, then fludrocortisone also has to be doubled. And in severe illness, the patient will need stress dose of IV steroids.
Yeah, correct. So all suspected CAH children, we start with 10 to 15 milligram per meter square of hydrocortisone, and fludrocortisone from 50 microgram to 200 microgram as a single dose after correcting the adrenal crisis. So we always add 1 to 2 gram of salt. The this is the for continuous management. So the giving salt for the babies is really difficult. because most of them are on exclusive breastfeeding, no? That time, how to give salt in the, small infants?
Sir, 1 gram of salt can be dissolved in around 10 ml of water, and that can be given throughout the day before feeds or after feeds. Once after 6 months, it can be added directly in the food. Before that, it has to be dissolved.
Yeah, correct. So 1 gram of salt will give approximately 17 milliequivalent of sodium chloride. So what we advise is, we ask them to give in the breast milk. Generally, we don't give water also for the newborn baby. We ask them to add it in the breast milk, multiple small doses taken as a multiple times. Because as 3 dose, 4 dose also difficult. They will not tolerate. Babies will vomit. If that is not working out, because measuring 1 gram salt is really difficult, because they will not be able to identify correctly 1 gram salt. So one patient we advised to go and measure in the Goldsmith, they are measuring this salt measurement. From there we got it, and we are continuing that. Otherwise, we advise them to take 3% saline. That will give 1 ml will give 0.5 milliequivalent of sodium. So according to that, we can give 3 to 5 milliequivalent of sodium per day for newborn. So salt is 1 to 2 gram, sodium is 3 to 5 milliequivalent of sodium chloride. Sodium that we ask them to take as a per kg weight, this much ml we advise them to take. So as you said, any sickness they are presenting with, that sick day management, we have to double the dose, or as a single stat dose also we can give for infant to 25 milligram hydrocortisone, then 50 milligram for older children, then more than 12 years 100 milligram of hydrocortisone, then your stat dose, and it has to be continued 6 hourly. That when you are giving a higher dose of hydrocortisone, fludrocortisone may not be required. When we are tapering, we can add the fludrocortisone. And many infant we had after adding fludrocortisone, hypertension also. So though they say the infants they will have resistant to the fludrocortisone, we have encountered 3 to 4 children after starting fludrocortisone with hypertension. So most of them were on some baby on 200 micrograms, some were on 100. When we reduced to 50, they are able to control the BP. The hypertension was not there at the beginning. It developed after fludrocortisone, so that part we are able to take care of that. Of course, the other aspect you can present and we'll see. This is the medical management we are doing in the pediatrics. Yeah. Yes.
So what are the minimal investigations? Almost you have come to some clinical clues of 21 hydroxylase. What are these are the minimum investigations. So what are the things you can highlight it and
So serum electrolytes, in these cases there will be, we can expect hyperkalemia and hyponatremia, a plasma glucose level where we will expect hypoglycemia, a serum cortisol, total testosterone and 17 hydroxyprogesterone. So cortisol level will be expected to be low, and total testosterone and 17 OHP will be high in these patients.
So these are the, except 17 hydroxyprogesterone, we can get the result that day itself or next day itself. Only the 17 hydroxy, we may expect some delay depend upon the resource availability. And other investigations, we can get it on the same day, provided the lab is this thing. And what are the imaging and what is the karyotype, or when will be advising?
So USG pelvis to look for first presence of the uterus and the Mullerian structures, and also to look for adrenal hyperplasia. Then to confirm the karyotyping, whether it is genetically female or male, we will do karyotyping, but that will take around 10 to around 21 days. So we can also do FISH to look for the presence of SRY gene, and to confirm at an earlier stage.
So the parents will be very anxious and very panic, and because the sex assignment is very, very crucial thing, and because relatives, everyone has to be, and as a pediatricians or endo, we have to also more answerable. So the USG pelvis will give a very important clue. So don't miss it, and it's easily available thing, and only the radiologist has to be trained well to do the scan for the newborn, and the adrenal hyperplasia is very significant, and the limb, medial limb and lateral limb, size of the adrenal limb, that will give you one important clue whether it is underlying any hyperplasia is there. So the good sonologists, they can able to pick up and presence or absence of uterus or gonads likely if any gonads are there, predominantly it will be testes, but ovary sometimes they may pick up, sometimes it is a very streak or may not be able to pick up, but the immediately or within 2 months there is a so-called as a mini puberty, they may able to pick up the testes and ovary, and after that it is a quiescent period and may not be able to pick up. So the ultrasound will be a very good clue, and if it is more anxious the fish, but we don't do routinely fish, but just next slide, next one. So the fish, we can see whether the Y chromosome is there or not. Okay, the previous one. So for fish, we can see that whether Y chromosome is there or not, we can able to see, and it will give immediately within 1 day. But the karyotype will be a confirmatory test, but it takes some 2 to 3 weeks. So depend upon the availability. And so what is the assay? And just I want to highlight it here is various assays are there. So you have to rely upon the lab to confirm the diagnosis. And if you hurriedly, you are starting the treatment, hydrocortisone or fludrocortisone, and you want to recheck, it will be difficult situations. So always you rely upon the lab with a good reliability. And so what is the best methodology for this test?
LCMS is the gold standard, sir.
And many of the times we don't have LCMS, and we have the CLIA. Many, I think in our government hospital in Madurai, we have Roche Cobas E411, and some places maybe a Beckman Coulter or some maybe a Siemens. So these are the best test, that is a CLIA, chemiluminescence immunoassay. And ELISA is a not very robust test for this hormonal assay. Even though previously we were using ELISA, maybe as the other immunological thing, maybe ELISA may be a more best test. But as far as testosterone, cortisol, or 17-hydroxyprogesterone, it may not be a good test. Some of the lab they do RIA by the 17-hydroxyprogesterone, but some lab they do the CLIA or CLIA. But wherever the LCMS is a gold standard. In Western countries, it is been nowadays predominantly been another 2-3 minutes we will finish it up. Western countries, they have moved into the LCMS. The advantage of LCMS, I think the Lal Path Lab, they do all these tests. I think 4,000 rupees per the total test, and we can pick up the rare diagnosis of XY DSD as well as XX DSD, because this 21-deoxycartylase is one of the newer marker, and it will be very highly elevated in the 21-hydroxylase deficiency, 11-deoxy and 21-deoxycortisol. And androstenedione also is there in this panel. So the androstenedione also, just next slide. And you can see that there is a diversion of pathway, and because of the enzyme deficiency, you expect very high 17-hydroxyprogesterone and subsequently very high androstenedione as well as very high testosterone. So this is the things which is leading to the virilizations in a female child, and this is the most important. And by LCMS method, you can able to do the multiple markers, whereas the CLIA we have to ask specifically 1 or 2 tests, and there is the advantage of doing LCMS methodology of the CAH, and it is available, and so rely upon the reliable lab. Next one. Next one, we will skip this one. So is coming to this case, and this child, this newborn has very high testosterone. You can see that much amount of virilizations, degree of virilizations, and 17-hydroxyprogesterone, it is very high, and potassium, and so this is a simple things whichever available in your setup or resources. Preliminary investigations, everyone can do it, and later you can refer to the specialist or those who are experienced in treating this all the DSDs. Next one. So this is equivocal case we do. Currently it is available, this ACTH or actin prolongatum in the previous times. So in equivocal cases, you give the, you can do the according to the body weight, you can choose a dose, and 0 minutes and 60 minutes cortisol as well as the 17-hydroxyprogesterone sample, that is ACTH. This is a gold standard, but predominantly is not required, but in equivocal cases, you can do these tests for the newborn. Next. And the interpretations, this is nanogram per deciliter it is given. So many of the commercial lab or available lab use nanogram per ml. So if anything more than 100, it is very quite significant or classical CAH. That is the last one. You can see that the 10,000 nanogram per TL or 100 nanogram per ml. So that is coming into the classical CAH, and lifelong they may be recurring this therapy. Other is non-classical or mild variety. I am not going into the detail because of want of time. Next. So they may be expecting falsely high 17-hydroxyprogesterone. So you should rule out all this investigation. If it is not fitting into the your the clinical parameters, you rule out all these the false positive things into the mind. So recently the genetics also has come up. So there is a very good pheno-genotypic correlations has been available in literature. And in India, almost 5 studies are there. And we are also one of the center. We recently did one paper. And just to go back. So you can see that the severe variety, you may expect the intron deletions or stop codon Q318. And in mild variety, you may expect this valine leucine point mutations or proline and proline leucines and isoleucine and arginine. So these are the green one is a mild variety and the severe variety manifest late. Yes, I think because of time we can finish it up. Next one, I think we can skip this slide. So already sir has highlighted all these glucomineralocorticoid and sodium chloride. And next. So this sick day you have to use steroids. I think that's all. Okay.
The slide is there. So Dr. Professor Sriram and Ramanathan from Chennai and Ramanathan from Chidambaram. So they will take the chair and discuss the case of an 8-year-old child with advanced breast development. So over to you. So of course, all of you know them.
May
So
I invite
you have been listening to Sriram's lecture, so naturally we will not waste time. Please go ahead.
Yeah, small change in the role played by the presenter and the moderator in contrast to the previous session. Our postgraduate Dr. Nayantara from Ramchandra Medical College, she will present and we will answer instead of we asking her. I think she will also be very comfortable. Oh, to you, Naina. Yeah.
Thank you, sir. So good afternoon, everyone. Today we are going to present an 8-year-old child with breast development who had come to our institute. So this is a Miss RP, who's an 8-year-old child who hails from Tiruvallur. She's a class 3 student.
Carry on.
Who was brought by her mother with the chief complaints of breast enlargement for the past 6 months. I would like to start with the birth history of the child. So she was born out of a non-consanguineous marriage. She was a full-term child. Her birth weight was 3.0 kgs. She cried immediately after birth. There was no NICU admission or prolonged jaundice in the neonatal period. Her milestones were normal and her scholastic performance is good. So history of presenting illness, her mother had noticed that she had breast enlargement which was insidious in onset, painless, gradual increase in size, no history of waxing and waning of breast size, also noticed a height spurt gain for the last 6 months. She had no history of vaginal discharge or bleeding, no history of axillary or pubic hair growth, no history of taking any medications allopathic or native, and no history of facial asymmetry or pigmented patches all over the body or fractures, no history of weight loss, palpitations, heat intolerance, again which is we asked in terms of McCune-Albright syndrome. No history of seizure disorder, swellings over her body, no history of recurrent vomitings, abdominal pain, hyperpigmentation, hypoglycemia, hypotension, again which is again seen with CAH. No history of constipation, weight gain, heat, cold intolerance, suggestive of hypothyroidism.
You can mention why you are asking that also. That will be.
Yes, sir.
Yeah. Anyway, we will discuss. Yeah.
Yes. So
Quickly
history of recurrent vomitings, abdominal pain, hyperpigmentation, which my colleague just discussed, is CAH again. Precocious puberty can present in a patient who is a case of CAH. So I had asked the history because of that. And no history of constipation, weight gain, cold intolerance, again goes in, I had asked to rule out primary hypothyroidism. No history of head injury or history of meningitis, encephalitis, chronic infections in the past. Any systemic illness can cause precocious or delayed puberty. No history of head surgery or radiotherapy, again is for ruling out central causes of precocious puberty. So coming to the past history, there was no significant illness in the past. Coming to the personal history, she consumes a mixed diet. Her sleep and appetite was normal. Bowel and bladder habits were normal. So the family history, mother attained menarche at 13 years of age. Father had noticed that he had beard growth and nocturnal tumescence at 14 years of age. She has an elder sister who had not still attained menarche.
What is the elder sister's age?
Elder sister is currently she is 10 years old, sir. So coming to the summary of the history, this is an 8-year-old girl who had an uneventful perinatal course, presented with complaints of thilaki and growth spurt, so which is suggestive of precocious puberty. So the differential diagnosis that I would put for the first, because of the events, so I would like to put gonadotropin independent precocious puberty as my first diagnosis, then gonadotropin independent precocious puberty, because both of them require investigations for differentiation of both, and a premature thilarchy as a last diagnosis, as a last differential. So questions for the panelist: what is precocious puberty, the definition, age cutoff, secular trends, and how commonly a pediatrician would encounter?
For a pediatrician to know, just to recollect the basics, precocious puberty is onset of secondary sexual characters before 8 years in a female child and before 9 years in a male child. So it's basically the breast development in a female child and the testis, which is more than 4 ml size in a male child. So that is the basic concept that we are to be aware. But even now the definition is a bit arbitrary, because some children now of late post-COVID, many of them have become obese. So the onset of thilarch and your puberty is a bit advanced age. So but still we need to have some guidelines. So we are sticking on to this old definition of 8 and 9 years for females and male children. Being a pediatrician, I would say it's not very common to see children with precocious puberty, but maybe because of the increased awareness they land up to the endocrinologist. But we have seen children with premature thilarch. That is more commonly being seen in a pediatric setup. So that age group is less than 2 or 3 years. So any child who comes with breast development who is less than 2 years without any other secondary sexual characters, we think of a premature thilarch, which is a normal benign variant which regresses automatically. Why this happens is because there is a mini puberty period which is called within the antenatal period and the early postnatal period. This is called as a mini puberty. That means to differentiate between the gonads, there is a pubertal response that is going on inside, which has to be suppressed after birth. Some children it gets prolonged, there is still activation of the axis of the hypothalamic gonadal axis, so they continue to have this thilarch, which regresses spontaneously. But what a postgraduate should understand is, whenever they have a breast enlargement, they should look at the other secondary sexual characters. Don't just tell them this is normal and send them back home. Please have a look at the other external genitalia, your pubic hair, other external markers for other diseases, especially neurological disorders. So that is the type of questions that we usually ask. And age per se, what the books and the textbooks have been saying repeatedly is, any girl child, the common cause will be it's not important to investigate usually, because it's idiopathic and sometimes it's settled down. But all male children with precocious puberty have to be investigated. That is one single line. And any child who has a breast engorgement below 6 years have to be investigated. Between 6 and 8 years it is arbitrarily if they don't have other problems. And we should also have a look at the bone age. Always, whenever there is a precocious puberty, other secondary sexual characters, bone age, height, velocity, and your ultrasound pelvis will give you a very important clue in the diagnosis.
We will discuss it in the next slide. Thank you, Dr. Ramanathan. And one more couple of small points to add is, see, the mothers are very worried when they bring these children. This mother is actually very intelligent. She has brought the child at 8. She has noticed 6 months back. Usually, the first doctor whom they meet, if they reassure in a different manner, sometimes they overlook also. They come to us at 9.5 with the menstruation. One more definition of precocious puberty is onset of menarche before 10 years of age. It's a very important thing. Today morning, Dr. Hemchand, you might have listened to, he presented on how these early menarche children at the age of 12 and 13 will come to with short stature. Now the growth chart in the growth chart height spurt has been noticed 6 months back. breast development is noticed by the mother means adukku meenadilende konjam estrogen irukum. One subtle point for postgraduates is, even though books will, the usual answer for a question like which is the first sign of puberty in a girl is breast development, thelarchy. That's the standard answer, nothing wrong in that. But if you are very meticulously monitoring height, growth spurt will start even few months before. So if at all this child was routinely monitored by growth chart also, you can pick up, rapidly. Today he showed short stature, 2 standard deviation, 2 centiles, 2 channels going this way. The child may go the other way. That's also a way of picking up. And very often falsely reassured by, if I can use again from previous talks, Dr. Swaminathan's term, GMT in Sadhasonare. Good, some medical information, bad medical information giving. All the more if the child was obese. I don't know the height and weight, till now we have not gone to the examination. Now, as you know, the breast will be, there will be a lot of fat in the chest area. That will also be mistaken as, so as a pediatrician, I think the job is even more difficult, in the sense you have to carefully assess so that you don't miss this rare patient of precocious puberty. Otherwise it could be, as sir pointed out, it could be just a infantile mammoplasia was one of the term used. That will usually happen only in the first 2 years of age. Or it could be only lipomastia, which is seen in an obese girl today, very commonly seen. Or is it true precocity? There will be a subtle points on the X-rays, which we will discuss. You go carry on, otherwise I'll be going on in this. If this was, why she put gonadotropin dependent precocity as the first possibility is, that is the most common, 90% of the time. Or within 6 months, in a typical independent precocity, the chronology of breast development to the menarche and all will be lost. There will be very short time before which they will have. So if you have any discrepancy in the order in which the puberty is developing, that will give you a clue for independent thing.
So on examination, this child was found to have a height of 135 centimeters, which falls between the 95th and 97th centile, and the weight of the child was 30.5 kgs, and she falls between the 50th to 75th centile. The mother's height was 148 centimeters, her father's height was 156.
You go to the next one. Yes. So this is what you are mentioning, that the child is already crossing with you. You didn't, where is the mid-parental height? You didn't put that.
Yes, sir. Mid-parental height is...
It was not marked there, no?
Yes, sir. Okay. But she has already started achieving the 145
so
was a mid-parental
children,
height.
But they may end up as short adults if not intervened. This will be the whole idea in the background, which we will discuss further things.
So on examination, her vitals were stable. There was no general examination findings of pyeloelectrocyanosis, clubbing or lymphadenopathy. She did not have caffeole macules, adenoma sebaceum. Caffeole macules can be present in association with McCune-Albright
syndrome. Some of
syndrome.
these are neurocutaneous markers, which gives that rare possibility, clinical clue for a sinister or ominous disorder which the child may harbor. For example, it could be neurofibromatosis or tuberous sclerosis, or again, tuberous sclerosis, neurofibroma, McCune-Albright. All these are sometimes very classic. The child would, show a big, you have to obviously undress the child fully and examine thoroughly for this large. If you have, it will be easy clue. And in the history also, I was mentioning to her, history of any CNS injury. It could be inflammation, infection, injury, chemo, whatever, head injury. We have seen with head injury with the IVH. During delivery, the child had an IV intraventricular hemorrhage, child presenting with precocity, meningitis in the childhood, recovered totally, seizure of any sort. One classic seizure which happens is, as you know, inappropriate laughter seizure. These are all classic descriptions of some things, but any CNS insult can end up in precocious puberty in a child. That's the better way to remember. That will be a good clue. So this child doesn't have any of that.
No. There is no facial dysmorphism or midline defects. She has no history.
Shall I comment, sir? There is one paradox here. See, this is, even though she is writing, there is no goiter. Just a offbeat point that will help to contrast precocity from other. Of all the etiologies of precocity, gonadotropin dependent, independent, there is only one etiology where the child will not be tall. The only, that is hypothyroidism. Hypothyroidism is a great mimicker. You saw again, I am quoting Dr. Hemchand's slide where you see he put as that ICP model, he put all the graphs, but he put thyroid everywhere. Thyroid, thyroid can mimic any of the condition, thyroid will go to any specialty. And the thyroid hypothyroidism, as you all know, will cause delayed puberty, but thyroid is also known to cause precocity rarely. Any PG, what is that called?
Van Wijk-Grumbach syndrome.
MCQ correct. Good, that's nice. So that's the only condition where the child will be short but still have precocity, and it won't follow the usual rule of thelarchy, menarche, and the bone age will be delayed. In all other precocity, bone age will be advanced. So in the one exception, அந்த குழந்தையை பார்க்கணும். Okay.
There's no clitoromegaly or genital dysmorphism.
Yeah, another odd point which you, even though you presented for completion in an academic forum, is correct, which is CAH, which was the previous discussion, will cause precocity. It will be heterosexual precocity in a girl. It will not, because the androgens are high. She won't come with thelarch as the presentation. So I wouldn't expect in a presentation where breast development without axillary and pubic hair but CAH, it will be a very odd combination to even consider.
So systemic examination was found to be normal. So after the examination, my diagnosis was GDPP.
So examination has not helped, except that the child has grown well. We are confirming that the child is growing pubertal growth spurt early, which is again a pointer of precocity. There are no clues for either independent or dependent. For gonadotropin dependent, I said any CNS problem. For independent, we had all the neurocutaneous peripheral markers, or even abdominal masses, whatever. These are all peripheral clues or exogenous intake. So the gross thing we will now have to, so we are stuck again. The mother will ask now, sir, ellam paathitinga enna panna poringa neenga. So obviously we have to investigate. Certain things are mandatory, which we'll discuss. Quickly you go through.
Yes. So when is thelarch pathological?
As discussed, even though it is arbitrary, but it gives a rough guidance for all of us that 8 years is a clinical cutoff we take. So some mother who has a mother bringing a child at the age of 8 with 6 to 8 months history of breast development means it is starting somewhere around 7. So definitely there is something wrong in that child. So definitely it's pathological.
More than the breast enlargement, it's the rapidity of the breast enlargement. It is more important than the breast enlargement alone.
And examination, we have already said, in the examination, axillary and pubic hair are clinical markers of underlying adrenal androgen production. So they are not markers of actually true gonadotropin axis. Gonadotropin ovarian, the hypothalamo-pituitary ovarian axis is not reflected by axillary and pubic hair. So axillary and pubic hair, if at all they are there, it may be independent of this whole axis breast development which is. So in the examination, we need to know whether there are combining things happening, heterosexual, isosexual, and all those clues which we mentioned already, which will be, and how to proceed further.
Just to reassure, gonadotropin dependent precocious puberty is always isosexual. That is one point that we have to reassure. And gonadotropin independent is heterosexual. So that will easily differentiate from if it's whether central precocious puberty or it's a peripheral precocious puberty. And as you've already mentioned, gelastic seizures with precocious puberty, think of hematomas. Hypothalamic hematoma will top the list. So that's the easy way to diagnose hypothalamic hematomas. If they have a hyperpigmentation of the skin, if they have bony disorders and precocious puberty, your clinical finding will say they have McCune-Albright syndrome. As sir was stressing, all conditions bone age is advanced except for hypothyroidism, where bone age will be delayed and they will present with a short stature. And you, as a pediatrician, I will also request the postgraduates to examine for neurological findings when they have precocious puberty. Don't miss those signs of raised ICT, whether they have diplopia, look at their fundus, see for neurological examinations. Otherwise, you're missing a neurological cause for the precocious puberty. Mother is not going to worry if you're going to miss a normal phenomenon. She will be blaming you if you miss something which is abnormal in the CNS. We are only worried about the CNS pathology there.
So from all these discussions, I think the audience would have understood reasonably that maximum we are getting information from history and examination, but still we are stuck. We are still not differentiated clearly whether this is central peripheral or you going to treat, and those answers can come only by the next couple of investigations. We have to convince the parents to undergo. So the first exam, the investigation which we will do will be easily doable in any setup, will be an X-ray. I think these and all we have discussed.
Should I just go?
I think you go on. We'll come back if time permits.
So this is the.
Oh no! Wait. This okay. X-ray will be done. Why is X-ray done? Not to say that I will diagnose hypothyroidism by X-ray and delayed bone age. X-ray will always show advanced bondage, how much, what is the growth potential, because that is one more discussion we are going to have. Height evlo save pannalam adu or discussion, and rendavathu this will give a reassurance for us also that okay, this child, even though at 8 the bone age is crossing
11 years.
Can you tell me, Naina?
11 years. So there is pisiform,
this
and
is
there
a
is sesamoid
simple
also. So 11
hand
years.
X-ray tool, even though technically we say do the non-dominant hand, usually the left hand alone, it is worth doing both hands together. Pisiform in a child will be, if appearing, I think pisiform is seen, no? Yeah, that dark thing will be 9 years for a girl, and the sesamoid bone, which is on the adductor pollicis, seen along the first metacarpal, will be a classic clue. These two are easily identifiable. You need not do radiotherapy to the child by ordering all elbow X-ray, skeletal survey panna bone age. Simple wrist X-ray and some vital clues. 7, 9, 11 can be easily identified based on this alone. The ulnar epiphysis, pisiform and sesamoid will give you the clue. 7, 9, 11. Add 2 for boys. Inge 11. So the 8-year-old child coming with 11. Again, height spurt, height plotting, bone age advancement, all are showing that estrogen is unnecessarily working prematurely. This is what we want, and whether it is quick. Then investigation will be, the most vital investigation in this case will be that baseline hormones as well as a stimulation test. A take-home message for all senior pediatricians as well as other budding pediatricians will be, without that test, it will be we can going on, unless there is a classic clue. Okay, the child comes with a shepherd crook deformity, with a big cafe au lait spot, with a goiter, a textbook like quiz program like a grammar, this is McCune-Albert, that's point. The point is, in the Mari, this is what you'll get in the baseline you see here. LH by current third generation assays is undetectable, which is what it should be. But you see, that is in February. We reassured the mother, we asked them to come after a few months. Sir, don't worry, sometimes it will be slowly progressive. Nama worry panavana. And correct our 6 months, it has gone up to 0.75. And that's the time we are, if the assay problem, sometimes you will have issues. I am sitting in setups where resource constraints will be there. We are not, the double conformula check. So we stimulate with leuprolide, which is the only test available with us. We don't have GnRH plain form. We have this analog, GnRH analog, which is leuprolide. This is the standard dose we give. And there are published papers now in India to say that this is equivalent to the traditional test. 4 hours and 24 hours we do. So 24 hours, ideally you need not do gonadotropin, it will be estradiol. If the LH is more than FSH, or the LH is in double digits, usually 10 to 15, clearly it indicates that the central fellow has got activated. You stimulate an axis which is already in a up curve, in a rising trend, you pick up this. Classic case of LH clearly more than FSH. That means the child is entering into precocity quickly. By this time, you will know the breast development is also progressing or not. She told B2, maybe it is B3 now, I'm not sure. So, usually what textbooks will give you, a child will come with breast enlargement, B2, that is second stage. Rapid progress are the slower. The slower, we don't. That will also be known. And this has to be done. Now we are 100% sure that this child has only
GDPP.
Central precocious puberty and that gonadotropin dependent. Why it is so important to differentiate this? Because that is the only case where treatment is highly efficacious in the form of GnRH analog injection. If you have any doubt in these values, or if you are suspecting peripheral precocity, which may be hetero or isosexual, for example, this could be ovarian cyst or something, then your GnRH analog will not work. There you have to give only estrogen blocker or estrogen synthesis blockers. So, differentiating this point is mandatory. GnRH analog test is tayanga kudadu. You should know the protocol, you should do in a proper way in a good lab. Otherwise, based on LH alone, we cannot do. Nowadays, there are some data on FSH stimulated inhibin B, etc., which is more theoretical, and I don't want to confuse this audience here. So we are now confirming that this child has gonadotropin dependent precocious puberty, possibly reasonably progressing rapidly. So what are the consequences? That will help us counsel the mother, how to treat or why we are treating, what can we expect in the next 2-3 years. The first thing is, every mother will be worried that, menses vandurma, ipe vanduruchuna, as usual, personal care, school problem, peer pressure, all these issues will be there. Sir nicely pointed out, ultrasound will done by a good pediatric oriented sonologist only will give this answer. Endometrial thickness, uterine corpus cervix ratio, ovarian morphology. FSH independent ovarian follicles will be seen even in a prepubertal ovary. Polycystic ovary that doesn't mean this is cystic. This is not the problem. That is why you have to have a highly reliable LH-FSH and stimulation test here. Next slide. So so this is clear-cut gonadotropin dependent precocious puberty. Then, as sir rightly pointed out, Ramanathan sir, 90% of these kind of 8.5-year-old child will have idiopathic. Once upon a time idiopathic. Today you may have a small hamartoma sitting there. So MRI is almost to be done. In today's era, I don't want to confuse this audience saying that illa adala idiopathic da 90% da 10% irundiruchunnaangara kelviki you have to tell the parents in the same manner, probably in the manner which I am discussing now. Maybe you can use your rapport with the parents. This child has to undergo an MRI also, so that we are not ruling rare possibilities of some CNS lesions. If not there, luckily this child had normal MRI, and this child will be a clear-cut candidate for gonadotropin analog injections. 3 monthly injections are available now. That's what we most commonly use. Idella the clinical clues. That's okay. This cafe macule, that is the fibrous dysplasia of macunal braid.
Adenoma sebaceum, Sjogren's patch, and cafe macule.
You should carefully look for some of these. Next slide. So, what is the dose and what is the thing? 3 important outcomes. One is the social problems we faced in an 8.5-year-old child, growing rapidly, breast enlargement, etc. Secondly, height concern is the main concern. A menarche I already mentioned, parents will easily understand that. So if you start early in the first 6 months to 1 year of starting of the breast development, younger the age, appropriate dose given, you will definitely able to reassure the parents that the child will reach the genetic potential of that parent. If started late, that's why that bone age is important. Every year you have to repeat. This child is already at 11. So this child has reasonable good growth potential, and we can definitely reassure the child that on the injectable therapy, it is, they will ask a side effect irka sir, Google padichittu odane bone affect agumame, neenga estrogen paidumame. Standard answer for all this is usually nothing happens. Calcium supplement வேணா கொடுக்கலாம், குழந்தைய நல்லா விளையாட சொல்லுங்க. இதெல்லாம் tell the negative consequences of not treating. Then they will understand that this, and this is a time tested more than 3-4 decades drug. Nothing new yesterday or today it's being given. And monthly injections we are, because we want to reduce the number of pricks, we are giving leuprolide 3 monthly injections in our practice routinely.
Once in 90 days.
Time up already, 5 minutes late. Romba late, sorry. Extra, this is extra ஒண்ணுமே இல்லை, இதுதான் இருக்கிறது தான் சொல்லிட்டு இருக்கோம், புதுசா சொல்றதுக்கு ஒண்ணும் இல்லை. The important take home message again will be younger the child, more likely to be pathological. Between the age of this 7 to 10, child coming with breast development, even though more often it will be an idiopathic variety, we have to go through the academic, the investigational exercise fully, so that we are confident in reassuring our. And Dr. Ramanathan sir definitely told a very important point, that was no time. Any boy with any suspicion of precocity, please counsel the parents to, and make them agree for detailed investigations. That will be 90% pathological. It will not be as simple as discussing like this patient. Thank you.
Thank you, sir.
So both the speakers, both the panelists, Dr. Peter Prasad and from PIMS, and Dr. Nayak, head of endocrinology in JIPMA, both will be discussing the case.
Good afternoon, one all.
the case will be presented by Dr. Sumdota Giri from JIPMER, Department of Endocrinology.
Thank you, sir. Sir, we will be discussing today regarding a 3-year-old child who presented with bowed leg. So she was brought to the hospital by her mother at the age of 3 years old age, and her mother noticed this problem since the 2.5 years of age. She noticed that there is a bowing of her legs on the both sides, which was insidious in onset and gradually progressive.
So what do you think is some of the common causes of this kind of presentation of a child who's got a bowing of legs?
Next slide. Next slide. Sir, regarding the common causes, as this bilateral involvement is there, so I will think of systemic cause rather than on causes like infection, neoplasia or fracture. So regarding the systemic causes, sir, Blount disease I will keep it, and then rickets and skeletal metaplasia. All the other sites are not involved here, and less common etiologies could be unilateral causes mostly, like it could be bilateral fracture, infection or neoplasia. Fracture could be due to secondary to osteogenesis imperfecta also. So in our patient, sir, there was no history of trauma or fracture, there was no infection in the leg, there was no growth suggesting any malignancy, and there is no history of limping or it was not painful. So I would put rickets as a possible etiology from this chip complaint.
So for the sake of the postgraduates who are sitting here, the rickets is a diagnosis, is a case which is commonly kept for the MD and DNB exams. So I have a question I would like to ask you, how will you broadly classify, there are so many causes for rickets. So we want you to broadly classify what are the etiologies for rickets, as well as tell us what would be the clinical presentations, so that we can suspect from history and clinical examination as to what is the clue for diagnosis of rickets.
Sure, sir. Rickets could be calcipenic rickets, that could be due to vitamin D deficiency, or if you have a treatment history and response is not there, it could be vitamin D dependent rickets also. It could be renal rickets like renal tubular acidosis or CKD, or it could be due to hypophosphatemic rickets where it could be due to familial causes. So I will ask the patient regarding the dietary history, whether any history of malabsorption like diarrhea, or any history of anticonvulsant use is there or not, to rule out vitamin D deficiency. I would also ask regarding manifestations of CKD, and I'll try to rule out renal tubular acidosis by history, and I also will take a family history to get a clue regarding the hypophosphatemic rickets. Now regarding the onset, vitamin D dependent ricket could be of very early onset. It could present at infancy. RTA and CKD could be a variable presentation, like posterior urethral valves, those things could go silently and lead to CKD at a very early age also. And on the other hand, familial hypophosphatemic rickets, the age of presentation might be delayed until 4 to 5 years of age. Now regarding the limb involvement, as the early onset is there in case of vitamin D deficiency or dependent rickets, so calcipenic rickets mostly present with upper limb involvement with widening of wrist. And if there is no upper limb involvement, predominant lower limb involvement, that could suggest the onset is later on. So that could give a clue that it could be hypophosphatemic ricket. Now fracture is common in RTA or CKD. Enthesopathy will develop later on in adulthood, sir. So that is common in hypophosphatemic rickets. Muscle weakness is a common phenomena in calcipenic rickets, and that could be a part of also renal rickets. Likewise, bone pain is also a common manifestation of calcipenic ricket. On the other hand, dental abscess is a part of hypophosphatemic rickets, and alopecia could give a clue to vitamin D resistant rickets type 2. And Titanian seizure I will ask to find out whether there is calcipenia or not. So in our child, there was no widening of wrist, no muscle weakness, no carpophoral spasm, no seizure, and no alopecia. Thereby, possibility of calcipenic rickets is less likely. On the other hand, I couldn't get a like finding of any dental problem or any joint pain at this point of time.
Like calcipenic ricket you told, like what are the causes of calcipenic ricket? It can have a very early age of onset, and how they respond to the treatment.
Sir, calcipenic rickets, most common cause is vitamin D deficiency that could manifest at the age of 3 months to 18 months of age, or it could be delayed also. But vitamin D dependent rickets, the manifestation is very early childhood, like in infancy. And there are these two rickets are calcipenic rickets. Even renal rickets also, like the CKD, that will lead to abnormal calcium metabolism because of 1-alpha hydroxylase deficiency. So in that case, these are the etiologies of calcipenic rickets.
Therapeutic response to vitamin D actually can decide upon whether you are treating with a vitamin D resistant kind of ricket, or particularly if you have a vitamin D deficiency, they definitely will respond to the vitamin D therapy. So that can give a clue whether you are dealing with a patient with a vitamin D responsive or vitamin D non-responsive rickets.
So that is why, sir, we have taken a detailed history of treatment, but our patient was treatment naive. So we could not rule out by history whether it is vitamin D deficiency or vitamin D dependent ricket. Our patient doesn't have any history of malabsorption, no liver disease, no other nutritional deficiency by history, and there is no decrement in renal urinary output, seizure, breathlessness, facial puffiness, or pedal edema. Thereby, I wanted to rule out possibility of CKD. And similarly, no nausea, vomiting, no history of poor weight gain, polyuria, paralysis, hypokalemic paralysis, fever, no renal stone or hematuria. Thereby, renal tubular acidosis by history is less likely.
There are certain features which can help you in distinguishing in the particular etiology, particularly nutritional, like celiac disease. If you have findings suggest history-wise suggestive of malnutrition, can help you establish the diagnosis. Similarly, like liver disease, actually it's not a very common cause of patient presenting with rickets, because even if very 20 to 30% of liver function is there, still vitamin D synthesis will be hydroxylation will be continued. So that's not very common in clinical practice.
I'd like to rule out some of the drugs we should take history from, which you should ask the patient during the history taking. Regarding the antiretroviral drugs, especially the tenofovir, adifovir, that may cause renal dysfunction. Phenytoin is the most common drug used for epilepsy, and ketoconazole, and the heavy metals that could deposit in the osteoid and lead to inhibition of mineralization. So those histories I would like to rule out from the patient.
Particularly in children, those have a history of seizure disorder, you should ask history about particularly if they are taking the older anti-epileptic drugs like phenytoin, sodium valproate. They can also present it with any kind of bone manifestation, but not common with the newer drugs.
Now I would like to take the perinatal history of the patient. The antenatal part was uneventful. Mother was non-diabetic, no hyperparathyroidism during pregnancy. There was no signs of vitamin D deficiency of the mother. There was no polyhydramnios. The baby was delivered at term by normal vaginal delivery. And there was no neonatal seizure, asphyxia, and she was breastfed until 1.5 years of age. And gross motor development was normal, including the dental development. So coming to the dietary history, because the vitamin D deficiency is the most common cause, but our child has
Taking dietary history is very, very important, because sometimes the amount of milk intake, kind of milk type of milk intake also can decide the amount of vitamin D intake. Because if you look at the guidelines, usually vitamin D as a supplementation usually recommend in the initial period, maybe within 6 months, but other time usually they don't commonly recommend to supplement the vitamin D. So that part also come into very important to take the dietary history in all the patient with presenting with rickets. As we told that vitamin D deficiency rickets are the most common type of ricket.
But our child has made the criteria of recommended daily allowance, and she has taken adequate calcium, vitamin D. Along with that, sun exposure was adequate. So now I move forward to family history. Our child was a second born child. The little ones are there standing, who is born out of a non-consanguineous marriage. and her mother had a history of genu-valgum, and she was undergone a corrective surgery at the age of 15 years. And her elder sister had a windswept deformity of the knees.
Taking a good history and drawing a pedigree chart can guide you what kind of rickets or what is the type of pattern of fall of inheritance you can determine. From this pedigree, what do you think? What is the pattern of inheritance seen in this child?
Sir, from this family history, as the child was born out of a non-consanguineous marriage, so I will keep recessive disorders a little bit less likely a possibility. And if we go through the pedigree chart, only the female members are affected. So possibility of a dominant disorder, and that too could be related to X gene, X chromosome. So it could be an X-linked dominant disorder that I should keep in mind.
So from this history, actually, you can give a clue like which disorder we are most commonly seen as a rickets, because this pedigree will give a very nice clue in this patient.
So I will come to the general examination. It was within normal limit mostly, and dental examination was also normal, including the fundus. There was no signs of papilledema.
Actually, systemic examination, if you are suspecting malnutrition, then it can guide you. But most of the time, in this patient, all features suggestive of malnutrition are like pallor or any other features are absent.
Now as I come to examine the child, like I'll do anthropometry, and there was a short stature also with a height STS of -2.1, but the upper segment lower segment ratios was normal and weight age was appropriate, including the bone age. It was 3 years, and it was pre-pubertal SMR. The distance, the intercondylar distance is coming 7 centimeter, which is more than 6 centimeter, suggesting zero Veram type of deformity.
How anthropometry can help you in a, like how will measure all these parameters like height, whether you should do any particular type of measurement?
Sir, actually here I have to very cautious regarding the height of the child, like I have to measure the sitting height also, including along with standing height, and upper segment lower segment could give a clue here because there is deformity in the lower limb. So that would be that will not be normal in this child, but in this case it was normal, sir. So other rachitic features, like there was no widening of wrist, there was no bony tenderness, no rachitic rosary, no frontal bossing, anterior fontanelle was closed, and there was no craniotabes. So to summarize, this 3-year-old girl presented with bending of bilateral lower limb without wrist swelling, who started at the age of 2.5 years, and she had a history of adequate vitamin D and calcium intake, and we found out a positive family history in her mother and her elder sister. With this summary, I will proceed to investigation, sir.
Now, what are the possibilities you are thinking at the end of clinical history and examination?
Sir, regarding the other causes of bilateral lower limb bowing, rickets, I have put a possibility here, and the age of onset is a little bit later with a positive family history, sir. So, and without calciphonic features, so I would like to put a possibility of hypophosphatemic rickets, and with the family history, I will put a hereditary hypophosphatemic rickets as a possibility.
Okay.
So, on general examination, general investigation, hemogram was normal with a normal RFT and LFT, and serum create was also normal. So as the patient
because CKD particularly in case of children, mostly they will be asymptomatic unless otherwise you take the creatinine. If forgot to take creatinine, then you may find it difficult to diagnose in later on after doing all the investigations. So very careful when giving these investigations, because even they don't have symptoms like urethral reflux, patient can present with chronic kidney disease and bone disorder. You may diagnose very late in these cases.
So the presentation was with lower limb bending, so I did an X-ray which was suggestive of irregular epiphysis. Cupping was not there, but there was fraying of the distal metaphysis of femur bilaterally, along with splaying and widening of the distal part of the metaphysis.
This is the typical radiological picture what he is described, but in this patient there are few of the features are there which is suggestive that the radiological features are consistent with rickets.
Sir, along with that, there is bending of the femur is there, but cortical thinning I could not appreciate in this patient. Next. So I did a wrist X-ray also, which was looking normal only. So after this, I did a calcium profile, and where I found that calcium was normal, within normal range. Phosphate was 3.35, so it is falling below the age-specific normal
How you are
range. Sir.
interpreting this investigation? When you do a what precaution you will take when you are doing this calcium, phosphorus and alkaline phosphatase?
Sir, I will do in the fasting state in morning, sir, because intake of phosphate or any diet that could lead to decrement of the
In the
phosphate.
common practice, you see most of the time we take tick on LFT and we tick on calcium, but we forgot to take the phosphorus. It's very common if you see in the practice. So always when you are doing calcium, you should do along with you should do the phosphorus and albumin. That's you should not forget, because calcium always look for the corrected calcium level.
Another finding is that alkaline phosphatase is high. So this is a biochemical marker of rickets which is present in our patient. So our diagnosis is confirmed up to this stage. It's a rickets, radiologically and biochemically.
When alkaline phosphatase is elevated, it clearly suggests that the patient is definitely child has a rickets. And when you are looking at the calcium phosphorus level, particularly you should look at the age-related range. Otherwise, you will misdiagnose, because you may compare with the because most of the lab will not be giving the range because most of the time they will be giving only the adult range. So you may think this phosphorus as a normal when you look at the child at 3 years of age, but you might be comparing the phosphorus level with the adult. Even alkaline phosphatase also you need to compare with the age-specific range of alkaline phosphatase.
So after the calcium profile, sir, I will do IPTH, vitamin D, and blood ABG also.
As I told initially that vitamin D deficiency rickets are most common, but you can see in this particular patient vitamin D is absolutely normal. But most of the time patient might have received vitamin D. That also you should keep in mind when you are looking at vitamin D level.
She also had a normal acid-base balance in her body.
Yes.
But we can see previous slide.
ABG can guide you whether you are dealing with a renal tubular acidosis or not, because from the history this patient didn't have any clinical feature to suggest renal tubular acidosis, but still ABG, if there is a if you have acidosis, it may help you to guide that you might probably dealing with a renal tubular acidosis. We are not going into the details about renal tubular acidosis because even the ABG can change with regards to the whether you are dealing with proximal or distal renal tubular acidosis.
By this point of time, sir, kidney etiology is almost ruled out, sir, by history examination and by investigations. But our finding is that her parathyroid level is a little bit elevated from the reference range.
So what is the reason behind your thinking?
Sir, regarding the PTH level could be elevated in rickets, sir. It could be due to nutritional rickets mostly, sir, because of vitamin D deficiency or any other calcipenic rickets due to low calcium levels, sir, as a part of secondary hyperparathyroidism. Even in case of phosphatemic rickets, sir, PTH could be elevated if there is simultaneous vitamin D deficiency. And along with that, if any phosphatemic rickets, we are giving phosphate as a therapy. So phosphate could stimulate the PTH hormones that could be elevated.
Yes.
So I didn't, sir, after the phosphate was low, sir, I did an urinary parameter to look for any phosphaturia is there or not. After these reports, you can see calciuria is not there. Then next. So to document phosphaturia, I calculated TMP, TRP, which was 99%, and TMP-GFR, which was appropriate to the age and sex specific normal range. So I could not document phosphaturia by these investigations. Next. So as by the history, family history was positive along with that examination, and after this we had a strong suspicion patient could have a hypophosphatemia rickets, and that was evident in the blood test also. But he didn't have a phosphaturia. That was an odd thing. But for low phosphate was there, so I did an FGF23 level. So it was not suppressed. So this is inappropriate normal value of FGF23 could also help us in deciding the next step of investigations. Sir, with this diagram, sir, I want to say regarding the role of PTH, phosphate and FGF23, what are their role in tubular phosphate handling? Sir, in case of hyperphosphatemia, it stimulates the osteocyte to secrete FGF23, which comes to the kidney, and with the help of alpha klotho receptor, it decreases the sodium phosphate channel translocation to the membrane, thereby decreasing the phosphate reabsorption. Thereby homeostasis is maintained. So if there is inappropriate elevation of FGF23, so that will lead to phosphaturia. So in our patient, in case of hypophosphatemia, FGF23 must have been decreased, but it was not the case. So this could be a significant finding. Along with that, FGF23 inhibits the alpha hydroxylation of vitamin D in proximal convoluted tubule, thereby decreases the active form of the vitamin D level. That has relevance to our patient. Next.
How will you manage this case?
Sir, just a minute, sir. This PTH was elevated, sir. This could be due to FGF23 mediated alpha hydroxylase inhibition also, because active form of vitamin D is not formed in this patient, sir. Next. So, next. Sir, regarding the management, sir, our patient, we are probably dealing with an X-linked hypophosphatemic rickets, sir. So in this case, I will give active form of the vitamin D, because it is not formed in the patient's body, although 25 hydroxy vitamin D is normal. So I will treat the patient with active form of vitamin D, either with calcitriol or alpha calcidiol, along with phosphate supplementation. So with this flow chart, sir, patient presented with rickets with radiological manifestations. It was biochemically proven, and then on investigation we found out that it was low phosphate. So we were on the right side of the flow chart. So it's a phosphogenic rickets. Now this TMP-GFR could not help us here. If it would have been low, then a possibility of FGF23 mediated disorders we'll look into along with RTA. RTA we have ruled out already. TMP-GFR, if it is high, then nutritional phosphate depletion is a possibility.
So in this case, though it was very classically kind of a phosphopenic rickets, there are some odd points where you could see that they could not demonstrate that there was phosphaturia. It was more or less in the normal range. This could be probably due to the child was not taking enough phosphate, could be one of the reasons. And here we had, though PTH level, we expect a normal PTH level. Here the PTH level was slightly elevated. This could be maybe due to FGF23 mediated. So this is a good case for us where we don't get perfectly all the investigations fitting into a case. But still we can explain this complex interplay of FGF23, PTH, and 1-alpha hydroxylase, and how phosphaturia, how these are all delicately balanced in our body, so that one deficiency can easily push the child into a resistant form of rickets. So we'll end here with 2 take-home points for all the, especially the pediatricians. Yes, sir.
Just show the genetics. Genetic study was done in this patient, and
sir, actually, our elder sister was presented to us. That time, her genetic sample was done, sir. So that was suggestive of X-linked dominant fake gene was mutated, sir. So it was XLH, and we would suspect that this baby is also having the same mutation in the family, sir. So
yeah, most important thing for all of us to remember, though nutritional rickets are the most common cause of rickets. So for that, a simple X-ray is enough to diagnose and treat. We don't have to do any elaborate investigations at all. And whenever we're investigating, sir said calcium phosphate, alkaline phosphate, don't miss out one of them. And it's important to identify refractory rickets based on history and examination, and identify and treat early. And of course, like sir said, the mutation is very important in this child, because we have to counsel the parents we have to counsel the family and offer them pre-implantation diagnosis and also screen the susceptible siblings and other relatives who are at risk. Here's one last question you wanted to ask the postgraduates who may be interested. What is we have conventional therapy. This is a new therapy which is not yet available in India, but still it's a point which the postgraduates may like to learn. So how does this act? What is the role of Birosumab?
Sir, Birosumab is a monoclonal antibody which they block the FGF23 receptor. So thereby the FGF23 mediated phosphaturia will be taken care of. So with this therapy, sir, phosphate level could be normalized. Like with normal phosphate therapy, our target is not to normalize the phosphate level, sir, because that could lead to hyperparathyroidism. But with Birosumab, the target is to have a normal phosphate level. So that could be achieved, sir.
Yeah, thank you. This, as he said, it's a selective FGF receptor blocking thing. So that in an X-linked hyperphosphatemia rickets, FGF23 is very high. So by blocking this, you actually treat the patient quite effectively. Thank you.
Thank you, sir.
So thank you everyone for the interesting case scenarios and productive discussions. So now we move on to the final session for today, emergency and adolescent endocrinology. And to chair this, I call upon Dr. Ramanathan, Professor and Head Department of Pediatrics, RMMCH Chidambaram, and Dr. Bharat Ramji, Consultant Endocrinologist, ARCA Center for Hormonal Health, Chennai.
We have come to the last session of today. So it's my pleasure to invite Dr. Narayanan to talk about endocrine emergencies in children. For want of time, we will directly go to the topic.
A very good afternoon to everyone. So that's because maybe they're all my PGs. First of all, I'd like to thank the organizers, especially Dr. Vijayabhasar Reddy, for inviting me for this talk. I soon realized that I'm the odd man out because most of the lectures are given by endocrinologists, and I'm not an endocrinologist. So I have some disclaimers to start with. First of all, I may not be qualified to give this, stand in this and give a talk on an endocrine seminar. But I accepted because of two reasons. One is, of course, Vijayabhasar Reddy is my classmate and long-time friend, so I can't say no to him. The second thing is, he said you talk only on emergency areas, which is my area of interest. I work in pediatric ICU, which is far away from endocrinology. Endocrinology is basically a OPD-based practice and very stable patients. So anyway, with these two disclaimers, I accepted the talk. It is on pediatric emergencies. So we will just, I'm planning to show just 4 or 5 cases which we have managed. In them, we are not going to concentrate on the endocrine aspects. I thought we'll talk on how to recognize an endocrine emergency among all the common emergencies we see, and how to stabilize them for the first few hours or days. So we'll not be discussing their chronic management or the real diagnosis of these conditions. Yeah, slides have come up. Okay, so we can start. So we'll start with the first case. So this is a 3-month-old baby who came with poor feeding and lethargy for 3 days. At presentation, child was apneic and hypotensive shock when he came to our emergency. So child was resuscitated appropriately, was intubated, given IV fluids and inotropes. The child required both adrenaline and noradrenaline infusions to maintain the stable hemodynamics. So at this point, our diagnosis was, as usual, 3-month-old child coming very sick like this, some respiratory infection or some other infection with sepsis was our diagnosis. But subsequently, over the next around 24 to 48 hours, sepsis workup were non-contributory. Just child had some slight leukocytosis. The rest of the things like all the inflammatory markers, cultures and all didn't grow anything in the first 48 hours. And child had some odd feature. Child had persistent bradycardia and hypothermia. Initially, we thought when child came, because child was in shock and hypothermic, we thought it is because of hypothermia, the heart rate is low and child is very sick. But even after resuscitation, child was in the kept in a warmer for many hours, still bradycardia persisted. It's very unusual for us. The classical simple teaching in MBBS is that whenever child is in shock, you should have tachycardia. But this child had bradycardia. Of course, the usual reasons we ruled out, child did not have any hyperkalemia or severe acidosis or something which can explain the bradycardia, and temperature instability persisted, even though child was kept in a warmer. Then we decided that maybe it's time to look at the child properly, because in ICU, what happens is that child is full of plaster, all those monitors attached. So you come look at the monitor, look at the ventilator, and you just go away and look at the lab reports. So then we decided to look at the child in great detail. We found that child had some coarse facies. Of course, we had already noticed the wide open anterior and pitting edema, but that time we didn't take it seriously because we thought because of the shock and IV fluids we given, child has got some edema. But this was persisting after 48 hours. Then we suspected that child may be having underlying hypothyroidism, as TSS showed more than 150, of course. Within 24 hours we could get the value. And at this time also child was still having all the bradycardia, hypothermia, and persistent need for anatropes. So we thought maybe child is having a mixed edema crisis. Even though I was not fully convinced because it's a very rare diagnosis. I keep telling all my residents that you should rarely think of rare diseases. But then in this child we thought it's a possibility. And then we started the management. We gave some hydrocortisone, and we started the child on thyroxine. IV was not available, so we had to give an oral levothyroxine. There was significant improvement, dramatic improvement over the next 48 hours. Child had heart rate around settled, and we could wean off all the anatropes and extubate the child and send the child home. So final diagnosis was hypothermia. We reported this case. So the messages from this child is that one is attention to vitals is very important. Okay, bradycardia in shock, you should always, simple things. A child in shock should be tachycardic. If it's bradycardia, you should have a very valid explanation. The common things will be a child who has hypothermia or a hyperkalemia or something like that. When these common things are ruled out, they should have a tachycardia. And of course, you should take an ECG to rule out any underlying cardiac arrhythmias, bradyarrhythmias, which was normal. So this was a clue in this child which was overlooked for the first 24 to 48 hours by us. And clinical examination is important everywhere, including ICU, where you pick up even hypothyroidism. And of course, hypothyroidism is a common mimicker. I know morning they might have told you in the hypothyroidism class is a great mimicker. It can present in any system everywhere, and frequently missed even in a sick child. Another valid point here is that because we had a doubt whether we can give oral thyroxine supplementation for a child in mixed edema crisis, but after we reviewed the literature, we found that lots of people have treated like that and they have recovered. Okay, so that's case 1. Then we go to case 2. This is a 3-year-old child on regular daily L-troxin for hyperthyroidism. This child was taking L-troxin because of congenital hyperthyroidism. Brought the ingestion of 10 to 15 tablets of L-troxin. Child is allowed suddenly. They were not sure how many tablets, definitely more than 10, maybe 20. And we examined the child was conscious, oriented, stable vitals. So what can happen? So initially, most people say that no, we'll have to give some anti-thyroid drugs and all that stuff for this child. But thyroid is a hormone, and there's a feedback mechanism in the body. So thyroid, so usually nothing happens. So the message is that most of the time this children does not need any management other than looking for any signs of hyperthyroidism. So with this child we observed for 3-4 days in our hospital. Child was completely stable. Now not had any tachycardia or any other feature of hyperthyroidism, and child was discharged home. So in most cases there will be no manifestations, but very rarely. If you look at literature, CVC, very few of, for example, there was a series showing around 78 children, less than 20% had any features of hyperthyroidism. So majority, 75 to 80% will be asymptomatic. And if at all they're symptomatic, management is only symptomatic. Same. You don't want to give any anti-thyroid drugs and all that stuff. Just give beta blockers and they will, for a few days, and they'll settle down. Okay, that is case 2. Case 3 is the 6-year-old boy who came with a history of abnormal posturing of both hands since morning with irritability. So mother was saying that he has some kind of vague movements and irritable, and was suspected to be of seizures outside. They given some anti-epileptic and sent the child to us. But then we ask history. There are similar episodes treated in the past in multiple hospitals. So when he was there, when we were seeing him in the emergency, he suddenly had suddenly became irritable. He was shouting and all that violent behavior. Then after that he calmed down and he was sleeping. So this was happening frequently, it seems. So we were wondering why this is happening. And then on examination, CNS examination, he didn't have anything to suggest any CNS problem. No focal deficits. Pupils were normal. His heart rate was suspiciously again, bradycardia, 55 to 60 per minute. And ECG showed sinus bradycardia with a QTC of 440. So this was the clue. So we thought, why he should have this? Then luckily, while we are examining the patient further, he had a, that abnormal movement. But mother was saying it was tetany. It was a clinical case of tetany. So, but we cannot explain the irritability and alter sensorium. Then subsequently, it turned out to be that when he was bradycardic, because of the bradycardia, he was having low perfusion to the brain. That time only he was having some irritability. That was the only explanation we could get. So as usual, calcium was low, PTH was very low, and it turned out to be a hypoparathyroidism. So this was an endocrine case which presented as a autosensorium seizures to us. It turned out to be an endocrine problem. He was managed well. Follow-up, he was doing well with vitamin D supplementation and calcium. Yeah, so in this case, messages are all abnormal movements, even when associated with autosensorium, are not seizures. And bradycardia is useful again. Always take an ECG if you find a child with bradycardia, which is not fitting into. Most children, when they are sick, they should have tachycardia. If bradycardia is there, always it's abnormal in a sick child, unless there is a severe hypoxia or acidosis or hyperkalemia. And of course, tetany. If you are lucky to have nowadays it's very easy because most mothers will come with a picture of or video of the abnormal movements, so you can easily pick up. It has a characteristic appearance. Case 4. This is a 10-year-old girl who came with respiratory distress for 1 week, vomiting for 2 episodes 4 days back, autosensorium for 4 days, this was the history. Yeah, so this was the history when she approached in the first hospital, and she was seen by the 2 to 3 local practitioners, and they were treating her for some respiratory problem, maybe wheezing or something, and they gave an injection Derifilin or something. Then she went to a local hospital where they developed increasing distress and developed autosensorium. At that point, this local private hospital, they referred her to a medical college. When she came to medical college, she was unresponsive with fast breathing, history of fast breathing during the transit period, and she was received with a low GCS of 3/15, required intubation. So what do you think is the diagnosis? Yeah, so I mean, since it's an endocrine talk, it has to be that, emergency. Yeah, so yeah, it was, so the medical college, they managed her as a severe decay for 4 days. She required intubation and admission, so very sick. But her sensorium did not improve even after the decay management. They managed for 3 to 4 days. She had rising creatinine and persistent autosensorium, and then she was referred to us. So then she came at this state after 4 or 5 days of decay management. So if you see the history, here again, if you see the history, if you again go back, retrospectively, most of us are very wise. If you go back again, that history was there, as usual. There was a polyuria and polydipsia history for 1 month, which was missed. So then she came with intubated with a serum creatinine of 2.7. So possibility we considered at that point was, of course, autosensorium we attributed to either decay. As you know, pediatrics, they can go into cerebral edema, even though small proportion. So that was a possibility for CNS infection, osmotic demyelination, uremia, and this child was on a ventilator, so she was getting a lot of morphine and midazolam and all that when she was having a significant AKI. So maybe sedative overdose also be considered. And of course, AKI, she has also a significant AKI, most probably because of severe dehydration, hypoxia producing acute tubular necrosis or even sepsis. So she was quite sick, but luckily for us, just with conservative management, she came out. We just gave her only some IV fluids, and she had properly recovered from the decay by the time she came. Her ketones were almost almost zero, beta hydroxybutyrate. So we just gave her fluids and antibiotics, and with that she recovered. The kidney function spontaneously started improving, and antibodies were given till the cultures were negative, and we didn't do an LP because her sensor improved dramatically after stopping the sedation. Most probably it was because of sedative overdose. So the messages in this child is, one is suspect early. DK, see this case, because DK is the commonest endocrine emergency we see. Most of them just fly away from the emergency, through the ICU with, safely, nothing happens, just that protocol you follow. But early detection is very important. Suspect early. Nowadays, point of care blood sugar is available everywhere. So I think any sick child coming to any emergency, you should always do a blood sugar. Otherwise, you'll miss it. Because DK is sometimes commonly missed. Second thing is, insulin is important. When we were residents, we were told that the most important thing in the DK management, say 25 years back, was insulin. So at that time, protocol is, as soon as the patient comes, we give 1 bolus dose of insulin, 1 units per kilo. Then start at 0.1 units per kg per hour and concentrate on insulin, and we'll be charting the sugars, how the sugar is falling. Some IV fluids will go. So thrust was more on insulin rather than fluids and electrolytes. But of course, now we slowly realize that that is not the issue. DK, insulin of course is very important. The moment you start insulin at a low dose, the problem is reversed. There's insulin deficiency, you have replaced it. Now, the child is remaining sick because of fluid electrolyte problem, severely dehydrated and electrolyte imbalance, hyperosmolarity. So, you should concentrate all your effort on correcting that slowly. So, DK management is mainly fluid and electrolyte imbalance restoration. And of course, insulin is very important. I keep telling that my residents that if the patient on DK is not improving, first possibility is insulin not going, second possibility insulin not going, third possibility insulin not going. So that is very important. Insulin has to go, but at the same time concentrate on this very aggressively and be gentle. Nowadays, the management has changed from bolus dose of insulin at admission to now bolus, first you give fluids at admission. We're starting insulin only after 1 hour nowadays. So first is always fluid electrolyte. That shows that what is more important. All right. Yeah. And of course, I thought I'll put a few more words on the cerebral edema and decay. So when it is a dreaded complication, all of you know, reported to be about 2%, 5% in different series. Previously, we used to attribute it to excessive fluid administration. When we were residents, we used to blame fluid. So we used to calculate around 4 liter per meter square in the first 24 hours was a cutoff. Anything beyond that, we will have cerebral edema and all that stuff. But I'm sure you might have seen this trial. This was the trial which came in 2018, Picard and decay fluid trial from NEJM, published in NEJM. So this is a randomized trial, factorial trial. So this is the conclusion, if you see. Neither the rate of administration nor the sodium chloride content of intravenous fluids affected the outcomes affected neurological outcomes in decay. That means whether the child has cerebral edema or not is nothing to do with the fluid you give, how fast you give, how slow you give, or what composition. Okay, we're not going to the details of this study, but it is a large study, 1,255 children. So it's quite a landmark study here. So what is this study says is that may not be the fluid which produces cerebral edema. So then what is that which produces cerebral edema? So most of it is because the severe presentation. That is the thinking right now. We feel that the more severe the presentation, in fact some of the studies which show that most decay, if you do MRI and other things at admission, around 10 to 25% of the children have some amount of cerebral edema even at admission. So if you get dehydrated for a long time with hyperosmolarity, your brain get damaged. So the more severe that is, the more chance of you having cerebral edema. It may not have nothing to do with the way you manage the patients with fluids. Even though that is important, it is not that important as we thought previously. Okay, this is the last case, I think. So this is a 15-day-old male baby, patient with vomiting, poor feeding, and lethargy on 1 day of duration. And on examination, child had mild dehydration and hyperpigmentation. I'm sure you can easily diagnose this now. Okay. So there's nothing strange in the diagnosis. Of course, as expected, serum sodium was 100, and the classical presentation around second week of life, sodium of 100, potassium more than 6. So we were very convinced that this is a case of CAH. Okay, so very easy diagnosis. Day one, we are very proud of ourselves. We patted us on our back and all that, and then started treatment. Obviously, started IV fluids, hydrocortisone, and whatever, even fluorocortisone. Yeah, I forgot to add that. Then child improved over the next 24 to 48 hours because of our excellent management. But then we got shocked. All the workup for everything came negative. CH was, certainly progesterone was normal, serum cortisol was normal. So we didn't believe. So we, as usual, whenever report is wrong, we say report is wrong. So we repeated it again outside, but still the values were the same. Then we thought maybe there's something wrong. Then by the time the urine cultures we sent had come, urine had gone E. coli, and child, as usual, for the workup for UTI, we did an ultrasound KUB, showed right hydronephrosis. Okay. Then we thought maybe something is wrong. So we started thinking and reading up and started diagnosing. Then we sent some more hormones. We found the serum aldosterone level is very high, okay, more than 1,355. This is more. So finally, it turned out to be pseudo-hypoaldosteronism type 1. So this condition, there are multiple types. There are genetic variants, type 1, type 2 and all. What this child had, this typical presentation is, suppose a child has a congenital obstructed urinary tract, and on top of it, he develops an infection. They can develop some kind of transient resistance to aldosterone. Exact mechanism is, of course, described in literature, but nobody knows how it is. It produces some kind of toxin-mediated damage to the receptor and all that stuff. So this child had that. So of course we published it as usual because very rare, and we were wrong. So what are the take-home messages from this child? One is, do not jump to conclusions. Like us, don't start patting yourself very early. Keep an open mind. All sick infants with hyponatremia and hyperkalemia are not CAH. Okay. Even though they said there is a commonest, of course it's the commonest, but all of them are not. So rare diagnosis can also be made if we approach the case systematically and read up. Of course, that is, reading up also is important. CAH needs to be recognized, but please don't take this case as saying that CAH is not be diagnosed. I'm saying that CAH should be diagnosed. All of us know that a combination of hyponatremia, hyperkalemia, hyperglycemia is typical of CAH with hyperpigmentation. But even then, I don't assume that all of them are CAH. Right now, it's not a very uncommon case. Right now, we have another case of suspected this in our ICU right now. This pseudo-hypoaldosteronism. Sometimes we overdiagnose this condition. Yeah, I think that's it. Thank you. There is five more minutes. If any questions, I will be happy to answer. Any questions?
Thank you, Dr. Narayanan, for making it very short and sweet, but your message was loud and clear. So the topic is open for the floor for discussion. Any questions
or any other endocrine emergency, if you want to ask, I can. Well, endocrine emergencies are not very common, other than decay. Decay management is, I didn't talk much because it is all standardized. All the guidelines are freely available in the internet. You can just read it and do it. Yeah, thank you.
Thank you very much, sir. So we'll go on to the next topic. It's delayed puberty in male by Dr. Vignesh, who is a consultant endocrinologist from Trichy.
So at the outset, I would like to thank the organizers for having given me this opportunity. Maybe I will keep it short, maybe the post-lunch session. So I'll restrict my talk on delayed puberty only on males. So it is common in males, though it can happen in females also. So for want of time, I'm just covering only male delayed puberty. So my preview will be what is normal puberty, and when do we say it is delayed, and how to evaluate, and how to manage such boys who present with delayed puberty. So by definition, puberty is a period where the adolescent reaches sexual maturity and becoming capable of reproduction. But the endocrine definition adds up some more. So it is a period of growth acceleration. So a boy, so other than the infantile period or other than the first few years of life, so puberty is a period where they will have highest growth velocity, and there will be alteration in the body composition. So there will be accumulation of the accumulation of the bone mineral or increase in the peak bone mass during the time of puberty, and appearance of the secondary sexual characters. So it has growth, it has improves the height potential, it increases the bone mass, and it is responsible for the appearance of secondary sexual characters. So basically we all know puberty. So it is initiated by the GnRH group of neurons, where it secretes hypothalamic neurons, where GnRH is secreted in a pulsatile fashion, and it stimulates the anterior pituitary, causes releasing of both the gonadotrophin FSH and LH, and these gonadotrophin in turn acts on the ovaries and testes to release the sex steroids, especially estrogen and testosterone, which has a negative feedback effect on both the hypothalamus and the pituitary. So this is the simpler one, and this is the more complex one. There are multiple peptide hormones involved in this stimulation of or initiation of puberty or stimulation of this puberty and progression of puberty. So including kisspeptine or various other peptide hormones are involved. I'm not just going to go in detail. So puberty, so how do you evaluate and how do you assess clinically? This is by what we go clinically by Turner staging. So onset of puberty in females, it is marked by breast development. So though theoretically we say increase in the height spurt is the most common, most earliest sign of puberty in a female, but most often what we see clinically is the breast development Turner stage 2. In case of males, testicular enlargement is the most clinical sign of puberty. So everyone in our during our period, we always have our archidometer. We generally don't go by imagination. So every child, male child who comes for evaluation of delayed puberty, we assess the child testicular volume clinically. Most of the time, as the previous speakers clearly told, the ultrasound given volume of the testis is not so accurate unless it is given by a pediatric trained sonologist. So many times they give volumes 0.5 ml, 1 ml like that, but clinically if you see it comes as 2 ml or 3 ml by archidometer. So it is worth to have an archidometer to document our testicular volume and follow them up every 6 monthly or yearly when we are following the child for evaluation of delayed puberty. Always check that whether there is an increase in size of testis. It gives a clinical clue. It can avoid a lot of unnecessary investigation in a child with delayed puberty. So these are the stages of delayed puberty. I'm not going into detail. Pubic hair stage 1 to 5. So initially there will be stage 0 is no pubic hair, and stage 1 is sparse hair at the root of the penis. Stage 2 is stage 3 is curled dark hair, and stage 4 is hair over the inner thighs, and stage 5 is hair over in the infraumbilical region. So similarly, there is a staging for genitals. So when we see, we all know that first clinical sign of puberty in a male is testicular volume. So only by measuring the testicular volume, only by seeing the testes with the orchidometer, we can able to say which stage of whether it is prepubertal or pubertal, and we can follow them up with puberty. So first stage, so it is not 2 cc, it is 4 ml. So anything more than 4 ml testis is pubertal testis. Less than 4 ml is prepubertal. This is followed by adrenarche, and this is followed by penile growth, and this is followed by height velocity. The height velocity comes very late in late stages of puberty in males, whereas in females it comes early. It's in the second stage of puberty itself, second B2 stage itself, they have started having a height spurt, and the peak will be at stage 3. So whereas in males the height velocity will be peaking in the stage 4. This is followed by development of further progression of puberty. So delayed puberty is relatively common condition in males. So almost 3% of children can have a delayed puberty, whereas it's less than 1% in females. So it is more common. Whereas precocious puberty is common in females, delayed puberty is common in males. So when do we say it is delayed puberty? So it is failure of onset of secondary sexual characters. That is pubic hair, testicular volume, all those things. So if you could not find a sign of puberty by 14 years in a boy, we call as a delayed puberty. Whereas if you could not find a breast development, thelarche, by 13 years in a girl, we call it a delayed puberty. So if somebody has developed some sign of puberty and there is no progression in next 4 to 5 years, if you could not able to progress and reach as an adult stage, where we call as a pubertal failure or pubertal arrest. So puberty, maximum duration of puberty is 5 years. Median duration is 3 years. So if a child could not have a complete transition in 4 to 5 years of pubertal onset, we call as pubertal arrest. So etiology wise, the most commoner thing we see in boys is a CDGP, constitutional delay in growth and puberty, which constitutes almost nearly 2/3 of all the causes. This followed by a systemic cause. Systemic cause can be anything. So many times we may have a subclinical systemic cause. We need to put a leading question. Many times they come with a chronic liver disease history or old notes, juvenile rheumatoid arthritis or uncontrolled diabetes or cystic fibrosis will have a history. Sometimes it may be occult also. They may have a rheumatoid arthritis or inflammatory bowel disease. So we need to have a detailed history and look at the previous old records. And other less common causes are hypothalamic cause or a gonadal cause. Which hypothalamic cause most common being idiopathic or isolated gonadotrophic hypogonadism or Kalman syndrome, and gonadal cause the most common being Klinefelter syndrome. So to evaluate, so always history is more important. By doing a very good history and clinical examination, 90% of the time we can come to a diagnosis. So only we do the investigation to support our diagnosis, not to diagnose the patient. So clinical and especially in pediatric endocrinology in short stature and delayed puberty history and charting our all the findings in the growth chart will able to make some good diagnosis. So and we do because there is a large set of investigations. If we start doing, we will be wasting our resources. So make some clinical diagnosis and go by the clinical diagnosis. Always get a detailed history about chronic or intermittent illness, history of nutrition, poor nutrition. Nutritional anemia itself can cause delayed puberty, or a lean body weight can cause delayed puberty in females, especially like athletes kind of thing. And all facts in history, many times even they may not have complete anosmia. They have a partial anosmia or hyponosmia. So even patient may not be aware that they have a olfactory defect, like in Kalman syndrome. We have to put a leading question and we have to test with the substance. And usually we use scent. And also other history like history of mental retardation and language problem, or hearing loss problem. So we should always put a leading question. In symptom wise, most of the time, if you, like a SOL sitting at the pituitary, like craniopharyngioma, pituitary, they may not have, all patients may not have symptoms like headache, vomiting, or blaring of vision. Sometimes we see a 2 centimeter or 3 centimeter craniopharyngioma sitting over there. The child may be absolutely asymptomatic, come for only for short stature. So we should always ask a history for hypothalamic pituitary disease like headache, vomiting kind of thing. If possible, do a fundoscopy evaluation. And antenatal history, family history is very important. CDGP, almost nearly 2/3 of patients will have a family history. Father also says, sir, I also developed all mustache beard only when I entered the college, or only at the time of marriage I got all those beard mustache. So family history is very important. Physical examination, height, weight, BMI, upper segment, lower segment, so maturity of the upper segment and lower segment ratios, all those, and mark the growth and all the parameters in the growth chart and see where the child is sitting, which centile the child is sitting, and if preferably if you have a previous data on height and weight, plot them in the chart and see whether the child is crossing the centiles from a higher centile to lower centile, all those things. If you have data for last 6 to 12 months, please plot it in the growth chart and see. So if the growth velocity is less than 3 centimeter per year, it's probably you are dealing with the pathological cause of delayed puberty and short stature. So clinical examination is vital. And other than neurological examination, olfaction examination is mandatory, and certain CNS defects like in Kalman syndrome kind of thing, so they can have a central CNS defects or a cleft palate kind of thing, midline defects, mirror image movements, all those can happen. And visual fields, if you suspect a CNS lesion, always examine for a visual field. So they may not come with a history of visual field unless we examine clinically. Only then we can make it out. And 6-time examination is a must. And growth rate. So normally we expect during mid-childhood expect a growth velocity of around 5 to 6 centimeter per year. So any child, there may be some pre-pubertal slowing of growth. For example, up to 3.5 to 4 centimeter per year can occur during pre-pubertal slowing. That's for a short 6 months duration. So any child who present with growth velocity, if you have a proper growth chart and if you have height plotted, and if you find growth velocity is less than 3 centimeter, probably you are dealing with a pathological cause. It can be a growth hormone deficiency, hypothyroidism, or hypocortisolism. And again, growth velocity is also decrease in CDGP also. Growth velocity corresponds to the bone age, not to the chronological age. So in CDGP, growth velocity corresponds to the bone age. So that has to be kept in mind. So any child presenting with delayed puberty and short stature, two things, CDGP and MPHDs will come in your mind. So next most important investigation is bone age evaluation. So it should be done in all patients with short stature and delayed puberty. And we always use a groove. So though there are, as Dr. C. Ramagadhan sir pointed out, there are some clinical clues that age, if sesamoid appears, it is 11 years, or if pisiform appears. So there are certain things, but always better to have a chart. It is available online. There are many charts are available. We usually follow GP chart. So we always compare the X-ray of the left hand and almost try to get a almost accurate bone age of the child. Usually bone age, in delayed puberty, bone age will be less than the chronological age. If it is delayed more than 2 years, probably you are dealing with a CDGP. So coming to the biochemical investigation. So once we come to a clinical diagnosis, that we are convinced that the child has a delayed puberty. Why it is important is that most of the time, our clinical practice, the child referred for small genitalia is not a delayed puberty. It is like an obese child with a buried penis. Most of the time we get an endocrine referral, obese child with a small penis, buried penis, it is a most common referral, it is not a delayed puberty. So once you get convinced that you are dealing with a delayed puberty, then you go for a set of investigation, complete blood count, look for anemia, chronic anemia can cause, and ESR, it is very important, we may be dealing with the inflammatory bowel disease or juvenile rheumatoid arthritis, so it is important. Creatinine, electrolytes, distal rheumatoid acidosis can have a low bicarb and hypokalemia, alkaline phosphatase and LFT, and thyroid function test, of course, it has to be done basically in all patients. And so once the basic evaluation is normal, so then we go for a hormone evaluation. So the most important 4 tests, FSH/LS and gonadotropin, that is then followed by sex hormone, testosterone or estrogen in females, and prolactin. So testosterone, if you find a value like more than 20 nanogram per deciliter, probably the child has entered into the puberty. He may not have shown clinical sign of puberty. So testosterone value, done with a good standard lab, early morning sample, if it is more than 20, it is probably suggestive of the child has entered into the puberty. We can reassure the parents at one go, and we can watch the child clinically. No need to go for further investigation. And probably we can tell them that within a period of 1 year, the child may show the clinical signs of puberty. And next important investigation, LS and FSH. If it is done in a standard lab, third generation assay, if it is accurate, we can have multiple cutoffs. So if it is a random LH, it is better. So if it is low, less than 0.1 to 2, it can be prepubertal, or it can be hypo, or it can be a CDGP. If it is more than 0.2, means the central puberty has started. If it is more than 0.6, some authors say it is more than 0.8. If you see a child with more than 0.8, means the child has entered into the puberty. So just we can reassure them at stop at this point of time. Suppose the LH is elevated, more than 10 or more than 15 or more than 20, we are dealing with a patient of hypergonadotrophic hypogonadism, which can be a Klinefelter syndrome or idiopathic. So FSH, LH is more important than FSH. Suppose FSH is very low, it can be a hypo, or if it is more than the upper limit, like 10, 20 or 30 like that, so probably we are dealing with a hyper-hypo. Most common clinical hyper-hypo is Klinefelter syndrome. So we generally try to avoid all these investigations like growth hormone unless the child has severe short stature or clinical clues of some central involvement like multiple pituitary hormone deficiency. Otherwise, we generally don't do other pituitary hormone involvement. And there are multiple other tests. So if you are not convinced with if you could not come to a conclusion with doing a testosterone FSH-LH, so there are certain other tests where we can do to differentiate as constitutional delay. This is in normal variant from a pathological one. So our problem is we have to convince the parents whether we are dealing with a normal variant or with this a pathological one. So at this point of this, there are multiple other dynamic tests has been done, but with limited success, limited sensitivity and specificity. So one is the GNRS stimulation test, give a leuprolide and check the LH levels. If it is more than 5 or 8, we can say he has a pubertal onset. Probably we are dealing with CDGP, not a pathological CHS. And other one is a HCG stimulation test where we give injection human chorionic gonadotrophin and we do a testosterone level. If it is like more than 230, we say it is probably the child is safe. So it is a CDGP, it will enter into the puberty in a short while. Suppose if it is very low, we can say it is probably hypo. And inhibin V, it is a marker of Sertoli cells, function of Sertoli cells. So inhibin V will be elevated in CDGP, can be low in hypo. The problem is this dynamic test has very overlapping. Sensitivity and specificity are poor. So there may be overlapping values between CDGP and hypo. So it is very difficult. And only in cases of suspected CNS lesion or a suspected Kallmann syndrome or pituitary adenoma, then only we do an MRI or a multiple pituitary hormone deficiency. Otherwise, we generally don't do an MRI for patient with delayed puberty. Only in precocious puberty, we try to go for an MRI. Delayed puberty generally is not required unless we have a specific cause. And karyotyping is useful for diagnosing Klinefelter syndrome or gonadal dysgenesis. So let me just point out most important causes of delayed puberty in a nutshell. One most common is in male is CDGP. It is a diagnosis of exclusion. So no systemic illness, normal physical examination, normal basic investigation, a normal thyroid function test, a normal nutrition. So, but child is at the lower centile, third centile, with a normal growth velocity for bone age, not for the chronological age. So probably we are suspecting CDGP. They have a delayed puberty, short stature, and delayed bone age. But predicted height, they will have a late pickup, and the predicted height will be expected to be normal. Say they grow along the lower centile with a constant growth velocity. But once they reach around 18 years, they have a late pickup of the growth velocity, and they reach the near normal adult height. This CDGP. So this is a normal variant, what we call as a delay in reactivation of pulse generator, what we call as a lazy pituitary. So this is very common in boys. So in where the puberty can be delayed by 2 to 3 years, And the family history always be there in nearly 2/3 of patients. And we can just, if you could able to clinically diagnose and make it to some extent, we can reassure the parents, don't get panic, your child will get into puberty. So there are various, already we have discussed, various tests that try to differentiate the CDGP from hypo. But at the end, what we conclude is no single test has the power to discriminate both these conditions. So it is really difficult. There will be overlapping, so we can't reassure. To some extent, we can say the non-progression of puberty by 18 years. The child has attained 18 years, but there is no progression of puberty or no initiation of puberty. We can clearly say it is not CDGP. It is hypogonadism. So the time only answers this question. So if we diagnose CDGP, the parent is anxious about the parents and child is anxious about the delayed puberty. We can give a short course of testosterone, low dose testosterone, maybe 4 to 6 months, 50 to 100 mg, not full dose. This will cause increase in growth, increase in the height, and accelerated puberty, and it will not affect the final height. So the problem in giving testosterone is it should not affect the height. So by inducing puberty, we should not make the child short. So short course, low dose testosterone will be helpful, but not more than 6 doses. There are some people will give 12 course, 18 course, so that is not advisable. So next commonly we see is hypo. So where we'll have a low testosterone, low FSH, low LH, and low response to gonadotropin. And the most commonest form is the Kallmann syndrome. So there are 3 forms, 1, 2, 3, and they will have anosmia. So they may have hyposmia. And they will have abnormal limb movements or mirror image movements where we call as synkinesia or midline abnormalities, cleft palate. Associatedly, they can have midline abnormalities or CNS abnormalities or hearing loss, all those things. So when a child has hearing loss or central abnormality with delayed puberty, tall stature, always that is also a clinical clue. We can straight away ask for FSH, LH, gonadotropin, then straight away go for an MRI, take an MRI, just see whether there is a hyperplasia of the olfactory cortex. So they may have a hyperplasia of olfactory cortex or olfactory bulb or tract. So, and if you suspect a child with cellular mass, they usually have a panhypopituitarism, acquired growth failure. They may or may not have symptoms of SOL, and the diagnosis is based on this thing. And this is one of my patients who presented with short stature and delayed puberty, evaluated, found to have a craniopharyngoma, but she does not have any symptom of headache or vomiting or visual disturbance on clinical history and examination. Only by evaluation we just did a MRI, then it came out to be craniopharyngoma. And last 2 or 3 slides. So next most common thing which we see in clinical practice is Klinefelter syndrome. Is a hypo. They will be tall and they will have a reduced head circumference. They present with gynecomastia because of more higher estrogen and testosterone ratios. They come with the history of, or they can present later with the history of decreased libido or decreased erectile function or infertility. So when we have a child with a boy with the delayed puberty, most important thing, if you are convinced that the child has delayed puberty clinically, then go for a gonadotropin. If it is like elevated, is probably you are dealing with Klinefelter syndrome. So suppose if it is low, most common cause is constitutional delay. So if it is constitutional delay is ruled out, or if clinical signs of CNS tumor, always go for MRI imaging to look for a CNS tumor. And if there is an anosmia, probably you are dealing with a Kallmann syndrome. So management, our aim is to induce and maintain the secondary sexual characters, induce a pubertal growth spurt, and to maintain them normal sexual function, to get them to normal fertility and prevent psychological and personality issues. Generally, for induction of puberty, we always try with testosterone with the lowest possible dose, like 50 milligram. So adult dose is 250 milligram, start with 250 milligram and increase it every 3 to 6 months. There is no hurrying. So if we start with a higher dose, because of sensitivity, they can develop priapism. So that is also a complication of therapy. So always start with the low dose, titrate gradually over a period of months. So summarizing, so delayed puberty is in male is a common condition, and CDGP is the most common cause of delayed puberty in males. And if we suspect hypogonadism, appropriate evaluation and timely induction of puberty restores the height spurt, bone mass, and self-esteem. And if there are fertility and psychological issues, please take specialist care. Thank you for your patient hearing. So I'd like to take questions.
Thank you, Dr. Vignesh. If there are any questions, I think everyone is in the post-absorptive state. So I think we will move on to the next session then.
Thank you.
So the last session is on adolescent girl with hirsutism. The talk will be given by Dr. Ram Kumar, endocrinologist from Chennai.
Good afternoon, everybody. I sincerely thank the organizing committee and Dr. Vijay Reddy for giving this opportunity to talk on one of the important topics in adolescence, a girl with unwanted facial hair. You can also include a girl with irregular menstrual cycle here. Next slide. So I work as a pediatric endocrinology in Apollo Children's Hospital, and also I was working as a pediatric endocrinologist in Egmore Children's Hospital, and I have my own clinic. So basically most of my experience in adolescence is from Apollo Children's Hospital and from my own clinic. Next slide. So this is the plan of presentation. So we'll be discussing about how do you grade hirsutism, what are the different causes of unwanted facial hair, how do you make a diagnosis in an adult, and what is the difference between making a diagnosis of PCOD in an adult and versus in an adolescent, and what are the normal variations that you see in terms of the menstrual irregularity and polycystic appearance of the ovaries, and a flow chart to approach a case of hirsutism and some case scenarios. Next slide. So this is a modified FG score, the Ferryman-Galway score. So we have 9 areas. Easy way to remember is if you 4 pairs and 1 area chest. So in the lip and the upper lip and chin, we have 2 areas: upper abdomen, lower abdomen, upper back and lower back, and the arms and thighs. So the 8 areas and the chest area. So each area is graded as from 0 to 4. 0 means no hair growth, and depending upon the severity, it is graded from 1 to 4. So totally any girl can have a score ranging from 0 to 36. So as per the current criteria, FG score more than 8 is taken as hirsutism. Anything less than 8 is taken as a mild form of a hirsutism. And there are certain concepts that in Asia, even a lower FG score can be still taken as significant. So these are the different causes of hirsutism in adolescent age. The most common you all know is PCOD. Almost 90-95% of the cases will be a polycystic ovarian disease. And the other important causes are idiopathic hirsutism. Non-classic congenital adrenal hyperplasia is one important condition. Other causes that are commonly mentioned in textbooks like hyperprolactinemia, hypothyroidism, Cushing's, economically not in adolescents, glucocorticoid resistance, ovarian tumors, adrenal tumors are all often considered as diagnosis to be excluded before making a diagnosis of PCOD. Other rare causes include syndromes of severe insulin resistance, drugs like sodium valproate. You all know a lot of children on sodium valproate do gain a lot of weight, have developed severe acanthosis nigricans, and also hirsutism. We recently saw one girl, actually a 2-year-old with aromatase deficiency, who with the clitoromegaly, who is actually at risk of hirsutism at adolescence. This is one uncommon cause, disorders of sexual differentiation. Actually, the child may be reared as a girl till adolescence, but after entering into puberty, you can notice the masculine development, like the development of the facial hair and the masculine development, change in voice, etc. Next. So whenever, as I said, the most common cause of PCOD, and there are 3 important parameters that define polycystic ovarian syndrome. One is the androgen status, second is the menstrual history, third is the appearance of the ovaries on the ultrasound. With respect to the androgen status, it could be a clinical hyperandrogenism or a biochemical hyperandrogenism. When you say clinical hyperandrogenism, it could be either a hirsutism, acne, or androgenic alopecia. When you say biochemical hyperandrogenism, it refers to the elevated levels of total or free testosterone. Oligo-ovulation refers to infrequent menstrual cycles, but here we have to take it up infrequent menstrual cycles, and that is that is bleeding happening more than 35 days. So there are certain cases where the cycles can be regular, but still you can have anovulation, that is detected by measuring the mid-cycle progesterone levels. And regarding the appearance of ovaries, the PCO morphology is defined as the presence of 12 or more follicles 2 to 9 millimeter or increased ovarian volume. So based on these three parameters, the original 1990 the NIH definition, based on this, the definition of PCOD has been formulated. The original NIH statement, that is a diagnostic criteria of PCOD, stated that you should diagnose as PCOD only when both are present, hyperandrogenism or hyperandrogenemia and oligo-ovulation. Ultrasound appearance of PCO was not included initially. Subsequently, in the Rotterdam's criteria, they included ultrasound, and then they said out of the three, any two if present can be diagnostic of PCOD. Subsequently, they modified because of the issues that lot of women can have a menstrual irregularity which may settle, and they can have a polycystic appearance of ovaries. So then they modified the criteria that among the three, hyperandrogenism is mandatory, and among the two, anyone should be there. So this is the current diagnostic criteria for a PCOD in an adult. So according to this, if you have three criteria, if all three are present, we have the classical phenotype, the one. The B, C and D refers any two combinations. If you look at the third one, phenotype 4, that is non-hyperandrogenic PCOD, there is no hirsutism or high testosterone, but they have irregular menstrual cycles and polycystic appearance of ovaries. See what will happen if you use this criteria in adolescent, because lot of normal adolescents will have irregular menstrual cycles and they can have a polycystic appearance of ovaries. So the criteria was modified in adolescent that, and they removed the polycystic appearance of ovaries. They actually went back to the 1990 NIH criteria. So that both should be there, hyperandrogenism should be there, and the irregular menstrual cycle should be there. But they have certain important they have added certain that there should be a pattern that abnormal uterine bleeding must be present at least for a year, and that should be according to the post-menarchal age. And the evidence of hyperandrogenism may be in the form of a hirsutism, maybe in the form of androgenic alopecia, or in the form of acne, or in the form of a hirsutism or elevated total testosterone or free testosterone. So this is because lot of normal women after normal girls, they don't have regular menstrual cycles immediately after menarche. It may take at least 4 years for the menstrual cycles to become regular. So in the initial, the first year, if the cycle length up to 90 is considered normal, in the year 2 cycle up to 60 is considered normal, and in the year 3 cycle up to 45 days is considered normal, and beyond 4 years, and if they have menstrual cycles beyond 38 days, it is considered abnormal. Similarly, regarding the ultrasound appearance of the polycystic ovaries, 1/3 to 1/2 can have the same criteria that is mentioned for the PCO appearance. So PCO morphology are not diagnostic for making a diagnosis in an adolescent PCOD. So I'm just quoting the guidelines from the Endocrine Society US and the Pediatric Endocrine Society. These are the guidelines from the Endocrine Society that if you have a hirsutism, according to the FG score, if it is significant, then get a total testosterone done. For mild hirsutism, that is 1 or 2 hair growths without menstrual irregularity or without any other features to suggest PCOD, the testosterone levels need not be measured. That is the local therapy can be suggested for them. And if at the same time, if they have hirsutism, and even if the testosterone is normal or the free testosterone is normal, if they are from a high ethnic group, like if they have a family history of CAH, and then 17-hydroxyprogesterone must be done, even if testosterone and free testosterone are elevated. This is from the Pediatric Endocrine Society guidelines. In this guideline, actually, they have asked a few questions, and then by consensus, they have arrived at certain recommendations. So these are just as what I said earlier. So what is the clinical evidence of clinical hyperandrogenism? That is, isolated mild hirsutism should not be considered, and moderate to severe hirsutism and acne that is poorly responsive to a dermatologic therapy. And what is the criteria for biochemical hyperandrogenism is elevated total or free testosterone, but there are no clear cutoffs. That's what the guideline says. If you are using an extraction method, then it is more diagnostic because they remove the interfering steroids, and such an assay is not widely available for commercial use. And if you are using an extraction step more than 55, but the same cutoff we still use for the immunoassay. And if they are using a LCMS more than 42 is taken as significant in an adolescent girl. So what are the criteria for oligoanovulation? As I said earlier, if they're more than 2 years, and if the menstrual cycles are happening beyond 45 days, it is considered oligoanovulation. And if the cycles are happening more than 90 days in the first year, then it is significant. If lack of menses by age 15, that is, we call it like primary amenorrhea, or if there is more than 2 to 3 years after the thelarchy, then we have to take it as significant. So what are the criteria for PCOM in an adolescent? There is no established criteria. Ovarian volume more than 12 can be considered, but as I said earlier, this is not included in the diagnostic criteria. You should not take a multifollicular pattern, and moreover, in obese adolescents, the ultrasound appearance may not be, may give inadequate information. AMH should not be taken for the diagnosis, and until better quality, consistent data are available, ovarian imaging can be deferred. Maybe maybe if you are thinking of in terms of an adrenal or ovarian mass lesions, then it may be helpful. So in healthy girls with regular menstrual cycles and without hyperandrogenism, a PCO morphology does not indicate PCOD. So just a PCO appearance in the ultrasound in an adolescent girl does not indicate a PCOD. So what are the diagnostic procedures? So as I said earlier, there are a lot of differential diagnoses for a PCOD, but PCOD is the most common of all. So you should ask for a thorough medical history, physical examination, and order an appropriate test. Most commonly recommended tests are TSH, prolactin, and 17-hydroxyprogesterone. So regarding the insulin resistance is not included in the diagnostic criteria, but if you document insulin resistance, it can be used as a tool to investigate other potential insulin resistance complications. Actually, in Apollo Children's Hospital, we do insulin as a part of the routine obesity package, although initially when I felt that it is something which is expensive, but a lot of women were able to sensitize more, but because that is the only parameter that and the SGPT are the most commonly affected parameters, so they're able to sensitize the parent something strong is already starting in the kid. So does the diagnosis of PCOS during adolescence provide an opportunity for meaningful intervention? Yes. So because you know this has a lot of future complications related to fertility and other complications like diabetes, dyslipidemia, and cardiac problems. And at the same time, you should also remember that overdiagnosis just by irregular menstrual cycles or ultrasound appearance may lead to unnecessary treatment with metformin or oral contraceptive pills. So these are the important history that you need to ask for abdominal symptoms, family history, consanguineous marriage, family history of diabetes for a PCOD, or a family history of any child with CAH, breast discharge for galactorrhea, extent of hair growth, menstrual history and medication history like valproic acid, skin changes, symptoms of virilization like a adolescent girl developing androgenic alopecia, masculinization, weight gain in PCOD, and physical examination, height, weight, and blood pressure, FG scoring, skin changes, galactorrhea, abdominal and pelvic examination for masses, Cushingoid features, and signs of virilization. So this is like a flow chart. So once we know that the child needs evaluation because of hirsutism, and if they have irregular menstrual cycles, you usually get a FSH, usually get a prolactin TSH done to rule out hyperprolactinemia and hypothyroidism. And if the testosterone levels, remember this cutoff 200. If the testosterone levels are more than 200, then it indicates probably some ovarian mass lesion, ovarian tumor, or an adrenal virilizing tumors. If the testosterone levels are more than 200, then we have to get a DHEAS done. If the DHEAS is also elevated, so when the testosterone is also elevated and DHEAS is also elevated, the tumor is from the adrenal. If the DHEAS is not elevated but only the testosterone is more than 200, it is probably a ovarian pathology. And similarly, for the 17-hydroxyprogesterone also, they have mentioned as the nanograms per deciliter. We usually use nanograms per ml for the 17-hydroxyprogesterone. Again, the cutoff is 200. If the value is more than 200, then we and more than 1000 it is clearly a CAH. If it is between 200 to 1000, we have to get a ACTH stimulation test. So any value more than 2, then we have to get a ACTH stimulation testing to exclude or confirm non-classic CAH. So I'm sharing some of the case scenarios which of adolescent girl with hirsutism. This is a typical case, a 15-year-old girl with hair growth for 3 years duration, increasing weight gain for 4 years, a menarche at the age of 11, and after 4 years she still has a menstrual irregularity once in 2 to 3 months, hair loss, there's no striae, myopathy or osmotic symptoms. You can look at the girl, she has actually removed it, but there is mild hair growth over the lips and significant hair growth over the chin. She had a FG score around 8. She was overweight, she was BMI of 27, she was hypertensive, she had acanthosis, and she had no features of Cushingoid, no Cushingoid features. And she was on screening, she was detected to have diabetes with the high insulin levels. HbA1c was 8%. She was clearly diabetic. She had a fatty liver with the bilateral polycystic appearance of ovaries. Testosterone was also clearly elevated, 70. And lipids and SGPT are normal. So this is a straightforward case. This is a typical presentation of an adolescent girl with a polycystic ovarian disease with the insulin resistance, diabetes, and a fatty liver. So compare the case number 1 with the case number 2. This is a 14-year-old girl with a progressive hair growth for the last 1.5 years. Her main complaint was increasing pigmentation of the axilla, elbow, nose, chin, and neck. There's no osmotic symptoms, no change in weight. The previous girl was having an increasing weight gain. This girl did not have any increasing weight. And she did not achieve cycle. She is only 14. We have cutoff is up to 15. So this girl was had a normal BMI of 18. FG score was very high, 30. She had a significant acanthosis nigricans over the nape of neck, axilla, and she can also notice the mild temporal recession of hair, and Tanner stage was B2. So you can see the acanthosis nigricans over the elbow, the axilla, and the extremities. So since she had a significant acanthosis nigricans, we thought of getting a get a OGTT done, because she did not complain had anything to suggest diabetes. We did a OGTT done with the insulin levels also. The insulin levels has come very high. The fasting was 106 and the 2-hour value was undetectable. And the 2-hour value and the HbA1c was suggestive of diabetes. LH-FSH ratio was more than 2. Her testosterone was 1.42. Actually, that is actually 142. I said the cutoff was like 42 or 55 for adolescent age. She had 142 and 17 OHP was normal. So if you take all these features, a girl with diabetes, severe insulin resistance, hyperandrogenism, and significant acanthosis nigricans, the ultrasound showed the polycystic appearance of the ovaries. So this is a case of a hyperandrogenism, insulin resistance, and acanthosis nigricans. That is a type A insulin resistance, Harran syndrome. So this is actually I have included this because I didn't have the face photo. This is actually reared as a girl till 15 years of age, and started developing, presented as a primary amenorrhea, noted immunoscrotal swellings, phallus enlargement, deep masculine voice, and there's no salt pasting. So ultrasound did not show any mullerian structure, and sounding hydroxyprogesterone was normal. So this was actually a XY wrongly reared as a girl because of significant androgen biosynthetic defect. So this may also be included here when we approach a case of adolescent girl with a hirsutism. And so since we are strongly suspecting androgen biosynthetic defect, because now because of puberty the androgens have gone high and she is able to manifest the androgenization. The ratios typically showed a high testosterone by DHT ratio, dihydrotestosterone ratio, so suggesting it's a 5S of 5-alpha reductase deficiency. And there was one more case around a 20-year-old who was actually XX, but presented at 18-year-old as a short stature, but on evaluation found to have a simple virilizing CAH. So these type of extremes of presentation also you can encounter. So this is the last slide. So the most common cause of hirsutism in an adolescent girl is polycystic ovarian syndrome. So total testosterone, free testosterone, and sounding hydroxyprogesterone if moderate to severe hirsutism, and other investigations like FSH, prolactin, TSH are done based on the clinical presentation and suspicion. Oligomenorrhea should be based on the post-menarcheal age, and PCO morphology in adolescent does not indicate PCOD. So thank you all. Thank you for giving this opportunity.
Thank you, Dr. Ramkumar, for enlightening us on hirsutism. And the topic is open for discussion. Any questions from the ground? Floor.
Sir, sir, what is the implication of testosterone level on determining the etiology? Like what level, beyond what level we'll think of tumor, and like.
So that's what I think we can remember two cutoffs. One is 55, another is 200.
Okay.
55 we can say hyperandrogenism.
Okay, sir.
Beyond 200, I think we have to suspect three possibilities. One is virilizing ovarian tumor, virilizing adrenal tumor, and even a congenital untreated long duration of congenital adrenal hyperplasia. All these are possible.
Okay.
So if the value is more than 200, definitely we have to screen for look for DHEAs.
Okay,
then
sir, if that is also normal, if there is no adrenal etiology, if you are suspecting an ovarian tumor, how likely that we will be finding that tumor in an imaging? Like for example, if you do an MRI, because I mean, whatever I've seen a few cases where it was mentioned that the ovarian theca tumors are very small. Sometimes they could be missed on the imaging.
I had come across a case of Tiruchi actually. I
Okay.
think Dr. Vignesh had seen some time back. I think maybe 5-6 years back. That was almost 3-4 endocrinologists already seen. She was 46 when she had first consulted an endocrinologist. I think all the senior endocrinologists they have seen. Everyone suspected as a virilizing tumor. DHEAS was not elevated,
yes.
but none of the imaging modality had shown. And but the testosterone was so high and 17 OHP was normal. So we had no other possibility than, in fact, we even discussed, I was even discussing with a gynecologist, will someone go ahead with a laparoscopy and then for a surgery, because I was so confident that it was a tumor. But I think from Tiruchi, I think Dr. Vignesh had seen and they got operated. It was a very small tumor. Some gynecologist had done an transvaginal ultrasound. I think they picked up.
Yeah, that was a patient who had progressive virilization. See, it was so severe that she said, I've been in house for last 2 years. I have not even gone out of the house. I could not attend any function. It was so severe, progressive, and testosterone was around 250. And it is a tumoral range, and I think she has around 10 ultrasound, 4 MRI reports. So everything is reported as normal. So I just spoke to but it is progressive. It is not at one point multiple, at least 20 reports he had testosterone, all high. So I told, I talked to the radiologist personally. So this is somewhere something is sitting. Please do our imaging, and we did scan everything from neck. Even there are certain reports like lung carcinoma also can secrete testosterone. So we did a imaging of the chest and abdomen, and they found there is a doubtful para-ovarian mass. And I discussed with my gynecologist, took the patient with the hand. She did a transvaginal ultrasound. Sir, she is saying there is one 3 centimeter tumor, and we operated. It came as I think virilizing ovarian tumor. I didn't remember the exact.
I think it's some theca cell tumor.
6 tumor. After surgery, the testosterone went to 36. All the hair shed out, and she had even male pattern baldness also. Clitoris, everything shut down except for the voice. Voice change is permanent, and she's happy now.
And actually, if
Venous sampling in such cases, because I also came across similar case with the testosterone level of 4, it is I think 4 nanogram per ml.
400, yeah.
So we could not find anything on imaging. So what's the role of
Selective venous sampling.
For ovarian and adrenal venous sampling that has been mentioned in the literature, but not done.
see, I have done a adrenal venous sampling for a Conn syndrome in Apollo. Apollo, I have done a inferior petrosal sinus sampling for 2 cases, and that was the first time I did, and it was very successful.
Yes, sir.
But adrenal venous sampling, although we have very good intervention radiologists, that was not helpful for adrenal venous sampling.
Okay.
But I think with the advent of, a lot of interventional radiologists, I think that should be possible.
That's what, sir, I was thinking of,
Because in tumor-induced osteomalacia, we do the sampling of the whole body.
Yes, systemic
so
venous
even
sampling
that we do a systemic. All the veins we take blood for FGF23. So I think for ovarian it should not be a problem.
Okay, one more thing. DHEAS more than 800. They have given a cutoff. More than 800 suspect adrenal mass. DHEAS more than 800. That's a cutoff. Microgram per deciliter.
Sir, I just have a similar scenario. So a post-menopausal female, like 46-year-old, so she has come with hirsutism, and then testosterone was 146 nanogram. So significant hirsutism, alopecia, and other things. And then outside she was already treated and evaluated. MRI pelvis normal, one trans-abdominal USG they are done, and DHEA is normal. everything was worked up. And because nothing was, they could pick up anything, she was given leuprolide. GnRH, leuprolide she was given, and then she had come after 2 months. So now when I repeated a testosterone, it is normal, and the symptoms is remaining the same. So now,
what symptoms?
like the hirsutism and everything.
Hirsutism will take 9 months.
So that's going. It's almost the same. It's not progressing, and the
that is
testosterone level has come down with the GnRH. So now, like we just told to wait and watch over.
There is one condition called stromal Leydig cell hyperplasia. And there is also ovarian hyperthecosis.
Whether that will
they can respond to GnRH agonist. So I think I also had one 64-year-old female. We did since based on the same presentation, testosterone was very much elevated, DHAs and 17-hydroxy progesterone was normal. We strongly thought in terms of ovarian mass lesion. This was a case in Ames. So we did a bilateral laparoscopic oophorectomy, and biochemically it came as stromal Leydig cell hyperplasia. So those conditions, ovarian hyperthecosis, can respond with the GnRH.
Like whether some tumor might have been missed in this, and it's like,
still it is possible. So
just to keep her on follow up and then see.
But I think if the hirsutism is significant, as you see Dr.
significant,
Vignesh going ahead boldly with surgery. So
because then we have also like kept this bilateral oophorectomy.
in Ames also we went ahead with the bilateral oophorectomy, but we are very confident that there is a pathology in the ovary.
In adolescent hirsutism, when we are talking about that, probably doing all these measures may not be applicable here. So even we cannot do a transvaginal sonogram. We can do a MRI, probably a MRI to look for any kind of thing like what you are talking about. We are here with the adolescent hirsutism. So probably a transrectal kind of an ultrasound, whether will it be helpful in patients? So you people only have to tell me.
So I think when we are going to think in terms of viralizing only when the levels
because they will be very small stroma tumor sitting in posteriorly in the ovaries, which you may not be picking up.
But when the biochemical levels are very high,
you cannot go for a oophorectomy. You cannot convince them many times.
Yeah, maybe we can keep them on follow-up. But the last 2 cases I have seen in the adolescent age group with the ovarian tumors are fairly very big.
Very big.
So
if you are big, you are okay. You are happy and you can make a diagnosis. Because you were discussing about the smaller undiagnosed things. I was just applying it to the adolescent.
Okay, for postmenopausal women, okay. But for younger age group, we have to keep them on follow-up.
I think that a discussion.
And my professor, Dr. Amini, used to try with, like the way you tried with GnRH agonist, my professor Amini used to try with Dexa. She used to give dexamethasone for 2 consecutive days, like the same Liddell's protocol used for Cushing syndrome. And then she will measure the testosterone levels. She will measure the testosterone levels, whether it has come down. If the testosterone levels drops, it is an adrenal pathology. If the testosterone does not drop, it is an ovarian pathology.
Probably that dexamethasone.
These were the investigations used earlier when the DHAS is not widely available. Other investigations. Now we have all the investigations available. We even have the venous sampling, so it should be.
No, even after all these things, we have a small set of patients who still.
We have to keep them on follow-up.
We have to keep them on follow-up. Thank you. Thank you very much for the discussion. And with that, we are coming to the end of the scientific program. And thank you, Dr. Vijay Bhaskar Reddy, for organizing such an excellent program.
So now we are moving on to the valedictory function, and before that we have prize awarding ceremony for poster presentations.
Thank you all for the wonderful participation in Trendo. I think the response has been overwhelming from all the, mostly I think it's the postgraduate students from all the nearby colleges. I think they're very enthusiastic, and we had invited abstracts also, and we had 24 abstracts. I think it is very good for a pediatric endocrine meeting. So I think, so it's very good response from all the PGs. I think they're very enthusiastic, and we're happy to share the prize presentations for the posters. So Scientific Secretary Dr. Jayaprakash Sahu will announce the results. So we have 6 prizes out of 24. So 1 first prize, 2 second prize and 3 third prizes. We have cash award 10,000, 5,000 and 3,000. So I request Dr. Ravichandran sir, he is president of IAP Puducherry chapter, to give away the prizes. Our scientific secretary Dr. Jayaprakash Sahu will announce the results. If anyone, if the presenter is there, please come and collect. Otherwise, from their college, anyone can come and collect.
So we have total 6 prizes. 1 first prize, 2 second prize, and 3 third prize. So first prize goes to Dr. Jayavardhan from JIPMER for the poster Therapeutic Response to Bisphosphonates in Osteogenesis Imperfecta, a JIPMER experience. So we have 2 second prizes. So one of the second prize goes to Dr. Anand S from SRMC Chennai for the poster A Case Series of Adrenal Insufficiency in Pediatric Age Group. Another second prize goes to Dr. Barun Suryadevan from JIPMER for the poster Etiological Profile of Precocious Puberty. We have 3 third prize. One of the third prize goes to Dr. Komal Sanjay Jog from Madurai Medical College for the project Neonatal Hyperinsulinemic Hypoglycemia, a short case series. Another third prize goes to Dr. Kanchana Devi from JIPMER for the poster 3 cases of neonatal diabetes with various genetic mutations. The last third prize goes to Dr. Aravind Prasad from JIPMER for the poster McCune-Albright syndrome, a case series. Thank you, sir.
We move on to the vote of thanks. As organizing secretary, I would like to thank Endocrine Society of Tamil Nadu and Puducherry for giving Puducherry the opportunity to conduct the 2nd annual Pediatric Endocrine Conference of the Society. I think from now we'll have this on a regular basis, Trendo. The place may change, but it will be organized by the Endocrine Society of Tamil Nadu and Puducherry. I thank our patrons, especially Dr. Murthy sir, Dr. P.G. Sundaraman sir and Dr. Venkatraman sir, who started this tradition from before. They used to conduct a pediatric endocrine conference every year, and we have taken over, the society has taken over the tradition, and we will conduct this pediatric endocrine meeting yearly once. And I thank all the Endocrine Society of Tamil Nadu and Puducherry members who offered constant support for us, Puducherry team, to conduct this meeting. President Dr. Kumaravel and all the society members and executive members provided ample support. As part of the organizing team from Puducherry, I express my thanks because it's a team effort, it's not a single person's effort. And my colleagues, Dr. Jay Prakash Sahu from JIPMER, Dr. Dukobando Nayak, HOD JIPMER, as Finance Secretary, Dr. Jay Prakash Sahu as Scientific Secretary, and Dr. Satish Kumar, Additional Professor JIPMER, and as Joint Organizing Secretary, and Vel Murugan for helping me out through this whole meeting. And this time we did it in association with the Indian Academy of Pediatrics, and Dr. Ravichandra sir is there. I think it was a combined effort, and we had a immense contribution from the Indian Academy of Pediatrics, and it is a collaborative effort. So that's why we put both our society logos in this. Dr. Ravichandra sir was always very encouraging, and he had a lot of suggestions, and we took up all the suggestions. And we also had good inputs from the Indian Academy of Pediatrics Puducherry chapter from Dr. Tirumurugan Seran, Dr. Shanmuganathan, the past president, and Dr. Johnson Reddy, and Dr. Abhijit Srivastav, and all the IAP members. I know them personally. So thank you, Indian Academy of Pediatrics Puducherry chapter, for giving us the opportunity to collaborate this time. And I thank all the delegates who come from far off, I think from nearly Chidambaram. I think we had from Krishnagiri also some delegates have come, then from Chengalpet and Vilupuram, Kadalur, so from Andhra Pradesh also. So I think it was a very overwhelming response. I thank all the delegates and especially the postgraduates who have come out with a lot of enthusiasm. I hope it was a useful session. From our side, we tried to keep the academics up in front. We tried to minimize the time gaps and try to keep the meeting on schedule. I think the quiz also was well received. We were a bit skeptical about the quiz, but I think the participation from the PGs on the quiz was very good. I thank Dr. Vel Murugan. I think he was the mind behind the quiz. I hope you enjoyed the quiz. So every 1 hour we thought we'll have 10-minute sessions so that we break the monotony of the sessions. And I thank our audiovisual team, Michael Karthik. I think they did a very good job, and we had live streaming also, and it's available in the website. If you go to the website, a live stream option is there. It will be on YouTube. You can go back and attend any sessions also. If you can just click the link, it will take you to the link. I thank the audiovisual team. I think they organized the posters and everything. I thank Galaxy Enterprises, Mr. Dilip, for having supported us with kit bags. I'm sure you would have had a look at the kit bags. They're of very good quality. I hope you use them. And he provided us all the support with ID badges and certificates and mementos. I think he did a very good job. And we gave a lot of importance to the no slide. So we gave a lot of importance to the designing of the brochure and the first page. So I told the designing person we want Pondicherry and children. So you make something like that. So we got some idea, and we got it designed from Trichy. My friend Dr. Shaktivel suggested his designer, and that's how we got some children playing. And Puducherry, lot of areas we have covered, we have come before. So this is I Mandapam, the Auroville, Mahatma Gandhi statue, and that side you can see the beach and the pyre. So we tried to cover a lot of areas as much as possible. So we thought of all these aspects also. I thank Hotel Accord for having given us all the support, and they, I'm sure the hall was arranged very well, and the crowd was very good, and I hope the food also was good. And I thank none of these meetings are not possible without the support of the pharmaceutical companies. Thank all the pharmaceutical companies for coming out magnanimously to support us, without the support of which we cannot have this type of meetings. So I thank one and all. I hope I have not forgotten anyone. So it's not by if I've forgotten anyone, I would like to thank them also for this. I think the photographers, audiovisual team, everyone. I thank all the medical colleges and their professors and students who came out in big numbers. I think Ramanathan sir has come all the way from Chidambaram. I thank one and all. So I would just like to invite our patron, Dr. Murthy sir, to give a couple of words and then we'll close the session.
A big thank you to the whole team. And when I mean the whole team, it is not only the doctors, all of you, and I'm sure the family members have also sacrificed a lot. I think they have not seen you at least for the past 1 month because you've been going through. On behalf of all our colleagues and all who attended, we'd like to thank you all profusely because the warm hospitality, the affection with which you received, the hotel, the rooms have been exceptional, food, and the scientific sessions of the highest quality degree. You had a whole lot of speakers, chairpersons, excellently done, and thank you also for having put it on the YouTube. I've been watching for some time and I went up. It's of the highest quality and this material will be very useful for people to them. And once more on behalf of the Trendo and all the group, thank you, a big thank you to all of you, the team. You've been all exceptional and it's been a huge successful program. We enjoyed being here and all the very best, and we look forward to coming to Puducherry in future for many more conferences like this. Thank you so much.